Hello, dear guests, attendees, our respected speakers and chairs, and welcome to our virtual summit dedicated to head and neck cancers. It is with great pleasure that I welcome everyone to this important event as we're closing out the Head and Neck Cancer Awareness Month. We are holding How I Treat Head and Neck Cancers in 2026 in order to address several gaps that exist in this heterogeneous group of cancers and their treatment. Despite recent advances in immunotherapy, precision oncology, and radiotherapeutic and surgical advances, there is a gap between emerging evidence with real world practice. And there are really great challenges that oncologists from around the world are facing regarding these cancers. So we are bringing together global leaders in treating these cancers, global experts of head and neck cancers, to share their experience and practical tips that can maybe help you improve your practice, your everyday practice, and implement experience-based strategies in your everyday practice. I'm happy to welcome and briefly introduce our chairs for today's summit. Dr. Nagashri Ramu, Director of Thoracic and Head and Neck Medical Oncology at Northwell Health and Associate Professor of Medicine at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Dr. Melvin Chua, Head of Department and Senior Consultant for Head and Neck and Thoracic Cancers in the Division of Radiation Oncology at the National Cancer Center of Singapore. And Dr. Amanda Psiri, Professor of Medical Oncology and Chair of Medicine at Attica University Hospital, National Kapodistrian University of Athens, the largest clinical department in Greece. Thank you to everyone for dedicating their time to join today. And without further ado, I want to pass the stage to Dr. Melvin Chua, who's going to give welcome remarks and start the first session. Thank you.
Can everyone see me? I presume people see me. Can you hear me?
We can hear you.
Perfect. Well, thank you. Let me try to share my screen. Okay. This is the first time trying this, so okay, share entire screen. Okay, can you all see me? Can you see this? What I'm sharing?
Yes.
Okay, so because I can't see anything now apart from just my slides, so let's hope this works. Well, welcome to everyone wherever you're dialing in from to attend this sort of Head and Neck virtual summit. I mean, first of all, before I begin, I'd like to congratulate and really thank the OncoDaily team, so for pulling this all together. Really, I think it's great work to bring experts from around the world to just speak for a marathon session on head and neck cancer. So I mean, I don't know how many people are online, but I hope you'll find the contents throughout the day informative. And so I'll kick off with some opening remarks. And I think for all of us who treat head and neck cancers, we agree that it remains a very heterogeneous condition. The biology differs by anatomic sites. We hear this again and again when it comes to clinical trials that were conducted, and we always, I mean, as physicians, we know that an oral cavity head and neck cancer is different from a P16 positive oral pharynx, is different from a P16 negative base of tongue, and obviously, and so forth. And so the biology clearly differs by anatomic sites. And despite all these years of molecular profiling and so forth, while our understanding has improved as a whole, I think there's still a long way to go in terms of really trying to decipher the biology and what it means in terms of treatment. And so I think, while we continue to make progress, I think generally we all agree that the field is moving towards individualized treatment approaches, right? We know that, for example, oral cavity cancers are best treated by surgery. And then, of course, with this whole field, this whole thinking about perioperative treatment, immunotherapy, using it before or after, um, it sort of bring us another step beyond just, single modality surgery or radiation as the first line treatment. And so I think the treatment differs by site, but it's also evolving with new therapeutics that we're seeing. But I think fundamentally, it doesn't really quite matter, whether we use combination therapies or, combining immunotherapy with radiation, immunotherapy with surgery, or, with radiation. But I think one of the pivotal cornerstone of managing head and neck cancer is the need for a multidisciplinary approach. We can all agree that it is in this cancer where, really, I think it's a whole sort of village being involved, from the surgeons to the radiation oncologists to the medical oncologists, and including the rehab physicians, and the supportive care dietitian, that all come together. And I think only with that, can we ensure good outcomes for patients. And so, before I begin my lecture, I would like to mention that there's some, to sort of give credit to the key progress and milestones we have made in 2025. I know we are already in Q1 of 2026, but it was really in 2025 where we finally saw number of positive trials, um, finally in positive phase 3 trials in the localized setting, right? And from these trials, we acknowledged that really, I think anti-PD-1 antibody, I think pembrolizumab, nivolumab, or PD-1 inhibitors as a whole, have been the game changer in head and neck cancers. With the initial Keynote 4048, that kickstarted the whole cascade of use of immunotherapy in head and neck cancer. And I think in a way is a game changer to us, because for the first time we have seen long-term survivors, even among patients who had resistant locally recurrent cancers or recurrent metastatic disease. And to me, the progress that have been made by the two trials have really been the case that, we now have a new strategy that may confer a disease control advantage, and we wait to see long-term overall survival advantage. But for far too long, we have taken a beating in terms of making progress in locally advanced head and neck squamous cell carcinoma. I think these two trials have certainly changed the sentiment of the community. Now, of course, in the recurrent metastatic space, there's this whole emergence of anti-EGFR means becoming in vogue again, with the ADCs. And, we've seen all the trials that were presented at ESMO last year in Berlin, with the EGFR TGF beta bispecific, and also the new avimentinib from J&J. I think these are compounds that have shown promise, and I think they may represent the next frontier in terms of combination therapeutics in the recurrent metastatic space. And hopefully at some point it will make its way into the locally advanced space. And then finally, a topic that's very close to my heart, and I put them as one massive domain, which is the virally associated head and neck squamous cell head and neck cancers. And that includes EBV positive nasopharynx cancer as well as HPV positive oropharynx cancers. And we're seeing, well, they're different disease ultimately. We're seeing a lot of convergence in terms of how we apply treatment concepts using liquid biopsies to individualized treatment or adapt treatment, and I'll share that in my talk later. And I think this is a space where we recognize as patients, there are some patients who harbor a favorable prognosis, and therefore they could be subjected to treatment de-intensification, whereas there still remains a subset of patients where they have aggressive disease, and we should be working to identify them and to think about escalating therapy for them. Of course, immunotherapy remains one of an area of interest, even for EBV positive nasopharynx cancers. So with that background, I will jump straight to my talk. And that sets the opening salvo and probably the setting for the webinar today, where you hear across all the different disciplines, across faculties around the world, where they'll share about their thoughts on what are the new things in hair and neck cancers. And so for my lecture, I'll kick off by sharing with the audience what I think are the changing paradigm in the treatment of nasopharyngeal carcinoma, which is a disease that's endemic in my part of the world. And these are my key takeaway points for my lecture. I want to cover. I don't have time to cover the whole breadth of all the changes in nasopharynx cancer, but I would like to speak about two key things that I feel are potential game changers. And the first is actually the use of plasma EBV DNA as a liquid biopsy in nasopharynx cancer. And I know that there's a lot of interest to adopt the same concept in HPV positive oropharynx, but I think for the first time this year, we now have good data to suggest that EBV DNA is not just useful as a tool at baseline to select patients for more intensive treatment, but rather it can be used while on treatment to adapt and individualize treatment for patients. And then finally, I'll sort of pivot to my um, my sentiment on the use of proton beam therapy as a precise treatment, potentially to mitigate acute toxicities in nasopharynx cancers. And we've seen, in the HPV oropharynx space, two contrasting trials, the Torpedo trial and the US trial, showing different results, but you know really the details are in the weeds. But I'm happy to share some of our experience, at least in the nasopharynx space, where we have been increasingly using proton beam therapy to treat nasopharynx cancer patients in Singapore. So I think I point all the juniors to these two guidelines. These were two resources that I've put up. And the first is actually the Cisco ESCO guideline, a joint guideline that was published in 2021 by a global group of experts. And this guideline is in a process of being updated this year, and we hope that the updated guideline can come out by Q3 or Q4 this year. And the other one is actually a resource that I sort of put together with Professors Matt Lechner and Bridget Ma, that was published in the the updated DeVita textbook of oncology. And in that, we wanted to put together, we were asked to propose a pathway in terms of how we think treatment for non-metastatic NPC should be. And back in the days, about 3 years ago, when we were putting together this pathway, we wanted to reflect both just a, typical treatment based on stage, but go a step further to say, hey, in fact, we know that within each stage group, and this is using TNM8, that patients are highly clinically heterogeneous. And there are markers out there to help us think through who represents a unfavorable versus favorable subset of patients in each of this stage group, and from there we can potentially individualize treatment. So for example, if it's localized early stage, in the absence of aggressive features like high EBV DNA titers and so forth, even for those unilateral node positive early stage early T status patients, then they may just require radiotherapy alone, and if they harbor high risk features, then they will get concurrent chemoradiation. Now, likewise, while majority of patients present with locally advanced disease, and this is where you see a diaspora of patients where they could be massively infiltrative locally, uh, in the absence of nodal metastasis, relative to, in contrast to patients where they may be small tumors but bulky nodal metastasis, then really the treatment can differ, whereby some of these node negative patients could just receive chemoradiation up front, whereas if they have no positive disease and a bulky tumor, then depending on whether there are aggressive features, a high EBV DNA titer, then often we find that the preferred first line approach these days is actually induction chemotherapy followed by chemoradiotherapy. So it's not a one size fit all, where based on the tumor size, the tumor stage, along with prognostic factors, we can then fine tune the which pathway the patient should go through, and then potentially sparing patients from the need to get more treatment or longer treatment. Now, what about the recurrent metastatic space? Now, this was again conceptualized in the pre-IO era. So, because mind you that this was put together 3 years ago when we're just beginning to see the early results of the phase 3 trials comparing chemo PD-1 inhibitors versus chemotherapy alone. And here we divide them into two segments. Now, while majority of patients are either de novo metastatic or recurrent metastatic in this space, because we know that high risk locally advanced patients, some of them do recur often with distant metastasis. Still, a fair number of patients still recur with local regional disease after radiation or chemoradiation, despite this being a radiation sensitive tumor. Now, briefly, if it's recurrent metastatic, then of course, it's still systemic therapy as a backbone. These days, if they are de novo metastatic, we now have data suggesting that local regional treatment could potentially advance survival, both DFS, PFS, and OS. Now, of course, the trial was done in the pre-IO era. So, but of course, we still need evidence to see whether local regional radiotherapy still confer the advantage in patients treated with combination chemo and PD-1 inhibitors. Now, we have made the first step to recognize oligometastasis as a different prognostic group in MPC, and so therefore, as reflected in the new TNM staging, oligometastasis is now subclassified into M1A or stage 4A, compared in contrast to polymetastatic disease, which is stage 4B. And so in this group of patients, we know that they do better, they survive longer, and one could consider metastasis therapy. And if it's local regional disease, then it is about the decision is made between whether is it resectable or not resectable. I think if it's not resectable, then one has to then think about what is the risk of re-radiation. And one of the first work I put forth 8 years ago was this model that could be used to stratify patients between those who are low risk. It means low risk primarily that they could undergo re-radiation safely, that the likelihood of suffering from treatment mortality is much lower compared to high risk patients, where then about 50% of them can succumb or demise due to re-radiation toxicity. And for these patients, perhaps they're better served by being assigned to systemic therapy as opposed to local treatment. So I think this was the pathway that we put forth for the recurrent metastatic disease, and I think it's still relevant today, even in the era of chemo IO, because it kind of provides a framework for how we think about the clinical heterogeneity of patients in this subgroup. So briefly, we know that we have updated the TNM criteria to TNM 9 that was implemented in January 2025, and primarily we seek to clarify the T classification, provided clarification how T staging should be annotated. We included extranodal extension first time as a adverse prognostic factor for nodal classification, and then as I said, we split metastatic disease into oligo versus poly, and then with all these changes, we essentially assign groups 1 to 3 to non-metastatic disease, and stage 4 primarily being reserved for patients with metastasis. So I think the way I see it is this is again a monumental move, because this then sets the scene for future iterations of 10 and 10, 11, where we can then think about how do we subdivide each of these stage groupings into more refined groupings to reflect the clinical phenotype and behavior of the patients. So with that, I'll move into my talk proper, where I'll also share two ideas as I said. The first is on liquid biopsy to stratify and individualize treatment, and then the second will be on proton beam therapy. So we know that EBV DNA is an archetypal sort of biomarker for nasopharynx cancer. Now, in our part of the world, and perhaps even in the non-endemic region where NPC is much less common, most of the cancers or NPCs are associated with prior Epstein-Barr virus infection. And what that means is that this virus kind of exists in an episomal form as a circular DNA. And and when the tumor lies, then it releases these fragments into the circulating blood, which then using a simple PCR assay, we can measure or quantify, both qualify and quantify the presence of absence as well as the titer of the viral load, which is meant to be a surrogate for the tumor burden. So with that, it then allows us to have a tool beyond TNM stage, beyond tumor burden, to be able to stratify patients across, the entire timeline of the journey from pre-treatment, that means deciding whether this is low risk, high risk, again, as I mentioned earlier, to measuring on treatment response, where then, you don't just get information from a single snapshot, but on treatment information where you have multiple data points to then allow you to fine tune your phenotypes better and adapt treatment real time. To then, of course, in the post treatment space, first identifying who still harbored minimal residual disease versus those who did not have any minimal residual disease, where you think that these patients, you know, may not require adjuvant intensification. Now, for that, I need to again point to we're all eagerly awaiting the results of the NRG HN001 study led by my dear colleague, Professor Nancy Lee from MSKCC, where this is a large phase 3 trial randomizing patients with no detectable EBV DNA at the end of chemoradiation to either adjuvant intensification or could these patients be observed alone. Now, of course, just briefly, these patients could also be, that this tool could also be used to survey for disease recurrence in the post-treatment setting. But point being that, because of the prior work over 20 years of developing a robust biomarker in the form of a plasma EBV DNA test, we now have this very powerful tool to apply across, different time points over the patient's journey. And one of the first things in terms of baseline I wanted to share is that, it's often been argued that we don't have a good cutoff to decide, what are low versus high risk. And this is data from our center. Again, sort of is led by, I want to give kudos to Ms. Niu Jialing, one of my research staff, where she basically pulled data from our local cohort and then tested for random sensitivity analysis if whether we cut off by 2,000 versus 4,000, it made a difference in terms of stratification. Now, as you can see here, really in terms of prediction of 3-year disease-free survival rate, they're largely comparable. Now, mainly the main difference here is that, of course, if you use a lower cutoff, then the proportion of patients that you segment in either group will change. But then that becomes a practical decision. Ultimately, it's about the proportion of patients that you want to, subject to treatment intensification, or the group of patients where you feel that want to use a less intensive treatment. But regardless of what cutoff you use, I think this data is meant to provide confidence that it is a very robust biomarker, whereby, of course, the hazard ratio should still be stable, but whether we use a lower versus a higher cutoff just speaks to the proportion of patients we want to enrich in either subgroup. And we've seen that this could be used to individualize treatment or to de-intensify treatment based on large phase 3 trials that were done in China. These are two studies that I point you to. One is a phase 2 trial where if you have low EBV DNA titer defined by less than 4,000, then whether you could just use 2 versus 3 cycles of concurrent chemotherapy essentially doesn't lead to any inferiority or differences in outcome. And the other study led by Professor Jun Ma's team and Professor Tang Linglong's team, where they looked at omission of concurrent chemotherapy in low-risk TNM8 stage 2 T3 N0 patients. And in the low-risk patients, then maybe IMRT alone would suffice as opposed to chemoradiation. Now, what is perhaps also relevant is that with the the large or the pervasive use of induction chemotherapy. Again, this is an exploratory analysis of the Zhang Yuan study that was published in New England Journal 2019. And then this is the updated analysis showing that perhaps it's only in the high EBV DNA copy number patients at baseline where they benefit from induction chemotherapy, whereas for the N23 or T34 N positive patients, if the EBV DNA titers are low, then they may not require induction chemotherapy. But the point is that while this is an exploratory analysis, it hints to us that baseline EBV DNA titer could be used to kind of decide the intensity of treatment from the outset. But this is really where things are exciting. I think this is, again, one of the early works of ours in collaboration with the investigators from Guangzhou, where we look at EBV DNA clearance after every point of treatment for a patient that's going through induction chemotherapy and chemoradiation. So what we found was that about 30% of patients, after giving one cycle of induction chemotherapy, the EBV DNA clears completely. So we call them early responders. Of course, we recognize that there are a lot of patients where the EBV DNA persists at the end of chemoradiation. But the point is that, as the treatment goes on, the dynamics of EBV DNA will change. And we've also seen early bounces and delayed bounces. So the point is that all these phenotypic patterns speaks to the likelihood of disease-free survival. So I show you here all the EBV DNA status, whether this is positive or negative at every juncture of treatment, and then during treatment, at the end of chemoradiation. And from these patterns, eight different patterns, we can divide them into 4 distinct clusters. So this are largely the patients I said earlier. They are the early responders where you see complete clearance very early on. And then this is a group whereby they don't clear so quickly after one cycle, but they still clear fairly quickly at the end of induction chemotherapy. And you can see that even between these two groups, there's a difference for disease control, but they certainly do better than the late responders where they only clear at the end of chemoradiation. So here. And then we have this group here where they are patients where they bounce during radiation, or they don't clear at the end of chemoradiation, or they're just persistent throughout. And we acknowledge that this is the worst group of patients. So you have these 4 distinct groups. What could you do with them? And so a few years ago, we came together to put forth this EPSTAR study, where briefly, if you are an early responder, then you go on standard treatment. If you are the intermediate responder, which means that you don't clear after one cycle, but you clear, quite soon after, we acknowledge that, perhaps this speaks to a biology where the tumor burden is high. And so this patient should get 6 months of metronomic capecitabine. And if this, persistent at the end of induction chemotherapy and, throughout, then this group of patients here should receive, intensification much earlier on in the form of PD-1 inhibition. And here we decided to combine it much earlier during concurrent, and then they continue for maintenance phase after for 6 months. So it is meant to reflect increasing level or degree of intensification. Now, the trial was published this year, in fact, a month ago, 6 weeks ago, in Nature, and we were very pleased that it received, substantial optics. And in fact, I would like to thank OncoDaily for, enhancing the publicity associated with this trial. And quickly, this is the trial design, as I mentioned: low risk, intermediate risk, which are your, intermediate responders, and then your high risk patients, where these are the group of patients who receive, concurrent and adjuvant PD-1 inhibition. This is the trial schema. So it's a 144 patient trial, of which about a third were, or lower than a third, were classified as low risk. So again, we know that this group of patients are not, they are about 30%. And then for the remaining, about half were intermediate and high risk. And note that all these patients receive induction chemotherapy upfront. And so the key result was that by simply acting on inflammation during the induction chemotherapy phase, we're able to show that we know historically the high-risk patients do poorer than the intermediate-risk patients, who do poorer than the low-risk patients. But by just adapting treatment, we essentially bring up the disease control rate comparable to the low risk patients. In fact, one could even argue that the intermediate risk patients did better than the low risk patients. So I think this is extremely encouraging. And I think as a whole, because of the adaptation, the patients as a group did better compared to the historical benchmark. So there was a 12% improvement overall for 2-year disease failure-free survival. And this slide, this Kaplan-Meier curve speaks to the point where we had a contemporary cohort where they were treated based on standard protocols. Treatment was not adapted. In contrast to the adapted therapy group, which is the blue line here, you see this improvement in 2-year failure-free survival of 10% at 2 years, and it persists and even widened to 15% at 3 years. So I think this is a exciting approach, and I can only see this, gathering steam and becoming a cornerstone in how we think about treating NPC in practice. And it's not just confined to just NPC alone, but I can see several of this concept being applied in the HPV positive oral pharyngeal squamous cell carcinoma space, where we're seeing a whole suite of liquid biopsy tests being put out there in the market to be again used in the same sort of clinical scenarios as I shared earlier, as what we would do for EBV positive NPC. So for the next few minutes of my talk, for the last part, I would like to just share briefly on our experience with how proton beam therapy could potentially be the other game changer in NPC. Now we've seen, substantial evolution in the delivery of real therapy, mainly in head and neck cancers. From the 2D era to the 3D era, where we then have to think about delineation, to the IMRT era, now we can shape treatment dosimetry and then reduce, improve dosimetry to the tumor targets, and then reducing dosimetry to the organs at risk. Now, but there still remains a limitation of IMRT. I think first thing is that the dose gradients near sensitive organs at risk, like the brainstem optic nerves, especially for T4 disease, where we know that given the proximity of the nasopharynx to the base of skull to the intracranium, the tumors can often infiltrate through the foramens, through the soft bones of the base of skull to affect these adjacent organs. And when they do, it then makes planning challenging. So we still need, to enhance our technique to really, I think, maximize dose delivery to the tumor, and then really preserving the normal structures. You're not having to sort of take compromise here and there. Now, still, like I said, acute toxicities remain debilitating. We still have patients who suffer from dysgeusia, xerostomia, dysphagia. And often, if you think about, in our experience, when we think about IMRT treatment, often we still struggle trying to meet those constraints to the constrictor muscles, to the skin, to the taste buds, and salivary glands. And that's why patients still, while they are much more improved compared to the early days where you see patients with, a large portion of patients with NG tube feeding, these days that is far and few between, but nonetheless, the treatment is still tough in the sense that, patients do suffer from loss of taste, dry mouth, which affects the quality of life. So quickly, this is one of the earliest experience from the MSKCC group, again led by Professor Nancy Lee, 77 patients. And the point is that they found, as I alluded to, that IMPT could lead to reduction of acute toxicities compared to IMRT. And this is, remains with multivariable adjustment. But interestingly, this is again, highly speculative, but they saw that patients treated with IMPT, even though they're matched for stage and all the other parameters, have a much lower, almost like basically no local regional failures compared to the IMRT cohort. So of course, this requires validation, but highly provocative. Now, this is our initial NCCS experience. Of 80 patients, majority were treated with induction chemotherapy followed by chemoradiation. And what I can show you here are the early benefits of IMPT versus IMRT. So to bring you through, this is the frequency histogram of the proportion of patients who suffer from these toxicities over the course of treatment. And here they're mostly grade 2 and above, dysgeusia, pharyngeal pain, dermatitis, xerostomia, and the red lines are the proton treated patients. The blue lines are the IMRT treated patients. And you can see that clearly there's a benefit of protons versus photons for preservation of taste, dry mouth, but on a trade-off is that you get a much higher risk or incidence of skin toxicities, which we know is the intrinsic behavior of proton. But to translate this to dosimetry, I think it's because we're not able to achieve very, very low D-mean doses to the product gland, to the oral cavity, the superior constrictor muscles, which we are unable to achieve with IMRT, even with the best IMRT plan. I think this has led to the early clinical benefits that we are seeing now in our patients. These are some examples. I treat patients with sequential treatment, and so we do phase 1, phase 2 technique. And typically we use a 5-beam technique where you have 2 for the front, 2 for the back, and 1 anterior beam for the lower neck. And so this is the reason why we're able to achieve very low dosimetry to the parotid glands, where you really spare the bilateral parotid gland. But some of the caveats, I think beam design is extremely important for proton beam therapy. Because you're essentially splitting the volume into multiple targets. So I think there's a learning curve there. And I think the setup is extremely crucial to deliver high quality proton beam treatment. So this is an example of a patient where you see this change between simulation and on the first day of treatment due to the setup, due to the variation in setup. So we put a lot of emphasis on that. And as I said earlier, this skin toxicities were substantially increased with protons versus photons. This is an example of a patient treated with proton where we use 50 gray 30 fraction, 1.6 group per fraction, and despite such a low, highly attenuated treatment regimen, we still see quite pronounced skin reaction, which you would not expect otherwise with photon treatment. So other caveats, I think accuracy is very much dependent on the range certainty. And we know that range uncertainty is a perennial issue with proton beam therapy because of change in anatomy, loss of weight. So I think it again speaks to the importance of ensuring good, robust daily setup. So final points, I think between the two modalities, at least for MPC, we're seeing superior dosimetry for salivary glands, for the oral cavity, for the constrictor muscles, and also to the lungs, where we're really able to reduce doses to the lung, even low doses to the lung. That may spare, apical lung scarring, especially we're thinking in terms of combining, treatment with chemotherapy and perhaps in the future, immunotherapy. We do see worse rheotherapy dermatitis with proton beam therapy, but the main thing is the devil's in the details. I think when you do proton beam treatment, one has to be very pedantic on the daily QA. So again, to go back to my key takeaway points, I hope I've shared with all a whole sort of a dimension of how precision oncology could be advanced in nasopharynx cancer, the success we have achieved in the form of EBV DNA for stratification and also on treatment adaptation, and how I feel proton therapy may have a place to stay, particularly in MPC, and may make treatment a bit more bearable for patients. And with that, thank you so much.
Thank you very much. Thank you, Dr. Chua. Thank you very much for your insightful presentation. It was very interesting. And now we continue with our next speaker, who is Dr. Nancy Lee, a radiation oncologist and early drug development specialist from Memorial Sloan Kettering Cancer Center. And she will be sharing with us head and neck cancer updates. Dr. Lee, the floor is yours.
Hello, everyone. It's OncoDaily Virtual Summit, how I treated head and neck cancers in 26. And let me introduce Dr. Nancy Lee, who is Chief of Head and Neck Radiation Oncology Service at Memorial Sloan Kettering Cancer Center. And please, Dr. Nancy Lee.
Hey, thank you so much for having me. this morning. Sorry I cannot be there. I think it's the end of April. I have a competing meeting, but I'm hoping in the next 25 minutes or so, give you an update on head and neck cancer. These are my disclosures. Now, the outline will be on first, I think the most exciting thing that happened in our field is the neoadjuvant therapy. So I'm going to look at Keynote 689 mainly, a little bit about Nivo post-op. And then I'm going to update everyone about nasopharyngeal cancer and plasma EBV DNA. Then I'm going to talk a little bit about proton therapy and the controversies around that. And lastly, I really want to talk about what's my passion, which is de-escalation for HPV or pharyngeal cancer and EBV positive nasopharyngeal cancer. Now, to start with resectable head and neck cancer, these are patients that typically we see the surgeon first. Now, what is the paradigm shift? Well, we all know about this very important trial and by Ravi Upalari that was published in New England Journal last year. And the reason this is exciting is that for the first 20 years now, I think since Jim Bonner's cetuximab trial, we have not had a single trial that's positive. They're all negative in head and neck cancer. And this is the first phase 3 trial that's positive. And what the idea is, you take patients that are resectable, whether it's your oral cavity, oropharynx, larynx, or hypopharynx, and here are the criteria right here. They're mainly HPV negative. It can be HPV positive, but it has to be the very bad stage 3 patients. And of course, you want to have PD-L1 staining. And the idea is either they go for standard care, which is surgery, followed by post-op radiation with high-risk features. You will get chemotherapy, that's very standard. Or we're talking about adding 2 cycles of pembrolizumab, then followed by surgery. And you can see the primary endpoint is event-free survival. And what I wanted to bring your attention is really there's the low risk group and the high risk group. So what pembrolizumab did is, if you look at the balance here, is that the dose with low risk, meaning you don't have any high risk feature, is only 60 gray. And there were more patients in the pembrolizumab with the low risk features here. And then if you go to the high risk features, you can see more standard of care patients, 132 versus 94, were with the high risk feature, meaning after surgery you have positive margin E and E. And of course, those patients we give 66 grades. So we have ourselves a 6 grade difference, meaning more people converted to a low risk category after the addition of pembrolizumab. And you can see the event-free survival is almost 60% versus 46% in favor of the experimental arm. And what's exciting about that is here, we know that the primary curve separates, but when you look at the low risk group, it also separates. And then you can also see the high risk group. It continue to show favor of the experimental arm. So the idea here is that instead of going straight to surgery, I would advise you to get together with your colleagues, your surgeon, the radiologist, the meta, together in a multidisciplinary fashion, and then determine this pathway. It's a lot of coordination. It's not for every patient, because if some patient needs to have the tumor taken out, you really don't have time. So this is the standard care. And then there are a lot of ongoing trial now looking at patients that perhaps will come. Oh, sorry, if you see, combine chemotherapy with immunotherapy prior to surgery. This is a lot of ongoing trial on that. And I think this will be the future, because what chemotherapy can do is actually symptomatically relieve your patient's mass in the oral cavity typically, or it will improve your response rate. So this is a neoadjuvant paradigm that has changed the standard care. Of course, there is this study, the Nevo post-op, that was also published at the Lancet earlier this year, and you can see the same inclusion criteria, basically high risk for recurrence, and of course, patients that have HPV positive tumor, you're allowed to be in if you're pathologic T3 or T4, and you have more than 20-year tobacco history. And then the issue about this trial, in my mind, is that it's got so many other features that we're, at least in the US, we would not consider high-risk feature. For example, you can have a 4 or more positive lymph nodes without extracapsular extension. That, in our books, we would not consider giving chemotherapy if there's no ECE. So this is a trial here. And of course, the primary endpoint is positive. But I want to call your attention. It's written in the paper and in the supplement that when they underwent a blinded independent central review, what it means is that we will have an independent group that assess the response. And it turned out to be a negative study. So it really begs the question, is this practice changing? At least in the United States, it's not yet practice changing. Of course, when we have a patient with multiple bad features, we are tempted to consider the Nevo post-op trial. So, but I want to bring these two trials to you because that's a change in paradigm for surgical patients. Now, nasopharyngeal cancer, of course, we know that since the New England Journal paper by Sanyat Sin, we know that the standard care is really of an induction approach. You give induction gemcitabine cisplatin followed by concurrent chemoradiation. We all adapted this. And then it's, why induction is very tolerated very well, but during the concurrent phase, at least in our hands and many others, it's very difficult to give another high dose cisplatin as written in the protocol. We wind up many times switching to weekly cisplatin. Now, whether weekly is better, same or worse, I think toxicity is different. It's certainly not better, but it's probably equivalent. Just when I thought induction chemotherapy is going to be the standard, the problem is now we have the adjuvants coming back. And this is another trial, and they're putting together the manuscript. It's an adjuvant setting where it's also phase 3, and we give adjuvant capecitabine. Now, instead of giving neoadjuvant chemotherapy, then chemoradiation, we're doing chemoradiation and then randomized to adjuvant. And you can see adjuvant capecitabine. Look at this. It's the in favor, and then especially the primary endpoint. And you look at every other endpoint, whether overall survival, failure-free survival, local regional free survival, recurrence-free free survival, it's in favor of the adjuvant arm. So now, of course, Sun did this elegant study that was published in JAMA Oncology. It's a phase 3 study that compared induction versus adjuvant in the backbone of concurrent. That's what we need to know. And you can see here, they actually chose patients with pretty high risk that have very high EBV DNA, which I'll get into a second. Induction paclitaxel cisplatin 5FU followed by concurrent, or concurrent followed by adjuvant cis 5FU, which has been the standard prior to induction chemotherapy. Guess what? Completely different, completely the same. There is no difference in the whether induction or adjuvant, but the pattern failure is different. Patients, if you're giving induction chemotherapy, have less chance of having distant metastases, but if you're having concurrent first, you have better local regional control. And that makes sense, right? But as a radiation oncology, in my own opinion, I think it's better to fail distantly because now we have immunotherapy. Because in the nasopharynx, when you fail local regionally, it's very difficult to salvage, we all know, right? There's no surgical salvage, difficult problem. And so now you have these two choices. Both are acceptable standard care. Now, why is there a difference? And I think it's because of this EBV DNA. I bring EBV DNA liquid biopsy because it is very important. Here, Dennis Lowe is the godfather of liquid biopsy. He did this in the 1990s, right? And you can see healthy controls do not have EBV DNA in the blood. When you have cancer, you do. And then here you can see with this, they use it for even screening in Hong Kong, where they take tubes of blood in asymptomatic at-risk patient, meaning normal population. We know that nasopharyngeal cancer is common in Hong Kong, China, so they did this screening study. And they take two blood targeted against BAMH1, 20 millimeter of blood. And guess what? They were able to find these asymptomatic small nasopharyngeal cancer. They treat them early. And guess what? When you compare to the historical presentation, patients are better. So now we're moving into earlier detection concept, which is across all cancer. It's very important. And nasopharyngeal cancer has this positive study. Now, it's important. Your assay is important. Because there's so many different assays, and the assay, at least in the United States, credential against NCI, Stanford Memorial. We have the assay. Otherwise, you get an assay that's not sensitive enough. It's not going to pick up the disease. Now, it's important when we are thinking about minimal residual disease, which I'll talk about later as well with oropharyngeal cancer. But on the whole, plasma EBV DNA is a more novel prognostic MPC biomarker, better than TNM. It's controlled, and you can see the fivefold increase in the outcome survival, especially in the post-treatment, post-chemo radiation setting. Now, because assays are different, it could be the sensitivity is an issue. So what Quinn Lee did is basically compare the different assays throughout the different expert labs. And I want to show you what's striking is these are all expert labs. Look at the difference in a tube of blood. Your sensitivity is completely different. But after harmonization, where they make sure everybody had the same buffer, PCR mix calibrator, the sensitivity increased, and harmonization even got up to happen over 0.9. And that's important because if you're going to run a trial, your assay, depending on the lab you go to, is different. Guess what? You're going to have different outcome. So you better make sure your assay is right. So this is a study that I ran. Very excited to tell everyone. Patient, pre-treatment, a tube of blood, chemo radiation. At the end of treatment, if you're low risk, you can see in non-inferiority study, patient versus cisplatin 5-FU. If you're high risk, adjuvant cisplatin 5-FU versus gemcitabine paclitaxel is a phase 2. And the results will be read out later this year. So for first time, we're going to know, do we need to have adjuvant chemo? If this is a positive study, meaning we can observe after concurrent chemo RT, then we're absolutely overtreating patient by giving everybody induction chemo. We have to think about late toxicity. So that's what I'm very excited waiting for the study to come. And of course, you can use adjuvant EBV DNA. You can do multiple time points. And we know that even if you're positive first time, if your second time is negative, then we know your progression-free survival is the same as if you had the first time negative. Now, clearance can be also used to prognosticate your MPC. You can see, I think this is a feature. This is why I want to bring out blood. Depending on, look, how many cycles of chemotherapy you give. If you clear first time, guess what? Your survival after one cycle chemo is going to be much better than someone needed that don't clear, right? And that makes sense. So these trials are going to be important. This is, I firmly believe, will be the future of how we conduct study to further personalized therapy. And that's nasopharyngeal cancer. Now we're going to talk about the controversy about proton therapy. I want to give an update for oropharyngeal cancer. Of course, everyone knows about the Steve Frank study published in Lancet, where it's a non-inferiority trial, and we did prove that proton is non-inferior. And when you look at these curves, it's in favor of proton, but this is a secondary endpoint. Events are very few here. And we know salvage is so different. If you're a proton patient, at least in the United States, you probably have access to better healthcare system. That's the problem with the US system versus if you are outside in a more socialized country where you may not see the difference. Now, they did show that the peg rate, feeding tube rate, is less with proton. But these are very high feeding tube rate. I think you guys would agree. So right now we'll probably have less feeding tube rate anyway. So all we can say in my mind for proton is it's another technology. If your patient asks for it, okay to have. If your patient doesn't ask for it, you do not have to offer proton. It is not the standard in my mind. In fact, at our center, we do have proton. I do a combination of IMRT proton because proton has its own problem, which is namely bone problem, air problem, skin issues. There are issues, and we publish on that. So something to think about if you are implementing proton. I like the combination. Otherwise, we can get into trouble. Now, of course, with a POSIT study, there is this UK study by Dave Thompson. I love this study. In the United Kingdom, there is no crossover. You're randomized, you listen, you get IMRT, you get IMT. In the US, if you're not happy, you can cross over. That's the problem. So here, IMRT and IMPT gave you similar quality of life score. That's their primary endpoint. There was no difference. So whether you got IMRT or IMPT, patient felt the same. The G-tube rate was the same, although at 1 year, that's a little criticism, but everything else is the same. So it is early. Now, whether this holds up, whether the curve will separate, that remains to be told. In fact, we can say the proton probably a little bit worse than the IMRT. So many more trials will come, but suffice to say, proton is one standard care. It doesn't mean it is the standard care. IMRT is perfectly fine as a standard care. Then I'm going to talk about HPV positive oropharyngeal cancer, very exciting era. For me, let's summarize what is the standard care. Chemoradiation to 7 weeks of platinum-based chemoradiation or surgery followed by post-op RT, 60 to 66 or 50 gray. Of course, patients have very high risk of toxicity, acute and late. And then there are a lot of effort to reduce these toxicity, whether it's surgeons, med-onc, and rad-oncs. And then question I had is, do we need to treat everybody the same? Does one size really fit all? We know it doesn't, right? We have two approaches for de-escalation memorial. I'm going to tell you about one that didn't work and one did work. The first one is, again, back to this liquid biopsy. Of course, like plasma EBV DNA for nasopharyngeal cancer, ctDNA is for HPV-associated head and neck cancer. And how do we integrate? We know it's important, but now we're going to use it as a change in treatment biomarker. We conducted this study. We said, all right, 1 tube of blood before treatment, surgery, you have to have an indication to get post-op RT. Then we had 2 time points afterward to say, has to be negative, bunch of imaging MRI negative, and then we had a paradigm. Like prostate, if you're negative, we observe you. If your ctDNA started to rise, it's not an event, we give delayed radiation. But if you have gross recurrence, it is an event. To our surprise, only 67% of patients cleared. Another 8% of patients delayed adjuvant therapy, but 25% with a closer trial because it exceeded our tolerance. They have gross disease. Here's an example. 1608 EBV DNA. Here's the tumor. Post-op negative. We follow negative. And guess what? Gross recurrence. The blood is still negative. It's not sensitive enough. This is what I mean by sensitivity. If you're going to omit therapy based on liquid biopsy, sensitivity must be very, very high. Otherwise, you can run into trouble. Here we wrote this article that liquid biopsy good for positive predictive value, but everything else is suboptimal. So be careful. Here we say that it's lacks a sufficient sensitivity to replace imaging or tissue, and we need randomized study for surveillance. You have to have a more sensitive test. And when I think it's helpful when you have imaging and they're like, is that tumor? Is it not? Liquid biopsy can be another added assurance. And then in California, they did this consortium, and they say that ctDNA is valuable for prognosis, diagnosis, and surveillance. But right now, you need to have trials. Must be validated in the prospective setting. And we now, with Dan Fig and Glenn Hanna, we have another piece and say, you cannot omit using ctDNA alone, any therapy. Maybe you can use it to also add to your pathologic feature. Then my question is, does it really add value? Because it costs money in someone's blood. We had an ongoing trial that was negative, I told you, but what we found is we had a cohort. What if you had surgery and you have positive ECE or positive margin, HPV, then you're going to get really high doses. What if your ctDNA is negative? This is going to help. Then we give 30 gray. And this trial is really good. We submitted to Astro. Hopefully we can share the result with everyone. Of course, the better assay, Natera, is one assay that we're going to partner with. It's personalized based on tumor as well as blood. I think it's a little bit better, and I'm eager to see the result, and we will have a trial. And look at this paper by Glenn Hanna. If you're negative after treatment, you do much better. If you're positive, look at the curve. You can put like 10 thumbs in between these curves. And here's a trial that we're putting together. We're hoping to open the next month or so, where if we have very early stage, we're going to continue to observe in that intermediate group, does this assay help? And we're going to give 30 gray. We're not going to observe them. But then the ECA positive margin will give 30 gray and chemo RT. Why 30? Because HPV positive anal cancer only needs 30. And I'm going to give that into a definite setting. So that's ongoing trial. So hopefully ctDNA can help us as an additional biomarker to omit or to de-escalate. I want to talk about hypoxia and talking about this. Hypoxia is an important biomarker, everyone knows, and it's important for HPV-driven cancer. It's more radio-resistant. We know that you can measure hypoxia non-invasively using imaging, different tracer like FTG, but we use F-misol, 18-fluoromisylnidazole. And the question is, how can we use intra-treatment imaging to de-escalate a gross tumor, not surgery, and to what dose? In my mind, must be safe, has to have meaningful toxicity reduction. It's based on Y30 grade based on anal cancer. We go back to this 1917, Dr. Nigro was surgeon. 30 grade was sufficient to treat with chemoradiation to treat anal cancer, which is HPV driven. Earlier on, the preoperative RT alone data without HPV status, 60% had pathologic CR. So I think we're overtreating HPV driven tumor. We kept the chemotherapy because it makes sense. It's a DNA repair deficiency. We give chemo and to sterilize even distant metastasis, enhance the radiation. So we put together this paper, very exciting. We had 158 patients after our pilot study. We took out the primary, and here's the paradigm. FDG positive, if your F-misol is negative, 30 gray. FDG positive, if F-misol pretreatment positive, but it converts 2 weeks into treatment, 30 gray. But if it's persistent on the third panel, FDG, F-misol positive, persistent positive, then we give 70 gray. So very binary. If you're hypoxia negative, 30 gray, hypoxia positive, 70 gray. And here we have 80% de-escalation. And look at our curve. Excellent progression-free survival. And then we had, this is our survival. And then we extended outside to our partners, and we continued to another set of 158 patients. Look at no difference, 30 or 70. 30 gray patient with F-misol negative, no difference regional failure, no difference in overall survival. And you can see 90 day of the toxicity. And you can see toxicity, call your attention, is about 30 gray is about, there's still some toxicity, but triple for 70 gray, grade 2. And grade 3 and 4, another triple, especially like mucositis, you can see. And then objectively, you can see this is unheard of for 30 grade. This type of no problem with swallowing. And then, of course, the people wanted us to bring to the FDA on the trial, and we did go to the FDA. We are running this trial. We have enrolled actually 130 randomized these patients to a double-blinded study. We do not know whether the patient is on the experimental arm, which is a pathway, or versus standard care. So how do we blind it? Everybody's blinded. Patient doesn't know, we don't know. A nuclear medicine doctor don't know. But we then assess whether the patient should get 30 gray or 70 gray. And then we use F-MISO. If it's positive, the trial, it will become like PSMA PET. And then we can now give it to patient. Just like FDG was a tracer, F-MISO is a tracer, PSMA is tracer. Primary objective is overall survival with a bunch of secondary objective. And then you can see that's power. And then not only is F-MISO hypoxic pathway study done in the United States, it's actually done in Sydney. I'm helping them, and there's a paper coming out, and the Gore-Tex in Europe is running this study, which is very, very exciting for me. And then, not Gore-Tex, the Germans, University of Mainz running the study, and at Gore-Tex, they're developing. I don't know where it is at right now, whether they are happening or not, but I do know Sydney, Australia, they're going to bring it to trial. Eventually, in the U.S. studies, a positive, we probably will have an energy oncology study. And I want to end by another concept. I think we are over-treating all patients. Why 7 weeks of chemoradiation? That was passed down by our forefathers, right? We just kind of said it. 2D era, safe, we keep going. Well, IMRT, proton, let's just do 70 gray. But why does everybody need 70 gray? So here, after we are learning our experience for HPV, we are now looking at NPC, nasopharyngeal cancer. We partner with Regeneron. We have induction chemotherapy. Then whether it's cemiplimab or induction cemiplimab, fianlimab, we give also bloods. And then here we have F-MISO. If F-MISO is negative, we're going to stop at 40 gray. And then if F-MISO is positive, we're going to go to 70 gray. And you may ask me, why 40 gray? Well, did you know that EBV-driven lymphoma need about 36 to 44 gray, and that's why I picked 40 gray. I think this is going to work. We are going to be very careful. This study, we're going to have our startup meeting tomorrow, actually, and we're going to start this study literally next month. We're very excited. We're hoping to help our patient. So in the end, I want to say that I've done a lot of study. There's a lot of update, very exciting for head and neck cancer. We're very good at our toys here, protons, great, but we need to think about biology. How can we transform the practice of radiation therapy from a blunt tool to really a biology information-driven target approach? Thank you for your attention. This work cannot be done without a lot of collaborators. Thank you for your attention. Okay.
Thank you so much for interesting presentation. I just one question about, because I saw a published article, I guess, in Green Journal about this phase 1 trial about hypofractionation of head and neck cancer. So I just want to ask, do you implement some trials in your institution about the hypo, or?
Great question. I didn't get into the whole hypofractionation because it's controversial. I know in Europe it's favor. When we think about the dose per fraction, you have to
Really?
think about future, the toxicity. First 5 years, I don't think there's much problem. When you
Mm.
get out to 10th year, the 15 years, and this is an aging population, patients can get very, very high toxicity, something to really, really think about. I am very worried about late toxicity. I
Yeah.
follow my patient. You go up to 20 plus years, you're going to have problem like
Mm.
breast cancer. So no, we do not implement hypofractionation.
Okay, thank you.
Thank you very much. Thank you, Dr. RN. We now in Malaysia, and here we'll be putting on impacts of immunotherapy in treatment of metastatic nasopharyngeal carcinomas. Dr. Lee, please go ahead.
Hi, can you see my screen? Hello.
Yes, we see.
Yes, we see. And my slide? Okay. First of all, thank you, OncoDaily, for the invitation, and thank you for the introduction. And it's a pleasure and honor to speak after two very preeminent speakers in the space of nasopharyngeal cancer. My name is David Lee. I'm a clinical oncologist at Sambil Medical Center here in Malaysia, and be sharing to you about the impact of immunotherapy in treatment of metastatic nasopharyngeal cancer, especially coming from a perspective from a clinical oncologist in Malaysia. Some disclosures. So for I guess the audience today will be quite widespread. So nasopharyngeal cancer is endemic in my region in Southeast Asia. So it's one of the more common cancers compared to our Western counterparts. And you can see from the right here, so Southeast Asia has a significant contribution in terms of the incidence of NPC globally, and Malaysia also has one of the front runners in terms of the number of NPC cases globally. And something unique about sharing about Malaysia is that we are a multi-ethnic country. So we have predominantly the Malays, and then a quarter of Chinese, and then the rest will be Aborigines as well as Indians. And the risk of developing NPC is very different among these three main races. So you can see in Chinese it's as high as 1 in 100 cases, and it's significantly lower in the Malay race as well as the Indian race. So because of the quarter of the Chinese population, that is the one that's driving the number of NPC cases in Malaysia. And another thing that's something that's quite unique for my colleagues who are working in the Borneo Island, the eastern part of Malaysia. There is a specific Aboriginal group called the Bidayu, and it's found to have even significantly higher risk of getting NPC, even compared to the higher than those of Chinese ethnic origin, whether it's across, whether in China, Hong Kong, and Singapore, and different parts of Malaysia. So it's something quite unique that we found in the Borneo Island part of Malaysia. So systemic therapy remains the key in terms of treating recurrent metastatic nasopharyngeal cancer. And back in the day, I can recall when I was new in oncology, we used to give cisplatin 5-FU and get patients admitted over 4 or 5 days to get these long infusions until this paper from the Sanyat San group that showed superiority of cisplatin gemcitabine over cisplatin 5-FU, 7 months of PFS compared to 5.6 months. And of course, that translated into overall survival. But this has sort of hit the bottleneck of chemotherapy. You can see, if despite a better regimen, the PFS at 1 remains only at 20%. So it is something that ought to be improved further, and seems to have limit in terms of what chemotherapy can do. And can we do better than that? So in the sort of past 5 years, the numerous PD-1 inhibitors came out in the phase 3 pivotal trials across 3 PD-1 inhibitors, tislelizumab, toripalimab, as well as camrelizumab, all showing all meeting their primary endpoint with a progression-free survival benefit compared to cisplatin gemcitabine. So firstly, I'll be zooming into Jupiter-02. It's a phase 3 trial randomizing patient with primary metastatic NPC or recurrent metastatic NPC after curative intent treatment. These are treatment-naive patients, ran with good performance status, randomized into combination of toripalimab and chemotherapy up to 6 cycles versus chemotherapy alone up to 6 cycles, followed by maintenance toripalimab for those in the investigator experimental arm with the primary endpoint of progression-free survival. So very clearly, clear separation of curve with a progression-free survival of 13 months. And you can see that 1-year PFS rate has significantly improved from the 20s to 30s to up to almost 60% of 1-year PFS rate with addition of an anti-PD-1 inhibitor. And we attempt to see any biomarker to lead us to show some of whether patients will benefit a bit more with anti-PD-1 inhibitor, and most of the subgroups actually benefit more, and whether a patient has a high or low baseline EBV DNA or actually PD-1 expression, actually all subgroups actually benefit from addition of immunotherapy. And that led to improvement of overall survival with not reached versus 33 months, hazard ratio 0.63, very significant and clear overall survival benefit with toripalimab. And with the further readout, this was updated in 2024 ASCO with the 5-year overall survival rate of 52%. So this is not seen in the era of just chemotherapy alone. So GP does give, cisplatin gemcitabine does give very, very high objective response rates on its own, almost in the range of 60%. So these patients tend to downsize very quickly. But even then, addition of toripalimab, improved the objective response rate to almost 80%. But what is also remarkable is that the complete patient getting complete response has doubled. So numerically, it might not seem like a lot of improvement in ORR, but the CR rate has doubled, and that's significant. And it's often a struggle because back then, without introduction of immunotherapy, we saw patients having downstaging very quickly, but it was not a sustainable partial or complete response. Often recur very quickly, which is something that immunotherapy is able to address through the maintenance component of the toripalimab. So with every new drug that we use, we often need to also look at the adverse events. I think by now, most people would have been used to to use anti-PD-1 inhibitor, at least in other indications, in lung cancer and other indications. So toripalimab is no different, very similar experience with other PD-1 inhibitors. These are mainly manageable treatment-related adverse events if IRA less than 10%. Range for those upper more than grade 3. So mainly very manageable treatment-related adverse events. And I think this is a recurrent trend. We're talking about NPC, EBV DNA clearance or EBV DNA monitoring becomes very important. And we can see by introduction of toripalimab, on the left side, you can see the clearance, more patients actually clear EBV DNA by the 3rd cycle. And then that's also very sustained in terms of maintaining that clearance for a long time, enough to up to 20 months median time from the EBV to back to the rebound. So much better clearance and much more sustainable clearance as well for a long time. So just in short, to just close up on Jupiter-02, PFS and OS were both significantly better. 5-year overall survival more than 50%, which is not seen before in the chemotherapy era. EBV DNA clearance, it does predict, help us to predict response and also recurrence, and the clearance is evident. And it's no new safety signals. It's similar to using any other PD-1 inhibitor in the market. So with the Jupiter-02, that has led to the introduction or addition of toripalimab in the NCCN guidelines as a preferred first-line therapy with cisplatin gemcitabine. I also talk about a bit about Rationale 309. This is a similar trial using tislelizumab. I'm very familiar with this trial because back in Malaysia, tislelizumab is the only, at this point, the only PD-1 inhibitor available for indication of NPC. So again, similar design with just replacing toripalimab with tislelizumab, similar chemotherapy and similar maintenance therapy as well. So very consistently, same as JUPITER-02, we're seeing progression-free survival benefit with the introduction of tislelizumab, median PFS improvement from 7 months to 9.6 months with hazard ratio of 0.5. Similarly, across subgroups, whether it's taking into account EBV DNA level, PD-1 expression, most of the subgroups actually do improve with the introduction of tislelizumab. Similarly, objective response rate is also, again, quite high already with the placebo group with chemotherapy. But again, we're still seeing that even though the bar is very high, the OR is still better with the introduction of tislelizumab with about 70% of objective response rate, and as well as again doubling up on the complete response rate from about 7% to 16%. And that also led to a favorable overall response, overall survival, and sort of a caveat is that in the analysis of this Rationale 309, there's also an inclusion of PFS2 because in this trial it was basically there were patients, about half of the patients were crossed over to tislelizumab group, and despite that, the overall survival is still favorable to tislelizumab plus chemotherapy group. Safety, very similar to JUPITER-02, manageable toxicity. I'm a lot more familiar with tislelizumab in my practice. Again, very manageable drug with nothing more expected than any other checkpoint inhibitors. So in the follow-up study that was presented in ESMO Asia 2024, in the updated analysis, progression-free survival is consistent. Hazard ratio remains about 0.5. So very similar, consistent with the longer follow-up of PFS in this trial. And the sort of longer readout, 3 year, at the 3-year point, the overall survival with the introduction of immunotherapy, 55.6% versus 46% overall survival improvement, despite very high crossover rate in this trial. So the investigators of 309 actually did adjust for crossover, and despite adjusting for the crossover, the overall survival was still clearly beneficial in the if you use tislelizumab in the first-line setting. So just to close about Rationale 309, it met its primary endpoint. It is consistent, very similar to JUPITER-02. And with the longer follow-up, 3-year follow-up, the benefit is sustainable compared to chemotherapy alone, whether it's overall survival or even if they take into account the high crossover rate. So to sort of sum up the meta-analysis, whether you should thinking about adding immunotherapy in the first line. So this meta-analysis compiled all 3 pivotal trials, the very similar trial design, and it's very consistently whether it's looking into progression-free survival or overall survival. It's a consistent improvement with addition of immunotherapy to GP. So in terms of choice of immunotherapy, there are sort of, I would call this a similar class effect, so very similar rates of IRAE with very low grade no surprises in terms of the grade 3 or more IRAE across all 3 pivotal trials. So I'm going to use this opportunity to share some of the experience. And sort of segue into the next topic. So I have 53 patient in 50s, a fit man, came in with bilateral neck nodes, one side more than the other. And then my ENT colleague did a biopsy and it showed to be non-keratinizing undifferentiated carcinoma, which is the most common histology in our region, with a baseline HBV in excess of 80,000 copies. So in imaging, in the nasopharynx, not too bad. Not is parapharyngeal space involvement, fairly big lymph nodes, especially on the right side. And in the new staging, introduction of new staging, because the lymph node, even though not lower than not in the SCF, but by virtue of muscle involvement on the right side there, you can see, so it becomes entry, and also has a single metastasis at the liver at a single lesion. So I've staged this patient at stage 4A with the new 9th edition TNF staging. So I have access to tislelizumab in my practice. So I've given him tislelizumab, carboplatin, and gemcitabine, had excellent response. Most of the disease have disappeared completely with a very, very small residual at the left nasopharynx. I'm still at the means. This is real-time case, and I'm still waiting for the repeated EBV DNA, which we sent to another center because it's harmonized. So at this point in time, the question will be whether is there a role or what next to do. So we shall segue into the topic. So and in the pre-immunotherapy era, for patients who have undergone chemotherapy in a metastatic setting, local radiotherapy has shown to improve progression-free survival as well as overall survival, and became standard of care for most of the patients who responded well, at least to the first-line chemotherapy. But in the era of immunotherapy, whether this remains sort of relevant and whether the bar is still could be raised higher with introduction of radiotherapy is up for discussion. So in my practice, it's sort of a shared decision making with my patients whether we're going to embark on local radiotherapy to the head and neck region. How about the metastatic sites? So if you want to ablate the head and neck region, the primary disease, how about patients with sort of similar like cases on the oligo, single nodule, whether it's in the liver, in the bone? This is a phase 2 trial that look at this with addition of metastatic directed stereotactic radiotherapy on top of immunotherapy, has shown, of course, it's a phase 2 study, small population, has shown a slightly numerical age over patients that has received metastatic directed therapy compared to patients who didn't. So in the NCCN guidelines for patients with oligometastatic disease, radiotherapy to the primary and regional nodes, and also with or without to the oligometastatic sites can be recommended, and especially for patients after induction for oligometastatic disease, and for patients who have widespread metastatic disease with good performance status, but responded very well to systemic therapy, whether CR or near CR, do consider the local therapy to the primary regional nodes, plus minus to oligometastatic sites. How about maintenance though? So back then, with just 4 to 6 cycles of cisplatin gemcitabine, the discussion will be whether patients will be keen to go on maintenance capecitabine, depending on patient performance status, preference, as well as disease volume. And this has shown to be better compared to just observation alone. And the question of whether with maintenance immunotherapy at this point, whether adding capecitabine will still remain relevant or not, is still up to be debated. Of course, from the Sun Yat-sen Cancer Center experience, single institution cohort, potentially showing a slightly better survival, PFS, or overall survival with a combination of capecitabine to the existing PD-1 that was used in the sort of the induction phase of the first line therapy. Of course, we're looking forward to a phase 3 trial that look at this properly in the randomized ratio, randomized manner to see whether maintenance, intensifying maintenance with chemotherapy, with capecitabine, whether it will be better than just immunotherapy alone. So we talked about immunotherapy in the first line setting, and besides the PD-1 inhibitor, the EBV specific cytotoxic T lymphocyte was also investigated, but this was shown to be negative. There's a continued discussion and efforts in the space of introduction of immunotherapy in the locally advanced group, and whether it's using it in together with the induction phase, concurrent phase, as well as the adjuvant phase of the radical treatment in the locally advanced group, and also for second line and beyond, slightly not less convincing, but nonetheless could be considered if you have exhausted other therapy. So pembrolizumab was looking at the second line, but it was the overall survival was negative. So I'm going to close here with just a bit of a take-home message. So at this point in time, platinum gemcitabine is a preferred chemotherapy of choice in the first line recurrent metastatic NPC. And with hopefully, with this region, I understand access can be variable depending on country. And if feasible, additional PD-1 inhibitor should be the new standard of care and should be considered. And with this change of paradigm in the first line setting, other questions sort of evolve, and whether local therapy to the head and neck region remains relevant. How about metastatic site directed therapy? And all this could be discussed and can be considered case-to-case basis. The other thing with the maintenance therapy is whether there should be intensification or de-intensification of maintenance therapy with single agent immunotherapy after the chemotherapy has complete. And potentially this could be guided by volume of disease, EBV DNA clearance, and that's potentially some of the sort of soft factors you can use that I would use to think about whether they want to intensify chemotherapy or not for these patients. And really exciting about, some of these, it's just really tempting, some of the potential role of immunotherapy, whether we could use some of the PD-1 inhibitors, it works really well in the metastatic setting, whether it could also be a new standard of care in the future for patients with locally advanced in the curative setting. We're seeing excitement in the head and neck squamous cell carcinoma space with Keynote 689 as only post-op, but whether this also could be translated into nasopharyngeal cancer or not is yet to be hopefully a near future for us. So thank you very much for your attention, and I look forward to the next topic of discussion. Thank you.
Thank you very much, Dr. Lee, for your insightful presentation. And just a short, quick question. I was wondering if there is still a role for PD-1 inhibitors monotherapy in metastatic setting for nasopharyngeal carcinomas. What do you think?
It's a good question. So it's very tempting, but it will not be. So NPC remains very chemosensitive. Even with GP alone, the response rate is very high. And I will try to, as much as possible, to incorporate that. But patients who are unfit or really does not want chemotherapy, I think that it is still, for those kind of cases, it could be still be considered if they really don't want chemotherapy, a single agent PD-1 inhibitor.
Okay. Thank you very much. Thank you
Thank
for
you.
your time and effort. And now we will have a short break while we are waiting for our next speaker. Stay with us. Thank you very much, everyone, for your patience. And we now move to the surgical part. And our next speaker is Dr. Kinjal Shankar Majumdar from Apollo Hospitals, Naritrapur, India. Dr. Majumdar, please, the floor is yours.
Thank you. Am I audible?
Yes, we can hear you very well.
So, are my slides visible?
Your, your screen is visible too.
So, slides are also visible, correct?
We can't yet see your slides.
Just a minute. To open through Chrome, correct? Make it visible. So, is it visible now?
Yes, now we see it.
Yeah. Sorry for the delay. Yeah. Now visible?
Yes, yes, Dr. Majumdar, you can start.
Okay. Sorry. So, thank you, OncoDaily, for the excellent opportunity. So, today we'll be discussing about the role of surgery in early head and neck squamous cell carcinoma, particularly in the era of organ preservation. So, at the outset, I would like to declare that there is no conflict of interest for the presentation. So, this is a brief roadmap how we will proceed today. So, we'll start with the historical context and then we'll discuss about all the surgical armamentariums that we have in our hand for organ preservation, the best possible site-specific evidence till date, including emerging evidences, the functional and oncological outcomes when compared to non-surgical organ preservation arms, and the future directions. So we all know that early head and neck squamous cell carcinoma are basically comprising of stage 1 and stage 2. So clinically T1, T2, and 0 tumors as per AJCC 8th edition. Although in South Asia, particularly where I practice, that is in India, we get only 30% of our patients in stage 1 or 2. And I hope that it's quite high in the Western Hemisphere and in any developed nation. But even if it's stage 1 and 2 early stage, the 5-year locoregional recurrence rate still remains in between 5 to 25%. The epidemiology varies, as we all know. The Western Hemisphere is dominated by HPV positive oropharyngeal squamous cell carcinoma, whereas in South Asia, it's predominantly tobacco-induced oral cavity squamous cell carcinoma, which predominates. Early detection always remains the key and foundational for any surgical conservation planning. So historically, till 1990, surgeons had an unopposed play in all types of radical surgeries, be it for laryngectomies or a radical neck dissection or commando surgery. So till in 1991, when Veteran Affair trial in larynx conservation hits hard and told us about the non-surgical organ preservation is possible, and it was kind of a decade followed by Veterans Affairs trial, which kind of debated originally centered was around avoiding surgery and projecting chemoradiation as an alternative. Thanks to modern techniques, the surgical innovations, particularly minimally invasive platforms like transoral laser surgery, transoral robotic surgery, which came into play and put back surgical arm again into the context of organ preservation. So mainly it started 2009 onwards, in the year when FDA approved TORS for organ preservation tool, and the whole surgical organ preservation roamed around or rotated around not only surgical innovative tools, but also a better understanding of the disease biology as well as a better understanding of the surgical margins. So these are roughly the surgical platforms that we have in our hand for organ preservation, so in form of transoral laser microsurgery, transoral robotic surgery, and open organ preservation surgery like partial laryngectomy, supracricoid laryngectomies, marginal mandibulectomy, hemiglossectomy, with additionally very good reconstruction with local, regional, or free flaps, microvascular flaps. So coming to site-specific evidence, oral cavity is still the undisputed surgical territory, and surgery remains the gold standard for all early oral cavity squamous cell carcinoma. Although no randomized trial have shown to be present, but as we can see in the picture that a large national cancer database study comprising of almost 23,000 patients showed that surgery still gives a better overall survival and disease-specific survival in early oral cavity cancers. And there was a recent meta-analysis also, a Canadian meta-analysis in 2019 also showed that the overall survival favors surgery. And eventually what happened is that almost 40% drop has been seen in non-surgical management of early oral cavity cancers from 1998 to 2009. So what we have learned over the years that a 5 mm or more than 5 mm margin has to be there to designate is that a clear margin, and anything less than that mandate postoperative radiotherapy is not sacrosanct. So there are emerging data, and one such data from MSKCC has also showed that the cutoff may be lowered down to almost 2.2 millimeter in cases of early disease, obviously in absence of other high risk features. The neoadjuvant chemotherapy for paramandibular disease for mandible sparing, otherwise where a hemimandibulectomy or a segmental mandibulectomy was offered, with increased use of neoadjuvant chemotherapy, almost 60% of the mandible can be spared, but it's still investigational. The current data that we have is phase 2 data, and phase 3 trial is underway. Depth of invasion based elective neck dissection has been postulated by the famous NEJM paper by TMH team, Tata Memorial team from India in 2015. And any positive margin or extratumoral PNI, LVI, and was pattern of invasion obviously denotes for a post-operative radiotherapy. So this is the NCCN 2026 version 1 guideline, where it also shows for early stage surgery is still the preferred regimen of choice. Coming to oropharyngeal squamous cell carcinoma, so basically in last 1 decade, most of the work has been rotated around oropharyngeal carcinoma, and thanks to Ang et al. For his seminal paper on HPV positive oropharyngeal carcinoma, which kind of changed how we look at the disease. The initial studies by Weinstein, Smith, and an Indian study also showed good clinical outcome in cases of transoral robotics in early oropharyngeal carcinoma. The first ever trial, randomized control trial that we had was ORATOR trial in 2019, but it was kind of a negative study for the TORS arm because of the significantly poor MDADI score at 1 year, and almost 70% of the patients received adjuvant therapy. ORATOR 2 trial, however, prematurely terminated, so survival data that we have is kind of immature. In 2024, ORATOR trial has come out with a 5-year report where it showed that transoral robotic surgery, although giving equal OS and PFS, MDADI score somehow converged over 5 years of time, although the adverse effects kind of different between both the arms, within the surgical arm and the non-surgical arms. But however, this is the best possible study we have in form of RCT, but it's not a good study to draw any sort of conclusions, because obviously it's a very small, for its small sample size, it's just 68 patients. Then the margin that they have chosen was kind of 1 centimeter gross margin. So because of that, we have seen more amount of bleeding and death because of the bleeding in the ORATOR 2 trial in the surgical arm. So as of now, the RCT that we have in form of ORATOR is not a very good study, so we should not draw any sort of conclusion. However, in HPV negative oropharyngeal carcinoma that is predominating in the Eastern Hemisphere or in low middle income countries, there is a large NCDB database study in 2022 with 848 patients, which surprisingly showed a better overall survival in the TORS arm when compared to non-surgical arm. Similarly, what we have seen that TORS achieves a negative margin of more than or upwards of 90% in particularly T1, T2 cases. So case selection is the key. However, in HPV negative oropharyngeal carcinoma, the data on TORS is still very sparse. The problem is that 14 to 70% patients receive any sort of adjuvant therapy, be it radiotherapy or chemoradiation. So the cumulative toxicities may increase. TORS, but the area where TORS has really given away is basically where TORS enabled us for an adjuvant stratification based on pathology, histopathology, and avoiding overtreatment in low-risk HPV positive cases. We have PATHOS trial, which is kind of a landmark trial that is ongoing and completion is expected in April 2028. The initial study has shown, or a subset study has shown, that in TORS arm we have around 45% of NG tube rate, and in TLM arm we have around 8% of NG tube dependency. So similarly, again in NCCN 2026, in both in HPV positive and HPV negative T1, T2 oropharynx, both the definitive RT and the primary dissection or the surgical arm has been given category 2A recommendation. Coming to early glottic squamous cell carcinoma. So basically in this area, transoral laser microsurgery kind of dominates, and we have good enough evidence in form of 3 systematic reviews where it has shown to be the TLM arm is as good as giving in equal local control. The overall survival and disease specific survivals favors TLM. Laryngeal preservation is better with transoral laser microsurgery. However, local control is poorer for T2B subset, where the vocal cord initially has shown some restricted mobility. The recent studies, particularly varying from 2014 to 2024 study, has also shown good larynx preservation and overall survival and local control, even if in those tumors comprising or involving the anterior commissure. I think this is because of the judicious use of radiology, preoperative radiology. So, in summary, both TLM and radiotherapy are acceptable for T1 glottic SCC. Tumor anatomy, patient preference, and center expertise basically determines the way forward. So we have various advantages of using TLM as a surgical organ preservation tool over primary RT. So the treatment time, as in TLM, is basically 1 to 2 hours. It's a daycare procedure compared to a 6 weeks of radiotherapy. A serial resection is feasible for marginal disease. In anterior commissure involvement, as I've already told, that recent studies produced comparable data, and we always have RT available for salvage. So that is how it's reflected on a better larynx preservation in the TLM arm. And because it's a single day procedure in most of the cases, for particularly in T1 glottic CA, it's cost effective when compared to 6-week radiotherapy course. So similarly, again in NCCN, in T1, T2, N0 patients who are amenable for larynx preservation, both radiotherapy as well as transoral laser microsurgery has given category 2A recommendation. Supraglottic SCC or supraglottis is one evolving subsite, so we don't have too much of data. However, we have two studies comprising of TORS in early supraglottis, and it's kind of one was in 2024 and 2025, which showed good results and around 20% of temporary tracheotomy, but definitive PEG dependence of around 5%. So, and also a 5-year overall survival of 80% and a 5-year local control of around 91% with transoral robotic surgeries. So similarly, again, in supraglottis, NCCN 2026 has given both the endoscopic or open partial laryngectomy and definitive RT equal category 2A recommendation. Hypopharynx, due to its inherent bad biology, is the toughest subsite, be it surgical organ preservation or non-surgical organ preservation. So for surgical organ preservation, we have TORS and TLM in our hands when compared to radiotherapy with or without systemic chemotherapy. So what we have seen that in the best possible evidence that shown in 2019 in form of a systematic review meta-analysis comprising of 15 studies have shown equal overall survival and larynx preservation for both the TORS and the TLM arm. Although we don't have a head-on comparison between the surgical and non-surgical arm, but it's always a tough subsite when salvage surgery is concerned. So any sort of recurrence or residual post-CRT always becomes a surgical challenge because of major deconstruction is involved and high pharyngocutenous fistula deaths. So the risk-benefit analysis has to be discussed always in MDT, particularly in hypopharyngeal squamous cell carcinoma subsites. So similarly, this has been reciprocated well in NCCN guideline in 2026, where both are equal, given equal recommendation of category 2A. Now, one area where TORS or surgical organ preservation has really worked well is basically when the de-escalation in HPV positive oropharyngeal carcinoma. The landmark trial, which is PATHOS trial, is still ongoing, so results are awaited. However, other two studies, the ECOP 3311 and DART HPV from Mayo Clinic, has shown to be in favor of TORS first arm. So what it enables is basically a histopathologically driven risk stratification and personalized de-escalation of the adjuvant therapy, particularly in low risk as well as intermediate risk category, which is not possible in non-surgical organ preservation arm. So to summarize what the published evidence demonstrates, oral tongue or oral cavity is still a surgical disease. Oropharynx, particularly in T1, T2, surgery or TORS has shown better overall survival. as also backed by the NCDB database for HPV negative cancers. Glottis is equivalent between TLM and RT. In T2 glottis, however, in high risk T2B, as I've already told, that radiotherapy is still preferred because of the poor local control for transoral laser microsurgery. HPV positive oropharyngeal carcinomas, where de-escalation benefit is there with the TORS approach. The HPV, however, in HPV negative oropharynx, hypopharynx, and supraglottic larynx, we have investigational data, and so institutional discretion and multidisciplinary tumor board is encouraged. Coming to functional outcomes, we have seen comparable swallowing outcomes, both in form of TORS or CRT in orator long-term trial, and particularly in HPV positive cancers where de-escalated radiotherapy following TORS have substantially improved swallowing outcomes. For voice and airway, both in, as we have already seen, that TLM for early glottic CA, the voice handicap index is almost equivalent, and in fact the initial few months the voice may be hoarse for transoral laser microsurgery, but over a period of time it has been seen that the curves usually merge, and particularly at around 4 to 6 months of time, because of the late onset of radiation induced fibrosis, which is kind of irreversible. With TLM arm, what we can also avoid is basically xerostomia and more or less chondronecrosis of the thyroid and cricoid cartilage. However, single cord irradiation studies are there, but it's still investigational. So a lot of recommendation have been given, and usually what we have seen that who belongs to OR and which sort of patients where surgical organ preservation has to be favored is a patient-centered decision making. And for this, we always encourage a multidisciplinary tumor board meeting for all sorts of head and neck squamous cell carcinoma, be it in the early cancers. So the unresolved questions are also there. What we have seen that particularly in HPV positive oropharyngeal carcinoma, that whether the outcomes are truly equivalent, we don't know, because single arm studies dominate. Orator 2 is the only randomized data, but it's prematurely terminated, and the overall survival data we don't have. However, the pathos results, which basically are awaited, might be a practice changing evidence for us. So can we omit post-operative radiotherapy entirely in Rowe surgical patients, particularly in HPV positive oropharyngeal carcinoma, if we go with the TORS first strategy? So again, as we have already told, that pathos trial is the data is awaited, but ECOG 3311 and DART HPV trial has shown or favored omission of post-operative radiotherapy in particularly low risk surgical patients. And surveillance protocols obviously is still not yet standardized, so we have to keep an eye on it. As I've already told, that the whole surgical conservation has roamed around acceptable surgical margin. As we have already told, that 5 mm clear margin remains consensus, but emerging data shows that even a 2.2 mm margin for an early oral cancer is still acceptable. However, molecular margin analysis with virtue of real-time PCR is still investigational. In HPV negative, we have limited data. Whatever have been published by NCDB and one Indian study or two Indian studies have shown initial great results. But the only issue is that adjuvant therapy is needed in almost 70% of the patients, or up to 70% of the patients. And eventually the combined morbidity may exceed primary non-surgical therapy. So as a surgeon, these are my take home or a clean recommendation, that early oral cavity is still surgery. HPV positive oropharynx, TORS is preferred when feasible. Early glottic SCC, TLM, RT both are equal. Elective neck dissection, DY based criteria may be applied. However, we have already seen that sentinel lymph node biopsy is also kind of inferior. Salvage surgery option is always to be given to any patient who is undergoing non-surgical organ preservation, because surgical salvage has its major comorbidity or morbidities associated with. So these are my take-home message, that surgery is organ preservation, obviously not its enemy. Histopathology from surgery drives personalized adjuvant decisions, which may improve quality of life of the patients. MDT decision making is not optional; it's mandatory. Salvage surgery post CRT carries high morbidity, so counsel patients beforehand. And future of organ preservation in early or head and neck squamous cell carcinoma definitely lies with judicious use of minimal invasive surgery followed by tailored adjuvant therapy. So I thank you for the opportunity, and I would like to open up the platform for questions and discussions. Thank you.
Thank you very much, Dr. Majumdar, for your insightful presentation. And as we are running out of time, we will not be able to do questions and answers. And we will move to our next speaker, who is the last speaker of this session, Dr. Long Nguyen from Vietnam National Cancer Hospital. And Dr. Nguyen will be presenting on a globally relevant topic about the access and affordability of head and neck cancer care in resource-limited settings. Dr. Lee.
Thank you for the introduction. So can you see the screen? Okay. So hello, everyone. My name is Long Nguyen, and it's great to be here today. And I'm a medical oncologist from Vietnam National Cancer Hospital. And today I will have a small talk on enhancing access and affordability of head and neck cancer care in resource-limited setting. And I have a disclosure to make before the presentation. The topic today is how I treat head and neck cancer. But to be honest, I actually don't treat head and neck cancer. I'm a breast and gynae medical oncologist. And the reason why I'm here today is I'm also an editorial fellow of JCO Global Oncology. And at JCO we have an increasing number of trials and articles on the topic of access and affordability of cancer care. So, and we will organize a dedicated educational session at ASCO annual meeting this year on improving affordability of cancer care in resource limited setting. And I kindly invite you to attend this session. The articles will be presented in full in this session and in more details. And today I will refer to some of the articles and trials in brief. So my talk will have 4 parts. I will talk about the barriers and challenges of cancer care in LMICs, and then I'll talk about some approaches to increase access and affordability of cancer care in developing countries, and also with some future directions for research and health policies. So speaking of the barriers and challenges, we have a paradox of cancer care in LMIC, in which the majority, 61% of new cases and 71% of cancer deaths occur in LMIC, while we only have less than 5% of global cancer control resources. And those burdens are projected to increase, and more than 75% of cancer deaths are projected to occur in LMIC by 2045. And we have many innovations and new data coming in cancer care. However, our patients still face significant barriers to access to those innovations and high quality cancer care, including the diagnostic gaps with limited screening, inadequate imaging and pathology. So the majority of head and neck SCC in low middle income countries still present at advanced stages. We also have limited access to systemic therapy, in which only 32 to 58% of the WHO essential medicines are available, and access to immunotherapy is extremely limited. In terms of radiotherapy resource, we only have 9% of global radiotherapy capacity, and this is a cornerstone in curative therapy for head and neck cancer. Our patients also face significant financial toxicities, which can drive up to 100 million people into poverty each year, and treatment abandonment will substantially worsen clinical outcome. Patients in developing countries also are often ineligible for clinical trial due to comorbidities, poor performance status, and malnutrition. And in clinical practice, we also face limited MDT availability, insufficient clinical workforce, and lack of research infrastructure and funding. Recent data show that only 8% of the global RCTs are led by LMIC investigators, and among the high-income country-led trials, only 29% include patients from developing countries. And only a few RCT address equity, affordability, and feasibility in developing countries. So why this matters for head and neck cancer in LMIC? Because the epidemiology may be different between two different settings, and also the health system capacity, infrastructure, and drug availability are different. So it is not reflected in global trial designs. So pragmatic and context-specific research are urgently needed in developing countries. So we wrote a paper on ASCO educational book this year, which is in production, in which we propose a value-based framework which integrates clinical benefit with affordability, feasibility, and equity to guide research, resource allocation, and regulatory policies. So the question is, can we have it all? Can we have clinical benefit along with all of this affordability and feasibility? So I'll show you some examples in which the researcher has addressed some of the aspects of the value-based care frameworks. So the first one is low-dose immunotherapy. The rationale for low-dose IO is that, of course, we know that the cost of IO is very high in our countries, and only a small fraction of patients can access to immunotherapy. And even in high-income countries, disparities still persist. So with the absence of universal health coverage, immunotherapy access is extremely limited and will lead to disparities in outcome. So when we look back at the PK and PD for immunotherapy, immunotherapy works in a different way compared to cytotoxic chemotherapy, in which the maximal tolerated dose are not totally applicable here. And when the PD-1 receptor are covered about 70 to 75%, the efficacy is not dose dependent anymore. So in the Keynote 001 trial, near complete PD-1 engagement are observed at the dose of 1 milligram per kilogram, and no differences were observed between different dose levels. For pembrolizumab and for nivolumab, the efficacy threshold is 1.2, and the standard dose achieved 28 times higher of the threshold for drug concentration for the efficacy threshold. And when we use a lower dose of 20 milligram, it can achieve more than 75 PD-1 occupancy, and this can lead to potential cost saving of 95 to 99%. So there has been many trials, many retrospective studies on low-dose immunotherapy, but recently we also have clinical trial showing that low-dose immunotherapy is still effective, while can reduce significantly the cost of therapy with the saving up to 99% with low dose and vial sharing. And with the weight-based dosing, which is initially approved by the FDA, it can reduce the drug use by 25 to 45% of the drug cost. So a recent trial was published in JCO this year, is the Delhi trial. It is a phase 3 trial done at Tata Memorial Hospital on 500 patients. They included patients with advanced solid tumors, after failure with at least one prior systemic therapy line. There are many tumor types were included, but more than a half of patients are head and neck cancer patients. They are randomized to standard chemotherapy, which was docetaxel or paclitaxel, or ultra low dose immunotherapy, in which nivolumab 20 milligram every 2 weeks were given. The primary endpoint was overall survival. So this is a very special trial because the patient included in this trial, their monthly income was only about 55 to 85 US dollars per month. So if not included in this trial, they could not afford immunotherapy. So this is very reflective of LMIC patient population. The median number of prior lines are 1, but 29% had at least 2 prior lines of therapy. So the study showed that the overall survival was improved from 4.7 months to 5.88 months, and the hazard ratio of 0.8, which was statistically significant. And the toxicity was also lower with low dose immunotherapy compared to chemotherapy. And the patient had better quality of life on the immunotherapy arm. And the benefit was consistent across all subgroups, including age, sex, smoking, performance status, PD-L1, or lines of therapy. So with this lower dose of immunotherapy, we can potentially save up to 99% of the cost compared to the standard dose. And this can be transformative for patients in LMICs. And the second approach is metronomic chemotherapy. So we know that the metronomic chemotherapy has been used in some cancers. They use continuously low dose chemotherapy rather than the prolonged drug-free breaks with the conventional chemotherapy. And it focused primarily on anti-angiogenic and immunomodulatory effects rather than direct tumor cytotoxicity. And in head and neck cancer, those mechanisms are central to the tumor progression mechanism. So in the context of platinum refractory advanced head and neck cancer, in which patient had poor prognosis and limited treatment options, and in developing countries, access to immunotherapy, as I mentioned, is significantly restricted. So the investigators combined 3 different drugs with different mechanism that I mentioned: methotrexate at low dose for anti-angiogenic effect, alatinib for EGFR signaling inhibition, and celecoxib for COX-2 pathway modulation. So with this combination of oral chemotherapy, it is very applicable to low middle income countries because it requires minimal infusion infrastructure, and all agents here are generically available at low cost. And we know that metronomic chemotherapy have lower rates of myelosuppression compared to conventional chemotherapy. So this is a scalable approach across developing countries. So it is also impressive that they have a very strategic and stepwise clinical development of oral metronomic chemotherapy. Back in 2019, they published a phase 1 and phase 2 trial, a single-arm trial on metronomic chemotherapy in advanced head and neck cancer on 91 patients, which showed feasibility and acceptable toxicity, and also a signal for survival benefit versus historical controls. And last year, 2025, they published a phase 3 trial comparing triple metronomic oral chemotherapy versus physician choice chemotherapy in patients after failure with platinum-based chemo in advanced head and neck cancer setting. And I will talk about this trial in the next slide. And this year, they also have a trial which is accepted for in JCOGO and in PRESS. They compare the addition of triple oral metronomic chemotherapy when added to paclitaxel and carboplatin in advanced unresectable head and neck cancer. And it will be published in a short period of time. So the MetroChase trial is a phase 3 trial comparing triple oral metronomic chemotherapy versus physician choice chemo in platinum refractory advanced head and neck cancer in 214 patients. They showed that the overall survival was improved from 3.1 months to 5 months, and the hazard ratio is 0.63. And the PFS was also improved from 2.7 months to 4.8 months, and the hazard ratio is 0.67. The treatment arm also had favorable toxicity profile in which they can improve the compliance rates and support the practicality of oral administration. So this is a very special trial because they can achieve survival benefit without increasing toxicity and without increasing resource utilization, which is rarely seen in clinical trial in oncology nowadays. And with those evidence, it is now included in the regional guideline of the National Cancer Grid in India for head and neck cancer, with the advantage of oral administration, limited infusion infrastructure requirement, and lower financial toxicities. And these are the evidence on some other trial on oral metronomic chemotherapy in head and neck cancer. So we can see a shift from conventional chemotherapy to evidence, but also affordable cancer care for head and neck cancer. So there are some future directions for research and cancer care in low middle income countries to improve the access and affordability. We can focus on not only the clinical effectiveness, but also cost effectiveness and budget impact analysis to inform the policy so that we can translate global evidence into local and context relevant policies. And we can also perform local research to inform our own policy in our own healthcare system. Another example that I would like to mention here is a trial not in head and neck cancer, but in breast cancer about optimizing the sequencing of treatment. This is the SONIA trial, a phase 3 trial in hormone receptor positive, HER2 negative advanced breast cancer, comparing using the targeted therapy, a CDK4/6 inhibitor in the first line versus in the second line. And the study showed that using the drug in the second line achieve similar overall survival compared with using in the first line, especially for postmenopausal patients. However, when using in the second line, we can reduce cumulative cost and toxicity. So this a very special trial which challenge the concept of always using the most effective therapy first. So when we have robust data on treatment sequencing, we can better optimally use the available resource at our hand. Another approach is evaluating the biosimilars and generic medicines, which has much lower cost to improve access to essential anti-cancer therapy, but also provide solid evidence for the practice. And with those data, I think we have some research directions that can be applicable for LMIC, including conducting pragmatic de-escalation and sequencing trials to reduce cost and toxicity without compromising survival benefit, and performing implementation science and real-world evidence studies, and also integrate health economic evaluation into clinical trials. So with those data, I have some message to deliver. So we have a paradox of cancer care in LMIC. However, with some approach, including dose de-escalation for immunotherapy or triple oral metronomic chemotherapy, we can provide evidence-based but also affordable and feasible care for patients in low middle income countries. Other potential approaches including optimizing treatment sequencing and also evaluating biosimilars and generics, and also implementation science. And with the examples, we can see that context-specific and investigator-initiated research in LMIC is not just possible, but also essential for global cancer equity. So with that, I thank you for your attention, and I'll be happy to receive questions. Thank you.
Thank you very much, Dr. Long, for your valuable insights. And with that, we conclude our first session. And we will be back after the break. And I would like to sincerely thank all the presenters for their excellent presentations and also the audience for joining us. Stay with us.
Good morning, everyone. It's my pleasure to continue our webinar, our summit on head and neck cancers with OncoDaily. It's my pleasure to introduce Amanda Psiri this time. Professor Psiri is Chair of Medicine and Professor of Medical Oncology at Attikon University Hospital, National and Cappadocian University of Athens. Trained at Yale, she has led pioneering work in HPV-driven head and neck cancers and has authored over 200 peer-reviewed publications. Today, she will explore whether less intensive treatment can be used safely in HPV-related oropharyngeal cancer. Please join me in welcoming Professor Psiri.
Thank you. Good morning, everyone, and thank you for joining us. Welcome to this session on head and neck cancer, a field that continues to evolve, particularly with the rising role of human papilloma virus-associated disease. We are fortunate to have a panel of distinguished speakers with us today, and we look forward to an insightful and engaging discussion. I will deliver the first talk, the first lecture on HPV positive oropharyngeal cancer, focusing on de-escalation. The second lecture will be delivered by Imperian Giolese from Istituto Nazionale dei Tumori, Italy. She will speak about concurrent chemoradiotherapy, optimizing dose and agent selection. Dr. Giolese is a medical director at the Head and Neck Cancer Unit in Nazionale dei Tumori Istituto in Milan. Via Mentesidou, a research fellow from Gustave Roussy, will speak about ctDNA in head and neck cancer. Then Dr. Emil Druzik, a medical oncologist from Sarajevo, will talk about HPV-associated oropharyngeal cancer, current management and insights from de-escalation trials. And finally, Dr. Dai Quoc Ngo from Vietnam, a distinguished surgeon, will present the role of surgery in thyroid cancer in 2026. So I will start now with my lecture. Can you see my slide? Yeah. This is the lecture, HPV-driven head and neck cancer, to de-escalate or not. Can you see my screen?
At the moment, we can only see you. Your screen was shared, but then you stopped sharing the screen.
Okay, I will share again, but I don't see here. Can you see them now?
The screen is not shared yet, but yeah, now we can see the slides, yes.
Okay, so I can go ahead. So I will speak about HPV-driven cancers. Here is my disclosure. I will start with an introduction, then present the escalation of systemic therapy in HPV-positive oropharyngeal cancer, the escalation of radiation dose and volume, selection strategies for de-escalation candidates, and finally, new directions. HPV-associated oropharyngeal tumors have a better prognosis and respond better to treatment. Patients with HPV-associated oropharyngeal cancer are younger at diagnosis than HPV negative. The acute and late toxicity of intensive chemoradiotherapy regimens combined with a better prognosis of HPV-associated oropharyngeal cancer gave rise to the concept of de-escalation of treatment for this patient, especially in the era of immunotherapy. Induction therapy is revisited. Novel biomarkers to monitor response to treatment, such as ctDNA, which will be presented later in this session, may allow treatment adaptation in patients with good molecular response to treatment. So, based on a pivotal paper published in New England Journal of Medicine in 2010, prognosis of locoregionally advanced oropharyngeal squamous cell carcinoma depends on HPV status, tobacco use, T-stage and N-stage, and 3-year overall survival ranges from 93% for HPV-positive non-smokers to 46% for HPV-negative heavy smokers. In addition, multiple randomized studies and meta-analyses have reported an up to 66% reduced risk of death in HPV-positive oropharyngeal cancers. Therefore, this data demonstrating the favorable prognosis of HPV-associated oropharyngeal cancer gave rise to the concept of the escalation of treatment in these patients. Late toxicity from combined chemoradiotherapy treatment affects the quality of life of patients with locally advanced oropharyngeal cancer. So the question is whether de-intensifying treatment, reducing the intensity of treatment, can attain similar outcomes with less toxicity. So, several de-escalation of systemic therapy approaches in HPV-positive oropharyngeal cancer have been tested. One of the first strategies is to de-intensify treatment by substituting cetuximab for cisplatin. We know that cisplatin chemoradiotherapy represents the standard of care in locally advanced head and neck cancer. However, late toxicity is substantial. 3 randomized studies were conducted, RTOG 1016 in the United States, de-escalate in Europe, and TROG 1201 study. This TROG study took place in Australia. The 3 studies were randomized phase 3 studies comparing cisplatin chemoradiotherapy to cetuximab radiotherapy in HPV-positive oropharyngeal cancers. The studies have different primary endpoints. RTOG 1016 had as primary endpoint overall survival. De-escalate had toxicity, and TROG symptom severity. We can see here the 3 studies in this table. They had different eligibility criteria. De-escalate included only low-risk HPV-positive patients with locally advanced oropharyngeal cancer. In this study, heavy smokers were excluded. TROG, the Australian study, included low-risk HPV-positive locally advanced oropharyngeal cancer as well, whereas the American study, RTOG, included all HPV-positive patients with locally advanced oropharyngeal cancer, regardless of smoking history. So the standard arm in de-escalate was high-dose bolus cisplatin, day 1, 22, and 43. TROG used a weekly cisplatin, 40 milligrams per meter square, whereas the RTOG used the high-dose bolus cisplatin, days 1 and 22, of accelerated radiotherapy treatment. The experimental arm was the same in the three studies, cetuximab, starting 1 week before the start of RT with a loading dose 400 milligrams per meter square, followed by weekly cetuximab 250 milligrams per meter square. So the radiation scheme was similar in de-escalated TROG. RTOG used the accelerated radiotherapy regimen with 42 fractions over 6 weeks, IMRT. The studies unfortunately showed that all the studies, the three studies, showed that outcomes were worse with cetuximab. So in de-escalate, PFS and OS was worse with cetuximab, the same with RTOG 1016. In TROG study, overall survival was similar in the two arms, but failure-free survival rates were worse with cetuximab. In addition, toxicity was worse with cetuximab in de-escalate and RTOG. In TROG Australian study, toxicity was similar in the two arms. The American study included 849 patients. So it was a big study. So now we know that cetuximab is not an appropriate de-escalation strategy in this patient because it results in inferior outcomes and it does not improve toxicity. So another strategy that has been tested is cisplatin omission. So we can see here NRG head and neck 002. It was a randomized phase 2 trial in HPV positive patients, P16 positive, non-smoking, low-risk patients. These patients received 60 gray of radiotherapy in 6 weeks, the accelerated scheme, with weekly cisplatin for 6 weeks, or received in arm 2, used 60 gray in 5 weeks without cisplatin. The 2-year PFS and 1-year mean composite score with a target of at least 60 on the MD Anderson dysphagia inventory score were the primary endpoints of the study. So we can see here that the 2-year PFS was 90.5% with cisplatin and IMRT 60 gray, whereas with omission with cisplatin, the 2-year PFS was 87.6%. So the reduced dose IMRT and cisplatin weekly was selected for further evaluation in the phase 3 subsequent study of NRG. Another strategy of the intensification is the substitution of cisplatin with immunotherapy. We can see here the different studies testing this approach, substituting immunotherapy substituting cisplatin with immunotherapy. Energy head and neck 005 was a phase 2-3 study in P16 positive patients with favorable prognostic factors, smoking less than 10 pack years, and N3 and T4 disease was excluded. These patients received the standard of care definitive CRT, 70 gray plus high dose cisplatin for 2 cycles in the accelerated radiotherapy RTOG regimen versus reduced dose definitive CRT, 60 gray plus high dose cisplatin for 2 cycles, or reduced dose definitive RT plus IO. Unfortunately, the experimental arms failed to reach the non-inferiority target. Therefore, this approach of substituting substituting cisplatin with nivolumab is not going forward to a phase 3 study. Another approach is radiation therapy de-intensification. So there are different strategies, including reduction of electing radiation doses and volume, reduction of definitive radiation. So this reduction of the doses, volumes, or both is designed either upfront based on favorable clinical, pathological, or molecular prognostic factors, or as treatment adaptation in good responders based on clinical, pathological, or molecular response. So elective radiation dose or volume reduction has been tested in the intensification phase 2 studies with very good results. The Montreal study, phase 2 study, reduced the dose to the lymph nodes and also the volume. They omitted contralateral level 4 and retropharyngeal lymph nodes, and also reduction of the prophylactic dose to the residual uninvolved neck to 43.2 gray, and they used concurrently carbo 5-FU. So they reduced basically the elective nodal irradiation, and the 5-year survival results were excellent, 100%. And also this de-escalation resulted in less acute grade 2 and 3 mucositis in the de-escalation arm. And there are other studies also, such as the LCC 1120 study, that used favorable criteria upfront, light smokers less than 10 pack years, 60 gray RT, plus low dose cisplatin 30 milligram per meter square weekly instead of 40, and also the 2-year PFS was very promising, 86%, with better toxicity profile compared to historical controls of concurrent aggressive chemoradiotherapy regimens. Genomic-based risk stratification has also been tested, and we can see here that upfront, one of the factors to decide the escalation is detectable HPV ctDNA in the blood sample at baseline. So a risk assessment based on ctDNA and clinical factors is performed at baseline, and patients with low risk profile undergo low dose RT, plus minus bolus cisplatin or weekly carbotaxol based induction chemotherapy, and the high risk receive the standard RT and chemotherapy, and the primary endpoint is PFS. In other studies, p53 mutational status and circulating HPV DNA is used as a factor in risk assessment. So in this study, p53 mutational status and past years of smoking is used to allocate patients into treatment arms. The 2-year PFS after the intensified chemoradiotherapy regimen is the primary endpoint. In addition, there are adaptive studies with where treatment adaptation and de-escalation is performed in cases with clinical and or molecular response. For example, in ECOG 1308, which was one of the first de-intensification studies in HPV positive or pharyngeal cancer, a patient received induction chemotherapy for 3 cycles, and those patients with clinical CR received reduced dose IMRT plus cetuximab, whereas patients with clinical PR or SD received full dose IMRT plus cetuximab weekly. And we can see here that the 2-year PFS for all low dose patients was 80%. And the patients with the better outcomes were the light smokers with less than 84 and less than N to C disease that had a 2-year PFS, excellent 2-year PFS. So there are also other studies that base the treatment adaptation or on molecular response and imaging criteria on plasma ctDNA decline, and also imaging criteria. Those that have rapid mid-treatment node shrinkage more than 40% compared to baseline receive de-escalated chemoradiotherapy. In this study, 67% had rapid response, imaging response, and the 2-year PFS between the standard and the escalated groups in this study were 91.7% versus 90.9%. And the patients with recurrence underwent successful salvage treatment, resulting in 2-year OS of 100% for all patients. The OPTIMA study was also a very elegant study where patients with HPV positive disease or pharyngeal cancer received 3 cycles induction with chemo immunotherapy with nivolumab, and those, depending on the response and the shrinkage they have and the upfront criteria, treatment was adapted and accordingly. And we can see the primary endpoint was deeper response rate, more than 50% tumor shrinkage per disease, And we can see here with this treatment adaptation based on upfront and response criteria, excellent 2-year PFS and OS. Another very interesting study is treatment precision radiotherapy based on assessment of hypoxia. Hypoxia is a risk factor, so it identifies aggressive tumors. So pre-treatment PET with hypoxic tracer is used as a selection factor during therapy for treatment adaptation. And we can see here a patient with a baseline FDG PET, and after one cycle of cisplatin and 20 gray of radiotherapy, the PET with hypoxic tracer becomes negative, and this patient undergoes only 30 gray RT with 2 cycles of cisplatin, whereas a patient that has a positive hypoxic PET, after 2 weeks of treatment, they get the standard IMRT with 3 cycles of cisplatin. And we can see here with this approach, excellent PFS, 2-year PFS of 91%. And in terms of toxicity, we can see that no grade 3 to 5 toxicities, late toxicities were reported, which is fantastic for these patients because these patients are younger than the HPV negative patients, and it's important to achieve good outcomes with excellent quality of life. Another approach is the de-escalation and following minimally invasive procedures. So in this ECOG ACRIN 3311 study, patients with P16 positive oropharyngeal cancer, stage 3 and 4, and clinical stage T1, T2, N1, and 2B. These patients underwent baseline functional quality of life assessment and transoral approach with neck dissection, and this then patients were based on pathological risk factors were classified as low risk, PT1, T2, and 0 to N1 with negative margins. These patients had only observation. Arm B, patients that had intermediate risk features, including close margins less or equal to 1 millimeter exanodal extension, and 2 to 4 metastatic lymph nodes, and perineural or lymphovascular invasion in the pathology specimens. These patients were classified, were randomized to receive a reduced dose of the IMRT with 50 gray, 25 fractions without cisplatin, or a radiation therapy, 60 gray 30 fraction, which is the standard of care, the 60 gray 30 fraction for intermediate risk patients. And the high-risk patients, those with positive margins, more than 1 millimeter exanodal extension or more or equal 5 metastatic lymph nodes, received concurrent chemoradiotherapy with cisplatin, 60 gray. So the primary endpoint was to evaluate the 2-year PFS, local, regional, recurrence, functional outcomes, and quality of life in these patients. And we can see here the PFS for eligible and evaluable patients with a median follow-up of 52.4 months. Arm A, that was observation only, had 93.2% rate of PFS. Arm B, that received reduced dose radiotherapy, had 94.9%. Arm C, 90.2%, which was the standard dose of radiotherapy in intermediate risk patients. And Arm D, 85.5%. This is the high risk group, cisplatin chemoradiotherapy. So we can see Arm B and C in intermediate risk patients that treatment de-escalation in this group of intermediate risk patients, de-escalation of radiotherapy, it did not result in inferior outcomes. So what are the challenges that we face with these studies? There is a variability in terms of research design, inclusion criteria, and methodology across trials. How to best select patients for de-escalation studies is a question that remains unanswered. The studies use different endpoints related to disease control and quality of life. And the use of different endpoints complicates the comparison of trials across the literature. There is differences in disease burden across studies, and there is controversy about how smoking intensity and the impact of quitting exactly affects prognosis. There is variations in tobacco thresholds to define low risk across studies. So smoking metrics are variable, and also smoking has not been incorporated in the staging AJCC 8 classification of oropharyngeal cancers. Because it did not retain the prognostic significance after adjustment for other prognostic factors. So the impact of smoking and how to measure smoking intensity is still unclear. So de-escalation is a very important research question. It's very important because quality of life of patients is very important, but on the other hand, outcomes, survival is also extremely important. Therefore, it's still a very interesting research question, but at present, for HPV positive or pharyngeal tumors, cisplatin chemoradiotherapy remains the standard of care. The current evidence suggests that the escalation can improve quality of life while maintaining high cure rates, but it has not cannot be implemented yet to clinical practice because we do not have data from randomized studies indicating that a specific de-escalation strategy is comparable to standard of care in terms of outcomes. How to interpret the different outcomes from various approaches is still unclear, and we need to integrate biological, molecular, and clinical factors at diagnosis and during treatment to better refine the escalation strategies. Thank you.
Thank you so much, Professor Amanda, for such an insightful presentation. Before we move forward, I would like to emphasize that we have audience on our YouTube channel, and one of our audience members actually has this question. I would really like you to also discuss the topic that one of the members is interested in. So the question is as follows. If a patient did not receive neoadjuvant immunotherapy, but is found to have ENE-positive disease after surgery, would you add immunotherapy to standard adjuvant chemoradiotherapy?
So this is a very interesting question. So we are talking about patients that have not received preoperative immunotherapy, and they undergo directly surgery, and they have high risk pathological features such as extranodal extension. So in this patient, we have the results of NIVO post-op study. So this study randomized patients with high risk pathological features after surgery with stage 3 and 4 disease to standard of care cisplatin radiotherapy or nivolumab plus cisplatin chemoradiotherapy and adjuvant nivolumab. And this study met the primary endpoint of improvement in disease-free survival and showed statistically significant improvement in locoregional control. So based on this study, in my practice, I incorporate nivolumab to these patients. However, it has not received approval by the regulatory authorities yet in this setting. But since pembrolizumab is approved, in that case, if you have access to pembrolizumab, I would use pembrolizumab to these patients based on this data.
Thank you so much. This is such a thoughtful response to the question. And at the moment, we don't have any more questions on our live chat. So we are free to continue our summit.
Okay, so we go ahead with the next speaker, which is Imperia Nujolese. Dr. Nujolese is a clinical director in Istituto Nazionale dei Tumori in Milan, Italy, one of the most important institutions in Europe in cancer treatment, and she will present concurrent chemoradiotherapy and how to optimize dose and agent selection.
Let's welcome Dr. Imperia.
So good morning, everyone. I really apologize for being unable to attend the meeting today. However, I remain fully available to answer any question, and please feel free to contact me for any clarification. So first of all, I want to thank the organizer for inviting me to talk about the latest advanced in thyroid cancers. So here are my disclosures and my agenda. So let's start talking about epidemiology. So thyroid cancer's incidence has steadily increased over the past decades, mainly driven by papillary forms, as you can see. In Korea, it has even become the most frequently diagnosed cancers. In contrast, mortality remains low, with a 10-year survival rate around 90%. So this rise is mainly due to overdiagnosis. We can say it's a common disease, but rarely lethal. Thyroid cancer mainly arises from follicular cells, including differentiated subtypes, which are the most common, anaplastic thyroid cancer, which accounts for about 2% of cases. We also have medullary thyroid cancer, a neuroendocrine tumor deriving from parafollicular C cells and representing around 5% of cases. Radioiodine is the first-line treatment for the small proportion of patients who develop metastatic disease, about 10 to 15%. However, around 50% of them become radioiodine refractory. And this is clinically crucial because it dramatically impacts survival. 10-year survival rate is around 92% in iodine-naive disease, but drops to around 10%, as you can see, once the disease becomes iodine refractory. According to the latest data guidelines, timing to start systemic treatment is not triggered by metastasis alone, but by clinically meaningful progression, such as symptomatic disease, high tumor burden, or clear radiological progression. At this point, molecular testing is recommended. In fact, beyond histology, what really matters today is molecular heterogeneity. Different driver alterations have been identified in recent years. They have clarified disease pathogenesis, thus enabling the development of targeted therapeutic strategies. And this suggests a variable degree of oncogene addiction where tumor growth is driven by a single dominant molecular alteration that can be specifically targeted. But in clinical practice, NGS is not always readily available. So what can be suggested? BRAF testing can rapidly be performed by using immunohistochemistry or PCR. If negative, NGS should be considered to identify other actionable alterations, as these are often mutually exclusive. Timing is also critical. Using recent tissue is important as older samples may lead to false negatives. At present, liquid biopsy remains investigational. So speaking about the wild-type differentiated thyroid cancers, as you know, results from prospective randomized placebo-controlled trials have showed the benefit of MTKIs in this population. In this setting, this agent represents the standard first-line treatment, with an overall response rate ranging between 50 to 65% and a median PFS of 18 to 24 months. However, toxicity is relevant and often lead to dose reduction in over 60% of patients, and in some cases leading to treatment discontinuation. Overall, lenvatinib is the preferred first-line regimen due to its higher response rate and longer PFS compared to sorafenib in landmark studies, with response rates around 65%. Its activity increases with dose and is independent of BRAF status, allowing effective treatment even in settings where access to targeted therapy is limited. Despite a modest response rate of 15% and a median PFS of 11 months, reported to be even lower in the pretreated patients, cabozantinib can be considered a preferred agent, as COSMIC 311 is the only randomized study demonstrating a clinical benefit in the second-line setting. Again, a substantial rate of grade 3 adverse events requiring dose reduction was observed even in this study. So how we do classify thyroid tumors today in 2026? We can broadly divide them into two groups: oncogene-addicted tumors, which the actionable molecular alteration enabling targeted therapy, and non-oncogene-addicted tumors. These therapies have reshaped the management of oncogene-addicted disease, showing deep and durable responses, longer PFS, better tolerability, and supporting their use even without randomized data, and often placing them ahead of MKIs, which remain a first-line option. NTRK fusions can be found in various type tumors, much more frequently and somehow pathognomonic in salivary glands and breast cancers. In thyroid cancer, we find them mostly in younger people, where the rates rises up to 26%. Rapid and durable responses have been observed with larotrectinib and entrectinib, regardless of prior systemic therapy. Their ability to cross the blood-brain barrier translates into intracranial activity. More recently, repotrectinib, a next-generation TKI designed to overcome resistant mutation, including the SOVEN front and gatekeeper mutations, has shown promising results. The study included also a small cohort of thyroid cancer with NTRK fusion, and was granted, and this drug was granted accelerated FDA approval in 2024. In general, few patients experience grade 3 to 4 toxicities with low discontinuation rates for larotrectinib in this study. Typical on-target adverse events have been reported, predominantly neurological, reflecting its neurotropism. BRAF alteration occur in about 40 to 60% of thyroid cancers, with around 90% being BRAF V600E mutations. Phase 2 studies have evaluated BRAF inhibitors alone or combined with MEK inhibitors in BRAF mutated DTC, showing response rates of 30 to 38% in the frontline setting. A large international randomized controlled trial of dabrafenib plus trametinib versus placebo, presented at last ESMO Congress, demonstrated a progression-free survival benefit and an overall an objective response rate of 53%. By comparison, I remind the response rates of cabozantinib that in second line that was about 11%. Notably, about 1/5 of the patients were treated beyond second line, while only around 1/3 of them had received prior lenvatinib. So the combination confirmed the known toxicity profile, and these are very interesting results in the second line setting, with a low rate of permanent treatment discontinuation around 6%. Another interesting point is that NTKI may actually be more effective in BRAF mutated patients, as shown in sorafenib and lenvatinib studies, where longer PFS was observed in this subgroup. Therefore, anti-VEGFR agents likely remain the standard of BRAF mutated disease. However, when feasible, clinicians may opt for a specific BRAF inhibitor, particularly when anti-angiogenic therapy carries higher risks, such as bleeding or uncontrolled hypertension. So speaking about RET alteration in differentiated thyroid cancer, I remind you we speak here about RET rearrangement, RET fusions, that can be found in 5 to 10% of cases. In contrast, medullary thyroid cancer is driven by RET point mutations, which activate the MAP kinase pathway and angiogenesis. These are present in up to 85% of sporadic medullary thyroid cancer and may be germline for hereditary and familiar disease, thus requiring universal germline testing. As you know, first-generation RET inhibitors, such as cabozantinib and vandetanib, have limited potency against the RET, especially some mutation like VA804M, but additional anti-angiogenic activity is reported with this drug. In contrast, second-generation selective inhibitors such as selpercatinib and pralsetinib show a higher potency across RET alteration with minimal VEGFR activity. In patients with RET fusion-positive tumors, phase 1-2 trial have shown deep and durable responses with prolonged PFS and favorable safety profile, both in treatment-naive and pretreated patients. Similar results with pralsetinib supported the accelerated FDA approval as first-line therapy in RET fusion-positive differentiated forms. In addition, the Libretto 001 trial with selpercatinib demonstrated very strong efficacy also in medullary thyroid cancer. And so moving to this histology and building on this result, selpercatinib was evaluated in the phase 3 Libretto 531 trial, comparing it with cabozantinib or vandetanib in treatment-naive patients with RET mutant advanced or metastatic medullary thyroid cancer. Median PFS with selpercatinib was not reached versus 16 months in the control group. Again, demonstrated a better tolerability with fewer dose reduction, around 39% versus 80%, and low discontinuation rates, around 5%. Common, mainly on target adverse events include hypertension, dry mouth, constipation, and edema. Notably, emerging data recently submitted by our group suggest a relevant incidence of erythrocytosis around 40%. The overall response rate was 82%, with a notably relevant 19% of completed responses reported, as compared with 43% of overall response rate in the control arm. Similar tumor responses were observed with selpercatinib regardless of the RET alteration. In the largest series of acquired resistance to RET-specific inhibitor therapy available to date, both on-target RET mutations and bypass pathway acquired resistance alteration were found, sometimes polyclonal on molecular profiling of progressive disease. These represent a major challenge necessitating the study of new approaches, maybe ADC or bispecific drugs, in this patient population progressed on first-line RET-specific inhibitor therapy. A brief mention of anaplastic thyroid cancer. Anaplastic thyroid cancer is a rare and highly aggressive disease. Median survival is 6 months with the standard chemoradiotherapy, with the prognosis largely driven by stage at presentation. However, the molecular selection is reshaping management in this disease. In BRAF mutated ATC, the combination of dabrafenib and trametinib is now the standard of care. In this basket phase 2 trial, the overall response rate was very high, around 58%. Nonetheless, median PFS remains limited at around 5 months, meaning you can get very good response with this treatment, but this response won't last. And the impact of the driver mutation, of course, is less pronounced than what we already seen in other histology like melanoma. But this efficacy can enable to operate the patients. And this retrospective study showed that adding new adjuvant BRAF therapy followed by surgery was associated with the longest survival compared with the upfront surgery or no surgery. For non-BRAF mutated disease, the combination of lenvatinib plus pembrolizumab was evaluated in the European ATLEP trial, showing a response rate of 52% and a median PFS and OS of 10 and 11 months respectively. A recent US study confirmed the survival benefit in ATC, albeit with the lower response rates and PFS. Despite being based on the single-arm data, the magnitude of benefit compared with historical outcomes supports the combination as a preferred systemic option in metastatic genomically unselected ATC. Moreover, using BRAF inhibitors can immunomodulate tumor environment, and combination of vemurafenib and cobimetinib with atezolizumab resulted in 43 months median overall survival in BRAF mutated patients, which is quite impressive for this very high aggressive histology. So, where are we heading? So, building on promising response rates of targeted therapy that I showed you today, there is a growing interest in upfront systemic therapy to downstage initially unresectable or borderline resectable thyroid cancers, as well as high-risk thyroid cancer. In addition, a number of ongoing trials, this is an updated table I made for you today. These ongoing trials are exploring similar upfront strategies across different histology and molecular targets. There is also the emerging concept of radioiodine redifferentiation. In iodine refractory disease, targeted therapies may restore iodine uptake. This is not yet standard practice, but is being explored in ongoing trials. The rationale is that oncogene-addicted thyroid tumors have a MAPK pathway hyperactivation, which suppresses NIS expression and iodine uptake. By inhibiting this pathway with targeted agents, NIS expression can be restored, potentially reducing radioiodine sensitivity. So my take-home message, molecular tests should be considered at the time of radioiodine refractoriness. Therapeutic options are still limited in wild-type thyroid cancers. Selective inhibitors show to be effective and generally well tolerated, but there are no comparative phase 3 trials that compare these inhibitors with MKI standard of care. So treatment sequencing in oncogene addicted still need to be defined, even if therapeutic landscape is shaped by national reimbursement policies in real clinical practice. And so I really thank you for your attention, and I repeat, I'm available for any question and clarification. Here my contact. So thank you.
Thank you so much. Thank you so much, Dr. Imperia. We continue our session with Dr. Vaya Mentesidou. Dr. Mentesidou is a medical oncologist and research fellow at Institut Gustave Roussy in France. Please join me in welcoming her here.
Can you see me properly and hear me properly?
Yes, Dr. Vaya, we can see you and your presentation, so we are good to go.
Excellent. Thank you so much to OncoDaily for this invitation. It really is an honor for me to be amongst you here today. So my presentation will be on the role of circulating tumor DNA or ctDNA in head and neck cancers, with a little bit more focus on minimal residual disease detection and treatment monitoring towards the end of my presentation. So as we know, head and neck cancers constitute a global health issue with almost 1 million new cases globally annually and 500,000 deaths. And despite recent advancements in surgery, radiotherapy, or systemic treatments, we do know that recurrences still remain high, which highlights the need for biomarkers that are sensitive and dynamic in order to improve disease monitoring and early detection of relapse. So currently, post-treatment surveillance relies heavily on clinical examination and imaging techniques, such as a PET-CT scan. However, we do know that these techniques contain certain limitations, such as the delayed detection of recurrence or the low sensitivity for minimal residual disease detection, that is MRD detection. So again, there is a growing interest for minimally invasive biomarkers that can provide real-time insights into tumor dynamics. Now, when we refer to liquid biopsy, it actually refers to the analysis of tumor-derived material from blood and other body fluids. This contains circulating free DNA, circulating tumor DNA, circulating tumor cells, and extracellular vesicles like exosomes. And I would say that out of all of this, perhaps ctDNA constitutes the most clinically relevant biomarker to date in oncology, since it has the ability to reflect real-time tumor burden and also give insights into molecular characteristics, exactly because of the fact that it has this short half-life ranging from 60 minutes to 2.5 hours. So cfDNA is the extracellular double-stranded DNA in the blood, and ctDNA is the DNA part that is released from tumor cells into the bloodstream, so it is a component of cfDNA. We know that both ctDNA values and cfDNA values can vary. For example, cfDNA is not tumor-specific, unlike ctDNA, meaning that elevated levels can also present in non-malignant situations, such as in the case of exercise, infection, or trauma. On the other hand, ctDNA values can also vary, beginning from below 1% of the total CF DNA values, especially in the cases of earlier stage tumors where the DNA shedding is low, but they can reach up to 90% of cfDNA in some studies. And it is also worth mentioning that values can also vary depending on the primary tumor localization. For example, there have been studies suggesting that in cases of a primary renal, brain, or thyroid cancers, the ctDNA values can be lower compared to other primary tumor localizations, exactly because of the fact that we have those physiological anatomical barriers. So now to begin with the HPV positive oropharyngeal carcinoma and ctDNA in that setting. There is this proof of principle study where liquid biopsy is actually feasible in head and neck cancers, and in this diagnostic setting, the detectability of ctDNA in the saliva seemed to vary based on the anatomic localization of the tumor. And as we can understand, the highest sensitivity was observed for the oral cavity cancers. On the other hand, the detectability of ctDNA in plasma varied much less on the basis of the tumor's anatomic localization. And if we combined the two assays, that is, from the two compartments, sensitivity was actually even higher without compromising specificity, exactly because of this innate nature of HPV DNA, the fact that it is very specific and it is quite unlikely that it can be observed in cases outside the existence of disease. If we move to the disease treatment setting, there are here several studies that have demonstrated that HPV ctDNA levels decrease rapidly during treatment in responders, while persistent or even rising levels are associated with poorer outcomes. However, in this setting, we should be cautious of the fact that there might even be a transient increase in ctDNA values, the so-called spike, ctDNA spike. For example, in this study, this was observed at week 2 of CRT, and this can be attributed perhaps to tumor lysis. However, the key determinant in this situation is the sustained clearance of ctDNA over time, and it is to be highlighted that longitudinal ctDNA monitoring is to be advised rather than the single ctDNA measurements. And now moving towards the post-treatment surveillance setting, again in the HPV positive population. In this study published in the JCO, we can see that 2 consecutive cDHPV DNA tests could identify patients with a high risk of recurrent disease with a positive predictive value of 94%. And increases in cDHPV DNA actually preceded the biopsy-proven recurrence in most patients with a median of approximately 3.9 months. Which leads us to the thought that perhaps a good interval for testing for cDHPV DNA might be 3 months. However, this is not yet validated and remains to be further checked into literature, especially in the context of translational research, which, as we can see, we have a lot of translational research going on. Like, for example, in the case of this systematic review, which showcased that ctDNA monitoring has a high negative predictive value of 91.7% for detecting residual and recurrent disease. And I do think it is worth mentioning, again, in this setting, the post-treatment surveillance setting, that in this study based on data from the top 10 cancer centers in the United States in 2021, the use of ctDNA was actually the lowest cost surveillance strategy, which is something that might be useful to us in future studies and also with regards to the regulatory context. Now, we understand that cDHPV DNA can actually provide clinically relevant information across the entire disease spectrum, as we can see, from screening and diagnosis to treatment response and post-treatment surveillance. However, there is currently no validated strategy for treatment adaptation based on the cDHPV DNA levels. And now moving to the EBV DNA and nasopharyngeal carcinoma, I would say that the only head and neck cancer subtype where a ctDNA-based biomarker is integrated into clinical guidelines is nasopharyngeal carcinoma through the use of EBV DNA. And now in this study published in the New England Journal of Medicine, we can see that nasopharyngeal carcinoma was actually detected earlier. And in fact, consequently, outcomes were also better in participants where it was identified by screening using EBV DNA. And if we move to the disease treatment setting, in this prospective multi-center randomized controlled trial, we can see that post-treatment EBV DNA levels strongly correlate with the risk of locoregional recurrence, distant metastasis, and death. However, the EBV DNA-guided adjuvant chemotherapy did not manage to improve relapse-free survival in the study, despite the accurate risk stratification. However, there are several reasons that might attribute to this result, given also the type of chemotherapeutic regimen used. And one might argue that since EBV DNA is now detectable, micrometastatic disease already exists, meaning that a subclonal evolution has already taken place and disease may now be even less chemosensitive compared to previous disease stages. Again, in this type of tumors, there is a growing body of literature, including, again, systematic reviews, which do support the prognostic and monitoring value of EBV ctDNA in head and neck cancer. However, most data remain observational with limited prospective interventional evidence. And I would say that in HPV negative head and neck cancers, ctDNA detection is, as we can understand, a little bit more complex because there is no one universal biomarker that can be used, unlike all those previously mentioned virally mediated tumors. which means that ctDNA detection relies on mutations such as TP53, which even though technically feasible, their detection can vary a lot, especially in the early disease setting, where again the tumor shedding is much lower. So we understand that more recently we have tumor-informed assays, such as personalized ctDNA platforms like Signatera, which have been developed and do show improved sensitivity. However, the integration into clinical practice still remains. And moving to the MRD-guided clinical trials in head and neck cancers, there are a lot of ongoing trials that evaluate ctDNA for early detection of relapse after curative treatment, as we can see. And I would say that one important trial worth mentioning is the SYNODY trial, which is a phase 2 study and is actually one of the first interventional studies demonstrated that ctDNA dynamics can actually guide treatment adaptation in head and neck cancer. In this study, 74% of the participants underwent de-escalation chemotherapy, and the objective response rate was 63%, which much less toxicity compared with historical cohorts. And if we move to the area of immunotherapy in head and neck cancer, since, as we know, immunotherapy constitutes now the standard of care in recurrent and metastatic disease, following several trials such as the KEYNOTE-048. We can see again here that ctDNA negativity during IO treatment is significantly correlated with improved OS and PFS. However, we should be taking several other parameters into account in this setting, and I will refer to them in a little bit towards the end of my presentation. So we understand that the key strengths of ctDNA in head and neck cancers right now are the fact that it's a minimally invasive approach, that it can allow for real-time disease monitoring and give us the opportunity to detect relapse early, and that it has a strong prognostic value that has been demonstrated, especially in the HPV and EBV positive cancers. However, we do have some challenges that remain. For example, to begin with, assay sensitivity and standardization. There are no yet standardized thresholds that we can use, and there are a lot of assays that can be used, like for example, quantitative PCR, digital droplet PCR, NGS. So of course, we can decide on which assay to use based on the clinical context and the clinical scenario. For example, in the case of the viral mediated head and neck cancers, we can use like the digital droplet PCR, or in cases where we have a lot of mutations and unknown alterations, NGS might be a better choice and more fitting for this in this clinical scenario. There is also the issue of tumor heterogeneity, which is inter and intra-tumor heterogeneity. And again, this is especially important in those HPV negative head and neck cancers. There is also the temporal evolution that takes place under treatment, and heterogeneity between the primary and the recurrent or metastatic sites. ctDNA can perhaps solve the heterogeneity issues between the primary and the recurrent or metastatic sites perhaps a little bit better compared to tumor tissue biopsies. However, this still needs to be solidified with further research and research that is mainly conducted in the form of prospective randomized trials. And again, we have limited detection in those low-shedding tumors, that is the early stage disease. We also have timing and sampling frequency issues. These are not yet established. And also barriers with regards to the clinical implementation, for example, accessibility to these assays and platforms, cost consideration and turnaround times, and again, the regulatory context. And I think it is also important to note that there is no proven survival benefit from those ctDNA-guided interventions because of the fact that we have a lack of prospective randomized trials. So we can see where the research focus can head a little bit more in the future. And just to quickly mention, because before I reach my concluding remarks, we do understand that now we're talking about the hallmarks of systemic disease, which means that even the evaluation of ctDNA values should be conducted within the context of several other parameters being taken into account, like, for example, in this study, as we can see by the group of Professor Psiri in Athens, Greece. For example, the tumor microenvironment plays an important role, especially when we refer to ctDNA values in the context of immunotherapy treatments. So we can understand that ctDNA MRD monitoring could be even better integrated with complementary biomarkers such as PD-L1 expression, tumor mutational burden, and clinical and other laboratory parameters which are yet to be established. And I would say also with, in concordance with the radiographic evaluation that already takes place, for example, with the PET-CT scans, and also the fact that in cases where we have equivocal PET-CT scan results, perhaps ctDNA might help solve these issues. And since we're moving into the era of artificial intelligence in oncology in general, but also in head and neck cancers, perhaps artificial intelligence-powered techniques could also help, of course, in a complementary manner alongside radiographic evaluation that already takes place and ctDNA monitoring. So to conclude, the strongest evidence to date we understand that exists in those virally driven tumors, the HPV or EBV DNA tumors, and that performance remains limited in those HPV negative tumors because of the fact that they exhibit a lot of biological heterogeneity with a lot of mutations. And we understand that ctDNA is currently considered prognostic, but it is not able yet to allow for treatment guiding decisions to be made. It is not yet fully integrated into clinical practice guidelines, but it is a promising biomarker for disease monitoring and for minimal residual disease detections. And of course, we need more prospective trials to take place in order for us to reach safe conclusions with regards to the clinical utility of ctDNA and how we can actually use it and implement it into our everyday clinical practice. So with that, I would like to thank you very much.
Thank you so much, Dr. Vaya, for the presentation. That was very interesting and insightful. And again, we have one question from our audience on YouTube live chat. If you don't mind, I will ask the question to you, and please elaborate a bit more about the topic that our audience is interested in. So they are wondering what the main barriers are currently limiting the clinical implementation of ctDNA in head and neck cancers.
Mm-hmm. So I would say that I touched a little bit on that during the presentation, but of course, to just repeat a little bit more, of course, and try to elaborate on this a little bit more. So we have a lot of studies based on translational research that are retrospective studies. I too participate in my current workplace in several translational researches with regard to this. But we do understand that we do have a lack of prospective randomized clinical trials that will give us a real understanding of both the biology, but also of how we can integrate ctDNA into the clinical practice, meaning that we do not yet have survival data that are validated enough for us to use them so that we can change our minimal residual disease detection techniques and conduct what we call MRD guided treatment adaptation. So we do have evidence, especially with regards to the EBV nasopharyngeal carcinoma, that's why it is also integrated into clinical practice guidelines, that EBV DNA, ctDNA testing is actually useful. It can guide the post-treatment surveillance techniques. So this comes from a lot of validated cohorts with and several trials with big populations. But this is what is lacking in the context of the other viral-mediated head and neck cancer, and also, most importantly, in the case of the non-virally mediated head and neck cancers. So I would say that reproducibility exists in the EBV DNA cohort, but we do not have yet enough data with regards to the reproducibility for the other types of head and neck cancer. So what we need is the more prospective validated clinical trials so that we can actually integrate ctDNA into all those different treatment stages, beginning from screening to diagnosis to post-treatment surveillance techniques. And I would say that the most intriguing out of all the questions with regards to ctDNA in head and neck cancers is how we can manage to move towards the change in treatment decision making based on the ctDNA values. Again, for example, here we're currently conducting a systematic review on intensification and deintensification strategies based on all those markers like cfDNA, ctDNA, HPV DNA, EBV DNA in localized and locally advanced head and neck cancer. So I do believe that translational research is the beginning of the understanding of the issue and might help shed some light into some issues that are not yet fully understood, especially within the biological context. But then we also need more trials that will address the issue of MRD-guided ctDNA-based treatment adaptations.
Thank you. Thank you so much. And thank you for your time and dedication in contributing to our summit. And with this continuation, I would like to introduce our next speaker, who is Dr. Amil Družić. Dr. Amil Družić is an oncology and radiotherapy specialist at the Oncology Clinical Center, University of Sarajevo in Bosnia and Herzegovina. He will present insights from de-escalation trials in HPV-related oropharyngeal cancers. Dr. Amil, the stage is yours.
Hello everyone, my name is Amil Družić, and today I will talk about how HPV-associated oropharyngeal cancers are a success story because many patients are cured. But cure creates a second problem. Patients may live for decades with dysphagia, xerostomia, fibrosis, hearing loss, dental injury, and the memory of a feeding tube. So the question is tempting: can we do less? Today I want to be disciplined. First, I will anchor current standard treatment, then we will ask which de-escalation strategies have survived testing, which have failed, and which should remain inside trials. So let's start this lecture with a case report. A 50-year-old never smoker with P16 positive and high-risk HPV confirmed right tonsil cancer, clinical stage T2N1M0 1 2.4 centimeters ipsilateral node, no radiographic external extension or meta nodes, excellent performance status, normal renal and hearing status, and intact swallowing. So as you see, this is the kind of patient who makes de-escalation feel logical. But the case also keeps us honest. Our job is not to make the treatment look smaller on a slide. Our job is to preserve cure while reducing meaningful long-term injury. For the first half, we will decide what standard management would be, and for the second half, we ask which trials gives us permission to change the standard. So, standard treatment is not a single modality, it is a sequence of decisions. First, confirm that this is truly HPV-associated oropharyngeal cancer. Second, stage and risk stratify. Third, choose the definitive radiation-based pathway or a surgery-first pathway. Fourth, if surgery is chosen, use pathology to decide observation, radiation alone, or chemoradiation. Fifth, build survivorship into the plan from the beginning. The last point matters because late toxicity is the whole reason de-escalation exists. The first standard treatment step is diagnosis and risk. De-escalation trials become dangerous if they enroll or are applied to the wrong biology. In oropharyngeal squamous cell carcinoma, P16 immunohistochemistry is the usual surrogate for most non-cytologic tissue specimens, but high-risk HPV-specific testing should be added for cytology or FNA material, equivocal or discordant cases, atypical presentations, low HPV attributable settings, and trial eligibility when HPV-specific information is required. So for the new 2026 and later cases, use the new classification, the version 9, for HPV-associated oropharyngeal squamous cell carcinoma. So we do not stop at stage, T category, nodal burden, node size, smoking history, comorbidity, and baseline functions all matter. For a surgery first plan, we must also estimate exposure, margin probability, and the chance that the patient will need adjuvant chemoradiation anyway. My practical line is low risk label is earned, not assumed. So the second standard step is the pathway decision. I like to phrase it in this way. The real choice is not radiation versus surgery, it is whole treatment package. A definitive radiation-based pathway may involve RT alone for selected lower risk patients or concurrent cisplatin for higher risk disease. A surgery first pathway may be excellent when the primary can be safely removed transorally when pathology will allow observation or reduce adjuvant therapy. But if surgery is likely to be followed by full dose postoperative chemoradiation, the patients may have received trimodality treatment, not de-escalation. That is why the tumor board question before surgery should be, what is the likely adjuvant treatment? Now the definitive radiation-based standard. For patients receiving definitive RT with concurrent systemic therapy, the recommended dose to gross disease is 70 grays in 33 to 35 fractions. When concurrent systemic therapy is indicated and the patient is eligible, cisplatin remains the preferred agent. Concurrent systemic therapy is recommended for T3 or T4 disease, multiple positive nodes, or a single node larger than 3 centimeters. Radiotherapy alone is appropriate in selected lower risk settings, such as a T1 to T2 node negative disease or T1 with a single small node. T2 with a single small node requires individualized judgment. The planning standard is IMRT including VMAT, with serious attention to dose reduction to swallowing structures and salivary glands. The key point, definitive standard treatment is not outdated. It remains the benchmark because the oncologic results are excellent. The surgery first pathway is not simply a different treatment. It is both a treatment and a staging event. Transoral surgery and neck dissection can identify low-risk patients who may be observed, intermediate-risk patients who may receive postoperative radiation, and high-risk patients who need postoperative chemoradiation. The pathology report is where the promise and danger of surgery first management becomes visible. It is most attractive when surgery allows less adjuvant therapy. It is risky when the patient undergoes surgery and then still needs full intensity postoperative chemoradiation. This is the postoperative standard baseline. So in selected PT1 to PT2 disease with a single small node, no extranodal extension, and no other adverse features, observation can be considered. So postoperative radiation is recommended for higher pathologic burden such as pathological T3 to pathological T4 disease, more than 2 nodes or a single node larger than 3 centimeters. Close margins, perineural invasion, and lymphovascular invasion often lead to individualized postoperative RT decisions. The highest risk findings are positive margin, defined as a tumor on ink, and extranodal extension. Those usually trigger postoperative radiation with concurrent cisplatin if the patient is eligible. So this baseline matters because many de-escalation trials are really trying to move patients from the red or amber zones into a lower toxicity treatment without losing cure. So the argument is not the treatment is inconvenient. The argument is that cured patients can live for decades with swallowing impairment, xerostomia, dental complications, fibrosis, hearing loss, neuropathy, fatigue, and altered speech or identity even. But the right response is not immediately to drop proven therapy. The first response is to deliver standard therapy well, high quality IMRT, including VMAT, careful organ and risk sparing, dental evaluation, of course, swallowing therapy, nutrition, pain control, and long-term rehabilitation. De-escalation only becomes legitimate after we have optimized standard treatment and still ask whether some patients can safely receive less. So today's green zone is careful HPV confirmation, staging, multidisciplinary selection, and high quality delivery of either definitive RT or surgery first management. The amber zone is individualized. Early definitive RT alone, T2 disease with a single small node, closed margins or perineural invasion and lymphovascular invasion after surgery, and systemic therapy choices for cisplatin ineligible patients. So the red zone is what we should not call standard de-escalation. Cetuximab substitution in fit cisplatin eligible patients, routine 60 grade definitive chemoradiation outside a trial, and surgery first treatment without thinking through the likely adjuvant therapy. Now we can ask which trials justify moving anything from amber into green. So as you can see here, the de-escalation literature only makes sense if we sort it by mechanism. Systemic substitution asks whether we can replace cisplatin. Definitive dose reduction asks whether less radiation is enough in favorable disease. Surgery plus pathology asks whether transoral surgery can identify patients who need less adjuvant treatment. And biology-guided selection asks whether PET or blood biomarkers can identify exceptional responders. And also the trials differ by P16 or HP testing methods, smoking cutoff, the staging additional nodal burden and endpoint. The cleanest negative story is cetuximab. RTOG 1016 showed that cetuximab was inferior to cisplatin with worse overall survival, worse progression-free survival, and higher local regional failure. De-escalate HPV was especially important because it was designed around the toxicity argument. Severe toxicity was not meaningfully reduced, while survival and the recurrence was worse with cetuximab. The TROG 12.01 reinforced the same point. Failure-free survival was worse, and symptom burden was not improved. So for cisplatin-eligible patients, cetuximab should not be present as de-escalation. The substitution looked gentler, but the full treatment strategy was not safe. Next, we're going to take a look on the HN002 trial. It was a randomized phase 2 trial in good risk P16 positive disease. The 60 gray plus weekly cisplatin arm met pre-specified progression-free survival and swallowing criteria, but the radiation alone arm did not. All of that led to the HN005 trial that reset expectation. The control arm used 70 gray over 6 weeks with every 3 weeks cisplatin and had a 2-year progression-free survival of about 98%. The experimental arms used 60 gray with cisplatin or 60 gray with nivolumab. Both failed non-inferiority and crossed futility boundaries. So we can't say that routine 60 gray definitive chemoradiation is a new standard, and favorable HPV positive disease is not enough selection by. But the most encouraging part of the field is postoperative pathology selected de-escalation. But the word selected is doing the real work. The E3311 is the anchor. After transoral surgery, carefully selected intermediate risk patients randomized to 50 or 60 gray. postoperative RT. They had excellent 2-year progression-free survival, around 95% in the 50 gray arm. PETOS is the important ongoing phase 2 to 3 trial testing reduced adjuvant intensity after transocular surgery, and the Mayo DART program, including MC1675, is randomized phase 3 toxicity positive signal for 30 to 36 gray with docetaxel compared with standard adjuvant treatment, but selection and institutional context matter. MINT adds encouraging non-randomized contemporary support for risk-directed postoperative intensification. And the key is not surgery alone, the key is pathologists selecting who can safely receive less afterwards. So this is not a blanket rule for all postoperative HPV positive oropharyngeal squamous cell carcinoma. So now we have Orator 2 that compared de-escalated radiotherapy and the transocular surgery-based approach. It was stopped early after treatment-related deaths in the surgical arm. In the later primary analysis, the RT arm had 2-year overall survival and progression-free survival of 100%, while the transocular surgery plus neck dissection arm had 2-year overall survival of 90% and progression-free survival of 86%. The trial is a small and incomplete trial, so we should not overgeneralize. But its safety message is powerful, and that means surgery is not automatically de-escalation. So transocular surgery can be a route to less treatment only if it avoids or reduces adjuvant therapy. It is not less treatment by definition. I would honestly say that the frontier is biology-guided de-escalation. F-MISO uses fluoromizonidazole to image tumor hypoxia. In the Memorial Sloan Kettering phase 2 study, patients first had surgical removal of the primary site, but gross nodal disease remained. Baseline and early inter-treatment F-MISO PET were used. Non-hypoxic tumors received 30 gray with chemotherapy. Hypoxic tumors received 70 gray. The 2-year local regional control met the pre-specified target, and toxicity was lower in the 30 gray group. Second, the FDG PET adaptation is also maturing. The University of Michigan phase 2 approach used baseline and fractioned FDG PET, and patients with at least a 50% metabolic tumor volume reduction were de-escalated to 54 gray. Third, the circulating HPV DNA is promising for risk and surveillance, but is not yet a standalone reason to omit adjuvant therapy. Postoperative negative circulating HPV DNA omission strategy closed early because of a high gross recurrence rate. The big idea is that PET and biomarkers ask about biology, not just anatomy, but they still require protocol-defined validation. So let's get back now to our case from the beginning of the lecture. For the 56-year-old never smoker with clinical T2, N1, P16 positive and high-risk HPV confirmed tonsil cancer, I would first confirm biology and risk, then discuss standard pathway choices. Definitive radiation-based treatment and surgery-first treatment may both be reasonable depending on anatomy, nodal details, patient priorities, and institutional expertise. But I would not offer failed shortcuts like cetuximab, substituting cisplatin for fit patients, and no routine definitive 60 gray chemoradiation outside the trial. If surgery is chosen, the adjuvant plan must be discussed before the operation. If a clinical trial is available, especially one with pathology selection or biology selection, it may be appropriate. The patient-facing phrase must be, we are not trying to give less treatment, we are trying to give the right amount of treatment. And we are slowly concluding our lecture with our takeaways. First, standard treatment comes first. We cannot interpret de-escalation without knowing the correct comparator. Second, do not use shortcuts that lose cure. cetuximab substitution failed, and HN005 reset the benchmark for definitive dose reduction. Third, precision selection is the future, but routine de-escalation remains unsafe unless supported by major evidence or strict protocol-defined selection. The most promising directions are pathology-guided postoperative treatment, PET-guided response or hypoxia selection, and carefully validated blood biomarkers. And my final line is the goal is not less therapy. The goal is the least toxic therapy that still protects the cure. Thank you very much. Here are the major de-escalation trials that were mentioned in the lecture, and also key references that were used for this lecture. Thank you for your attention, and I would like to thank OncoDaily for inviting me to speak about this important topic. I'm sorry that I cannot be live with all of you today, and until next time.
Thank you, Dr. Družić, for the time and for your contribution to our summit. And we continue with our next speaker, Dr. Duy Quoc Ngo, head and neck surgeon at the National Cancer Hospital in Hanoi, Vietnam. Please welcome him. Dr. Ngo, I think you're on mute from your side. Please unmute yourself and we can hear you. Unfortunately, we cannot still hear your voice. And would you please unmute yourself? I'm sorry. I'm sorry to tell you, but unfortunately, we can't still hear you. Maybe you can work on your privacy settings on a computer for microphone, if you can hear me.
Can you hear me? Perfect. Hello everyone, my name is Ngô Quốc Duy. I am a head neck surgeon from Vietnam National Cancer Hospital. First, I would like to sincerely thank OncoDaily for the kind invitation. Today is my honor to speak about the role of the surgery in thyroid cancer in 2026 and the experience of transoral endoscopic thyroidectomy in Vietnam. Today, I would like to focus on differentiated thyroid cancer. For DTC, surgical is the main treatment. Dry is used in selected patients, mainly in the higher risk cases. TS suppression therapy has reduced the recurrent risks. In recent years, active surveillance is an option for small, low-risk tumors, and also thermal ablation is a new, minimally invasive option for the highly selected patient. According to ATA Guidelines 2025, uh, about recommendation 11, active surveillance may be offered as an appropriate management option for some patients with CT1A and 0 M0 PTC. And for patients undergoing active surveillance, NAC ultrasound should be used to monitor disease progression. So how? Surgery when um, in patient undergoing active surveillance, surgical option is indicated if there is an evidence for new biopsy-proven lymph node metastasis, growth of the primary tumors by more than 3 millimeters, distant metastasis, or evidence of extrathyroid extension. How about the ablation? According to ATA Guidelines 2025, thermal ablation um, has been studied and as a primary treatment for low-risk PTC in carefully selected patients. And also selected criteria are similar to those employed for active surveillance, and also patients who are uncomfortable with active surveillance or with surgery may be prefer ablations, you know. And regarding surgery, this is the main treatment for the thyroid cancer. There are four types of thyroidectomy, as shown in the finger. However, in the clinical practice, only two procedures are used for treating thyroid cancer: lobectomy or total thyroidectomy. According to AT guidelines, the extent of surgical depends on the clinical stage. For small unilateral tumors such as a T1 and T1 and 0, lobectomy is usually enough. For bilateral disease, total thyroidectomy is recommended. In T2 tumors, uh, we can consider either lobectomy or total thyroidectomy, depends on the case. However, for more advanced disease such as T3, T4, or when there were lymph node or distant metastasis, total thyroidectomy is the standard approach. Another important point is surgical experience. According to AJ guidelines, high volume surgeons have lower complication rates and better outcomes. Regarding to prophylactic central neck uh, it should not be routinely performed in T1, T2s, and C and 0. About surgical approaches, there are two main options. The first is conventional open thyroidectomy, which is still the standard approach. The second is remote access thyroidectomy, which avoids a neck scar and is increasingly used in the selected patients. Regarding to the indications for this technique, according to the consensus from six major surgery societies worldwide, from ATA to the American Head and Neck Society and APTES. First, surgeons should be high volume. The second, patient selection is a key, and this approach is suitable for small, well differentiated tumors without extrathyroidal extension. However, it's not recommended for advanced or aggressive disease. So overall, good outcomes depend on both surgeon experience and careful patient selection. As all you know, TREDVA has many advantages. It's safe, provides a shortest access approach, allows a total titany and central neck dissection also, and also provides an excellent cosmetic outcome with no scar on the skin. And this is a photo after total titany with central neck dissection. Here's some patient. Here's some pictures of the patient after surgery, and all patients are confident after surgery. And we have performed more than 1,500 cases with TREDVA. A meta analysis of over 1,025 cases compared to more than 1,800 open surgeries show that TREDVA is safe for both benign and malignant thyroid disease. Importantly, it provides medical cosmetic outcome. Compared with the other approaches, such as the Gallus accelerator, PAPA, retroauricular techniques, the transoral approach offers several advantages. For this reason, it has become increasingly popular since 2016. Today, I would like to emphasize my modified 12 technique. I believe it can shorten operative time and reduce post-operative complications. In the traditional technique, we had to use the varus leader and a stick, special stick, and this often causes significant pain for the patient. We can also found that injecting the large amount of saline made create working space more difficult. In our modified technique, we no longer use any sticks and we do not inject any solution to the submental or neck area. This makes the procedure simpler, faster, and more comfortable for the patients. More important step, you can see in my modified techniques in the insertion of the center trocar. Now I only use the scalpel to make a small incision to the muscle of the oral vestibular. Then I use a forceps as shown in the video. With this modification, I believe the risk of mental nerve injury is very low. In contrast with the previous technique, you can see the mental nerve could be injury more easily. Yes. Next, the strap muscles were divided in the midline, and the isthmus was divided from the superior to inferior. Next, the harmonic scalpel was then used to divide to the superior thyroid vessel. Yes, you can see our technique in the in this video. In this step, we use a harmonic scalpel to cut the muscle and also divide the superior thyroid vessel. Yes, after that, we identify the recurrent region. Yes, this is recurrent region. And after that, we perform thyroidectomy with preserving parathyroid glands and recurrent region. Our modified 12 technique has been published. And this is a post-operative photo of the patient who underwent modified 12. I hope that in the future, Every medical center can perform this modified TFR technique without the need of for the special instruments. Next, I will present the results of our technique in more than 600 thyroid cancer patients. The average age was about 33 years old, including the about 20 PRH patients, and most patients were female. There are two types of surgery, lobectomy and total thyroidectomy, with most patients undergoing lobectomy regarding post-operative staging. Most patients were PT1A. There were 65 patients with PT1B and only 6 patients with PT3B. And the surgical time has decreased over time. Initially, lobectomy took less than 1 hour and a half. With more experience, the procedure now takes about 1 hour, and the patient will discharged about just 1 or 2 days. Regarding the complication, to advise is safe. No patients require conversion to open surgery. No patient had bleeding. No patient experienced permanent recurrent narrowing nerve injury or permanent hypocalcemia. About 5% of patients had temporary recurrent narrowing nerve injury. Around uh, about 15 patients have temporary hypocalcemia, which recover within about 1 month after surgery. And the rate of temporary maintenance nerve injury was about 3%. This is a special complication of this approach, but the rate has decreased as we have improved the technique, and there were no case of permanent nerve injury. Therefore, this is the safe procedure. Regarding the oncologic outcomes, we observed only one recurrence. This was a right neck recurrent occurring uh, eight, 18 months after surgery. Next, I would like to talk about the 12 with the neck dissection. After controlling the technique, we perform the trans-auto endoscopic approach to modify radical neck dissection for PTC and 2020. In 2020, I underwent total thyroidectomy, center neck dissection, and modified radical neck dissection via the trans-auto endoscopic approach. However, in my view, dissection of level 2 lymph node via trans-auto approach is very difficult due to the limited surgical view. On the other hand, the trans approach provides better exposure, making the level 2 lymph node dissection more feasible. Hence, I decided to combine the trans-auto approach with the trans approach to the neck dissection. We decide to combine the both approach. And this is slideshow the location for inserting trocars in the combined endoscopic approach. We continue exposing the right level 2 neck lymph nodes. Yeah, sorry. You can see the chest approach can help the surgeon to perform level 2. We continue the dissecting the plan between the internal ganglion and the SCM measure until the posterior belly of the digastric muscle was exposed. After that, we continue the right level 2 neck lymph node. And after that, the accessory nerve was identified and exposed. And also the internal ganglion was exposed. Lymph node, as shown in the video. Yes. Yes. For the transfer approach, we can dissect level 3 for neck lymph nodes. You can see in this video. The right phrenic was identified and preserved. The right phrenic nerve was identified and preserved. And after that, we continue removing lieutenant level 3, 4 neck lymph nodes. And after that, the right transverse cervical artery was identified and preserved. Yes. Okay, you can see. After that, we continue checking after total thyroidectomy, central neck dissection, and right level and for modified radical neck dissection. And after that, we continue checking after surgery, and a drain was placed. Yes. After that, and the patient was good after surgery. And 60 patients were performed neck to neck dissection. One of them had a leak after surgery. Use endoscopic instruments through the small 1.5 skin incision to grow it with good results. And I believe that this may be an effective approach for managing high leakage after endoscopic thyroidectomy. Yes, it was good. About the modified reconnect dissection via TEDVA, open surgery is still a standard approach for modified reconnect dissection, and also modified reconnect dissection via the transoral approach is technically very challenging. A new direction combine the transoral and the trans approaches, and this technique is only for the careful selected patient. And endoscopic modified reconnect dissection should be performed by only by high volume surgeons with experience with TEDVA. Next, I would like to show some different case I have been performed. And the first case is a cancer patient with a tumor invading the reticular nerve. We're trying to retract the reticular nerve and preserve the reticular nerve. So you can see. Yes. Okay. And the second case is a cancer patient with a lymph node invading to the reticular region. So I use a needle inserted through the skin to assist in removing the lymph node invading the nerve, and it was a challenging case. Yes, you can see this is my needle. I tried to remove the lymph node and preserve the reticular region. Yes, in my conclusion for DTC, surgery is the main treatment. In recent years, active surveillance is an option for small no-risk tumors, and also thermal ablation is a new, minimally invasive option for the highly selected patient. And 12 is safe for both benign and malignant thyroid disease in selected patients. Importantly, it provides better cosmetic outcome. Yes, thank you very much for your kind intention.
And thank you for joining and sharing your insights, your surgical insights to our panel. That was very impressive and thoughtful. And we do not have any more presenters at this time. We will now take
Yes,
a short break and then return for a panel discussion with all the speakers.
yes, thank you very much.
Yeah, see you. We are back. Thank you for staying with us. And we are going to continue our summit with the panel discussion. And the panel discussion will be moderated by our chairs, Dr. Amanda Psiri and Nagashri Sitaramu.
Hi again.
Hello, thank you so much for arranging this session. Very excited to meet you, Dr. Zere, and hopefully we'll have a very lively conversation that everyone can relate to.
Yes, so this was a very interesting session, and it's very interesting uh, to listen to people from different continents and see how head and neck cancer is being managed in different countries. So we heard the topic of HPV-associated oropharyngeal cancer, which is a very important public health problem with epidemic in several countries. In Western Europe and the United States, over 70% of the new cases of oropharyngeal cancer are HPV related. In Greece, a recent study showed that about 60% of the new oropharyngeal cancer cases are HPV related. So I would like to hear what is happening in your countries. Do you have data on the incidence of HPV associated oropharyngeal cancer? We cannot hear you, Dr.
Sorry, I was muted. Let me start first, since I see myself on the screen as the first panelist here. Well, as you know, in North America, just like you mentioned, it's definitely accounts for the majority of the patients with oropharyngeal cancer. We used to see much younger patients before, but now that cohort is shifting. So patients are much older than they used to be. I mean, there are still younger patients, but I do see patients in their 70s and 80s still. So it's not really kind of age dependent like we used to talk about before. I think the cohort has shifted a little bit. And with regards to the specific demographics, many of these patients also have concomitant, tobacco use history, alcohol use history, which makes, clear delineation of the risk factors, somewhat challenging. Testing has been routine in our practice. We do both, P16, immunohistochemistry, like for quick turnaround, but then we also follow it up with HPV testing, and then we do the blood-based testing for E5 and E6 as well. So, and then, with regards to treatment strategies, just like everybody, we try to, enroll patients in, and I know you're a proponent of it, but, we try to enroll them in these de-escalation strategies. But outside of clinical trials, I tend to treat them, similarly to other subgroups, other cohorts of patients. And then, just to complete, we also have a very good, TORS program, and, many of these patients are considered for robotic surgeries.
That's important. For patients that are treated with TORS and have, after surgery, intermediate risk features, do you treat them with reduced dose radiotherapy based on the ECOG study, or you follow the standard of care radiation dose?
Yeah, this is a constant debate in our tumor boards. I think if we have a study open at that time, some de-escalation, lower dose and radiotherapy, yeah, that would be offered to patients. But outside of that, I think it's somewhere in between. I think, we are aware that the standards still remain the same, but there is evolving data. So that's a discussion with the patient. A lot of times they do get lower dose adjuvant radiation.
Mm-hmm. Okay. Dr. Majumdar,
Hi,
um,
hello.
hi, how are you?
I'm
Regarding
good.
TORS, do you have experience in your institution with TORS?
Yeah, we have, but the thing, as Dr. Nagashri was already telling, in our part of world, we rarely see an HPV positive oropharynx. So almost 90% of our patients are HPV negative, or else they eventually turn into an high risk group because of the inherent more than 10 pack years of smoking history. So we do offer TORS, but in very selected cases with great mouth opening and with early T1 and selected T2 cases only, especially those who are neck node negative clinically. Any positive neck node, we usually don't offer TORS as of now, because eventually these patients will end up with radiotherapy, and almost half of them will require some form of systemic therapy.
Okay, so we see some studies, for example, the study from Memorial using the hypoxic PET, that some patients are cured with very low dose radiotherapy, 30 gray, for example, which apparently is associated with substantial less toxicity in the long run. Do you think we are overtreating these our patients today? It's my opinion is that certainly there is a subset of patients with good biology that are being overtreated, but unfortunately we do not have the tools worldwide to identify these patients and de-escalate them effectively. So I will change the topic and go to immunotherapy. So is perioperative immunotherapy approved in your countries?
Me,
Yeah.
no issues. Please carry on.
Go ahead.
Yeah, it is approved. Pembrolizumab, 2 cycles. Prior to surgery, followed by adjuvant, is an approved treatment, and we routinely use that in our practice. However, the issue is a lot of times patients, when they're referred from other institutions, they may already have received, have had surgery, or they, for patient, due to patient factors or whatever there is, there might have been surgery. So we're kind of, like a lot of times it is the adjuvant discussion that we end up having. I know the NIVO post-op study, did show benefit for adding nivolumab postoperatively, but it's not in the NCCN guidelines, and that has not yet obtained approval. So it's kind of a little, challenge when we're trying to get that across through the insurance.
I see. Yes, another challenging factor is getting the PD-L1 CPS score on time. In Europe and in the United States, the perioperative pembrolizumab is approved for patients with PD-L1 CPS 1 or higher. So, sometimes surgeons take the biopsy and we have the results some days later, and then we have to request the PDL1, and this, or you have to get the block from outside because the patient is referred to you by others. So this may cause a delay. And I think, for the implementation of perioperative immunotherapy, it's very important to educate the surgeons, and so they order, testing at the time they see the patient. For the first time, if the patient has stage 3 or 4 disease and is resectable, so a candidate for perioperative immunotherapy. Professor Majumdar, what is happening in your institution? What is your experience?
So we do see a lot of stage 3, stage 4, particularly stage 4 oral cancers, not oropharyngeal cancers in our institutes or our area of practice. But frankly speaking, the perioperative immunotherapy is still not widely practiced here because of two main concerns. One is that the overall survival data is still awaited. And the second part is basically as this is not yet streamlined, so most of the insurance companies usually land up not paying the patient for this. So we don't have an national guideline yet, which promotes or which endorses perioperative immunotherapy. So we are just waiting for that. But yes, it's a point of discussion every time we do MDT. But practically, we are far from practicing that.
Yes, the implementation is important because the EFS improvement, event-free survival improvement, and distant metastasis recurrence rate decline was very impressive with the study. In
And
my
I think
opinion,
the keynote trial, sorry to interrupt actually, the keynote trial in the event-free survival, I think it mainly, the distant metastasis-free survival eventually, I think, reflected more in the event-free survival data in that study.
Exactly. Yeah, they didn't. The study did not show any substantial improvement in local regional
Local
recurrence.
regional control, correct.
Or
Yeah,
major pathologic response was really very lukewarm. I don't know if that is because it was only 2 cycles or maybe there's more time necessary. But yeah, I mean, the event-free survival data was pretty impressive.
yes. I mean, it seems that it is they that immunotherapy induces a systemic anti-tumor immune response, which affected the distant metastasis-free survival mainly. However, in the nivo post-op study, the benefit was seen mainly in the local control. Hi, Dr. Ghosh. Can you hear us? Hello.
Hello.
Hi. We are discussing perioperative immunotherapy.
Okay. Sorry.
We would like to hear your experience. Is perioperative pembrolizumab approved in Nepal?
Actually, perioperative pembrolizumab is approved, but it is beyond the reach of most of our patients. So even though that's an option, it's quite inaccessible. More than 90% of patients cannot afford it. So it's used very less frequently. We do often use perioperative, maybe 1 to 2 cycles of Taxol and carboplatin, and then assess for surgery. But unfortunately, pembrolizumab is very less oftenly used.
So, do you give induction chemotherapy in resectable tumors, or you give it in unresectable, hoping to make it resectable?
Mostly, the decision is taken in a multidisciplinary tumor board,
We have a quick discussion with the surgical team and then the radiation oncology team. Mostly for tumors which per se seem to be resectable, maybe we do with 2 cycles and then reassess.
So may I add something?
Yeah.
So basically, in our part of in our institution, we usually follow neoadjuvant chemotherapy 2 cycles in borderline resectable oral cavity tumors. So we take into consideration the high ITF involvement, extensive skin involvement, or a tongue tumor where we cannot get a 1 centimeter gross margin till hyoid, so which is very near there. So in those cases, so there is a paper from Tata Memorial Mumbai which has described this borderline resectable. So we do take care of that, and we eventually offer the chemotherapy to those patients. However, initially it was a triplet regimen. So now slowly we have moved out, and what we practice here majorly, although I'm a surgeon, but I have seen my medical oncologists are now giving taxane and platinum.
I see. But based on what we currently know, when you operate, you have to go to the original margins.
Yes.
Because I mean, we don't know the pattern of tumor shrinkage. It's possible that there are some tumor nests outside the new margins.
Yes. So as a surgeon, it's very difficult when you get a post neoadjuvant therapy, post neoadjuvant patient to determine on surgical margins. So what we have seen is in borderline resectable, getting out with an histopathologically clear margin or a negative margin is what we try to achieve here. That's all.
Yeah. So do you use tattoo to mark the original margins?
No.
No.
Because eventually,
Hi,
no, because eventually,
Dr. Chua. Hi, Melvin. Very nice to have you. Can you hear us? Yeah, he's still connected. Okay. So um, immunotherapy is not reimbursed in your countries in the majority of patients, I understand. So what about patients
no,
in
we
the
give Nivo post-op. We
you
practice
give
nivolumab in, we give Nivo post-op. That's there because of basically we do have a biosimilar now available in India. So the cost has significantly come down, and it is now almost we have seen that most of our patients can afford that. So we do endorse Nivo post-op, but yeah, perioperative pembrolizumab, I think it's still quite unreachable, as Dr. Ghosh has said.
Okay. Um, so and also there are studies from India showing that even lower doses of immunotherapy are effective. And that's also important because in the low, but for all economies, because immunotherapy is expensive, it's not only for low
Yes.
middle income countries, but for every country, it's important for the
Low dose,
economy.
low dose Nivo coupled with oral triple metronomic. That's
Yeah.
the data that we have from Tata Memorial.
Yes. So in the recurrent metastatic setting, what is happening with the immunotherapy um, reimbursement?
So as a surgeon, whenever I see a recurrent metastatic, I always ask for a PDL1. I talk to my medical oncologist. We do PDL1 testing so that eventually if we have to, or the patient is well enough to pay for pembrolizumab, we go ahead with a single agent, or else we still follow the extreme regimen.
In recurrent metastatic settings, what we have seen is the patients usually do not have a very good performance status. and then going with very aggressive therapy is a limitation. And then thanks to the trial from Tata Memorial, like out of trial, we have had a quite good experience with low dose immunotherapy alone as well. And then maybe because the drug guidelines or the protocols are not much stringent, we have now we have a paper with ultra low dose immunotherapy. So even we have clinically gone forward with doses of 20 mg in individual patients, so with showing quite good response, and that's quite encouraging. Maybe in a few years we'll have some data, and then like out of due to logistic constraints, maybe the lowest dose vial of biosimilar available is 40 milligram, and then maybe two patients collaborate, and then on the same day we give 20 mg to each. And then like in clinical practice, like most of the ones who have been doing systemic therapy in our setting, we have had quite encouraging results with that as well.
I see. So, I think overall immunotherapy is important for head and neck cancer. Of course, it's the availability of biosimilars will, improve the access to immunotherapy across the globe, and also, the optimal dose, because as you said, it may work in much lower doses, will also facilitate the access to this treatment. I think, in my opinion, it is very important to for patients to receive immunotherapy. The earlier, the better. And even in metastatic setting, we have some patients that, for example, you see in the keynote 48, almost one-fourth of the patients who had received chemo, pembrolizumab, are alive in 5 years. And this, was extremely, extremely rare in the past before immunotherapy. And also trying to improve recurrences and cure the patients in the early setting also is very important. So we have the perioperative immunotherapy. There are studies ongoing in the locally advanced setting, in operable setting. So there is currently the JADE study and other studies, immunotherapy given after concurrent chemoradiotherapy. I don't know if you have these studies in John Cartridge, but also we are awaiting for these results with great interest to see if for poor prognosis patients that are PD-L1 positive, we can improve the outcomes.
Yeah, we have.
I have a
So,
question to all of the panels, if I may ask. So, how do you see this the new theory of immune depleted patients? Because in recurrent metastatic setting, especially for head and neck squamous cell carcinoma, we usually the patients land up post neck dissection, sometimes bilateral, or maybe either taken out surgically or radiated bilaterally. So, how this concept is playing up now, this immune depleted scenario, and then immunotherapy.
so the question is how lymph node dissection or lymph node radiation affects subsequent response to immunotherapy. That's
Yes,
the
yes.
Yeah, so there is uh, data preclinical in animal models showing that lymph node irradiation affects antigen presentation and immunotherapy response. So in these studies that are ongoing, there are the idea is that first, that in keynote 412 study, which used Keytruda pembrolizumab with cisplatin radiotherapy in the definitive setting, which was read initially as negative, that long-term follow-up showed that there was a benefit for patients, especially the PD-L1 positive patients. So another observation is that the reconstitution of the immune system occurs about 4 weeks after radiotherapy. So if you give immunotherapy before that or during chemoradiotherapy may not work, and this sequence to give it 1 month, to start 1 month after chemoradiotherapy, works better. And also there was a study which published in JCO testing concurrent versus subsequent after radiotherapy, which showed that the sequence to follow immunotherapy after radiation was better in terms of event-free survival. So, all this data support the testing of pembrolizumab, not PD-1 inhibitors in, after chemoradiotherapy.
So
So we
maybe
are
that's why the Keynote 689 has shown a great result when compared to other pembrolizumab studies where the pembrolizumab was sandwiched between surgery and radiotherapy, which is usually, as you were saying, that it's prior to radiotherapy and usually within 4 weeks of postoperative area. So maybe that's why.
I think in that case, you still had the tumor intact. So that's kind of a little different scenario with regards to the concurrent chemoradiation. I don't know, maybe time. We probably with a longer follow up, all these studies will turn past, just like the Keynote 412, which at now I think it's 47 months of follow-up or a longer follow-up. It seems like it is, there is a benefit for adding pembrolizumab. But I totally understand your comment about immune depletion. I don't know what it is about head and neck cancer. I mean, it's a very immune-rich microenvironment, but I also treat thoracic malignancies. There, we like to do the immunotherapy within 2 weeks of completing chemoradiation, but it's the same process. We are still doing the same, immune, the same theory holds for that as well, but somehow it seems that it's like it depends on, the site of disease is as a big determinant of how this will all play out in the end. I don't know if anyone else
Well,
has it.
in the Pacific study, patients were evaluated 1 month after completion of chemoradiotherapy, and the ones that were stable and responding, they received immunotherapy. So this study showed that the earlier you give the immunotherapy, the better. So the patients that received it 3 months later did worse. So this is the concept that it should not be far from chemoradiotherapy, and it can start at 4 weeks. So I don't think it's much difference. And also, I think there is another study of immunotherapy, another Pacific, which showed that if you give it earlier, they were not able to replicate the results. So it's. I mean, I agree. We do not fully understand the mechanism and the importance of sequence and all that. We can just hypothesize at this point, and we will see the results of the studies, the ongoing studies, and see if immunotherapy will enter uh, the treatment package in inoperable cases treated with concurrent chemoradiotherapy. So, in your opinion, what is the biggest gap today? Is it biology? Is it access to therapy? Is it healthcare systems? What do you think? How we can improve globally the prognosis of head and neck cancer?
I think all of the above that you mentioned. But thinking globally, I feel like we put all the head and neck mucosal squamous cell carcinoma into one bucket, but I think it's really a composed of several different disease types. To me, the biggest challenge globally, apart from the access issues and getting the medications and the cost and all of that, is that we do not have good biomarkers to differentiate between subgroups of patients, to deliver tailored therapeutic approaches. Even with de-escalation therapies, even using hypoxia um, um, uh, based radiological assessment, we still there's a big gap in finding who is going to benefit from what treatment. And I think that is perhaps, everyone can probably universally acknowledge that. And then, of course, there's access and cost issues, cost to the healthcare system, cost to patients. Even when they're completely insured, there is a copay, co-insurance, and I think Europe may be different, but our patients are constantly, we're always trying to get help from the sponsors. And the last thing I want to mention is clinical trials. We talk about diversity, diversifying our clinical trial access, but I want to call out on how exclusive many of these trials are. It's very difficult to get a patient on a clinical trial based on the eligibility criteria. But when the drug gets approved in real world, it's a totally different thing. I mean, we use it for many patients who would have never qualified for any trials. So that is a big challenge, in my opinion. And with patients with head and neck cancer, social support is extremely important. So while we talk about all of this, we kind of minimize that part of the story. Our patients are, the morbidity is there. They've probably had, significant surgeries in the past. Their social support uniformly is lacking, regardless of what site of disease you talk about. And those are major challenges that I think that we are facing today.
Yes, it's true that at this point we have only HPV and smoking as prognostic factors, and we are not as lucky as lung cancer that you have all these disease, the molecular subtypes, and that has resulted in such an impressive progress in lung cancer treatment and outcomes over the past like 15 years. It's amazing. And I agree with you about patient representation in clinical trials. And that's why it's important to obtain real world data, to see in the real world how well these patients are doing, because these ideal clinical trial patients are not the typical patients that we see every day. So, any other thoughts, Dr. Manjumdar? Would you like to comment on this? In your opinion,
No,
the biggest gap?
I think Professor Nagashri has quite well summed it up.
Okay, Dr. Ghosh?
Yeah, and so there are a lot of challenges, and thanks, Dr. Sitaram, who has brilliantly summed it up. And then what I feel is, especially in our setting, now we have quite a bit of surgery and radiotherapy facilities, but with regards to the systemic therapy trials, and others as well, there needs to be diversification. Like most of the trials are done in a separate group of population, and then we replicate them in the clinical scenario, in different clinical scenarios. So definitely there should be increased access to clinical trials to people in the LMIC setting as well. Yeah, that's one point I wanted to bring out.
Yeah, thank you. Hi, Melvin.
Hello, sorry.
No problem. So you are talking about gaps in head and neck cancer treatment, understanding of biology, access, or healthcare systems. And it's interesting that we have representatives around the globe, and we share our experience and our difficulties. So, in your opinion, what would define a good center for head and neck cancer in 2030? So, what do you think? Um,
The No, I think, so obviously in Asia, things are very disparate, right? It's very heterogeneous. I'm sure it's the same in each of our systems that we practice in. And one thing that I still find, which is kind of difficult to believe, is the access to tertiary multidisciplinary care. And we know that, if you have good surgical, radiation, medical oncology working together in, a hair and neck cancer treatment facility, the patients definitely do a lot better. And I think even in Asia, we see that in LMICs that they have no, access to good pathology, radiology, compromises are made, even for nasopharynx that we treat, some places have no MRIs. And and even within countries itself, there's a big disparity. So I think as a whole, at the fundamental level, there needs to be a upskilling that brings us closer to the high level trials that are done. And when those two, we bring them closer together, I think that's really where you see, great gains in outcomes. Because you can have the best immunotherapy, the best trials. If a place just, your to turn around a pathology takes, 4 weeks after surgery, and to start radiation takes another 3 to 4 weeks in a post-op setting. It's just, it will compromise outcome. So I think
mhm.
that's one of the key issues that just needs work, and it has to happen at a few levels: infrastructure, education, training, and of course, firms like this where experts can interact. Yeah.
Mhm. Yes, it's important because the approach is multidisciplinary. So just good drugs are not sufficient to improve outcomes. There has to be, all the components of the care have to be state of the art. Radiation therapy is very important, the timing, the access to
Yeah.
radiation. So, with that, in the different countries, what is the availability of, radiotherapy, let's say, in remote areas? For example, in Greece, patients to start radiotherapy on time, oftentimes we have to refer them to private centers
Mm.
because in public hospitals, by the time we get the biopsy result, the surgical pathology, it's a month, for example, after surgery, then the time is very limited, and sometimes the waiting time might be over 4 weeks in public hospitals. So, um, I don't know what is your experience in your
It,
countries.
it's the same. I think you will see a big disparity. So I mean, I like in Singapore, of course, we are small, so that's less of an issue. But even then, for us to start a patient, usually it's 2 to 4 weeks we could cope. But I do a lot of teaching and training in Malaysia as well. And you can see that even like of course in the major cities, the major capitals like Kuala Lumpur, yes, the patients can get real therapy, get MDT access quite quickly. But then when you start going to the smaller states, smaller cities, that's when they still, some of them still use cobalt. For example, I just saw a patient who had a cobalt wedge path for a parotid gland tumor. I can't remember was the last time my trainee did a cobalt treatment. So I think that's what it's meant, that you got to look at it as at a macro level and also at a micro level. even though you may have, I- enough radiotherapy machines in one particular place, it's just how it's distributed, whether provides equal access to people. And then, in our region, well, it's not as big as, say, certain parts in Europe, but we have, Malaysia, Indonesia, Thailand, Myanmar, and they've always been struggling with the same issues. So I think that's, if we can deliver good MDT care, I think that's probably one of the big gains we can get in head and neck cancer.
Yeah, that brings me to, yeah, I mean, that's a great point. I think, quality improvement projects are equally important as clinical trials, and having some global benchmarks as to what is considered optimal treatment for different diseases, having guidelines in place with groups like this, perhaps may be a very good step. I know the American Head and Neck Society and other platforms have put forth some guidelines, but a lot of times I feel like the global scene is not taken into consideration. So perhaps something for us to discuss further beyond this discussion here.
Yes, exactly. It's very important. I remember some years ago that quality assurance was assessment was performed for radiotherapy across Europe for clinical trial, for identifying sites for clinical trial. Half of the radiation oncologists were missing the target. So it's very important, the quality assurance and, improving our skills in surgery, in radiotherapy, to deliver the best care for our patients. Because our time is up, I would like to thank you all for this interesting discussion, and we will proceed to the next session.
Thank you.
Thank
Thank you
you.
so
Thank
much
you so
for the
much, you
lively
all. Thank you.
discussion. Thank you. Nice meeting you all.
Same.
Same here.
staying with us. Let's continue our webinar on head and neck cancers. The chair of this session is Dr. Nakashi Sitiramu, Director for Thoracic and Head and Neck Medical Oncology at Northwell Health, Associate Professor at the Zucker School of Medicine at Hofstra Northwell. Dear Dr. Nakashi Sitiramu, the floor is yours.
Sorry for the delay in clicking the buttons. Thank you so much for this wonderful event. It's a global presentation of multidisciplinary practice across the globe. And I really thank the moderators and speakers of previous blocks who have set the stage for an exciting session. We will now move on to Block 3, which focuses on Europe and early North America. This session is designed to highlight how regional perspectives are shaping current practice and innovations in head and neck oncology, from multidisciplinary care models to emerging therapeutic strategies. I'm honored to chair this session, and I would welcome an outstanding group of speakers. The way we've fashioned this is that we have interjected lectures with case presentations that we believe are going to be very engaging and somewhat practical, and perhaps everyone that treats head and neck cancer can connect with. So first of all, I would like to introduce my speakers very quickly. The first speaker, we'll begin with Dr. Taneja, Dr. Chari Taneja, who is a board-certified endocrinologist at Northwell Health, assistant professor of medicine at Donald and Barbara Zucker School of Medicine at Hofstra. His clinical focus is benign and malignant neoplasms of the thyroid. So he is a very critical member of our multidisciplinary thyroid care program. Joining him is Dr. Arthur Ong, a second-year hematology oncology fellow at Zucker School of Medicine, Hofstra, who brings a trainee perspective, but he's also a budding, poised to be very successful thoracic and head and neck oncologist. We will then proceed with Dr. Palma, a lecture by Dr. Palma, I believe, who is a radiation oncologist at the London Health Science Centre and clinical scientist within the Ontario Institute for Clinical Research. He specializes in thoracic and head and neck malignancies. He has an extensive academic background, and he chairs the Canadian Pulmonary and Head and Neck Radiotherapy Investigators Group. And then we have another case discussion, which Dr. Sagar Rakshit, who is an assistant professor of medicine at Hofstra Northwell, and with a clinical focus on head and neck and thoracic malignancies, and I will be discussing. Then we are privileged to have Dr. Gregory Randolph, who is an internationally recognized leader in thyroid cancer surgery and nerve preservation. He has really shaped the endocrine section of the American Head and Neck Society and various other platforms such as that. And he has pioneered several techniques in thyroid surgery. So we're very interested in hearing about his perspectives. And then after that, we have Dr. Paolo Bassi, who's from Italy, a recognized leader in head and neck oncology and a key voice in advancing multidisciplinary care and translational research across Europe. He'll be sharing his thoughts grounded both on clinical excellence and academic leadership. And then we will be lastly hearing from Dr. Aaron Karapetian, who represents Armenia, and he'll offer an important perspective on regional practice patterns, challenges, and evolving approaches to care in head and neck malignancies. Together, I believe these talks will provide a valuable transatlantic lens on how evidence, innovations, and context intersect in patient care. With that, I would like to have Dr. Taneja and Dr. Ang take the stage from here.
Excellent. Thank you for having us today. I think Dr. Ong, do you want to bring up your slides?
Yes. All right, so I think our slides are uploaded.
Yep, I think it looks good.
All right. All right, so good morning, good evening, everybody. So we're excited to share this case that involves kind of multimodal management of RET mutated medullary thyroid cancer. And we want to take you through a case that our group recently managed to use it as a lens to examine and understand one of the most clinically relevant questions in head and neck oncology right now. When do we operate on a patient with advanced medullary thyroid cancer? Is there a role for neoadjuvant treatment in this disease? And the answer is evolving and has been changing for the last 3 to 4 years. So I think by the end of this talk, we'll have a framework that you can bring directly to the multidisciplinary tumor board. Next slide. Oh, sounds good. All right, I can move it. So amazing. So these are the learning objectives. We'll talk about the significance of RET M918T as a high-risk oncogenic driver, and then we'll compare sulfatinib versus other multi-kinase inhibitors, what the trial data suggest, and AE profiles. And we'll also look at the evidence and rationale about systemic approaches in locally advanced RET mutated medullary thyroid cancer, and we'll look at the framework for surgery first versus neoadjuvant inhibition. So our case was a 51-year-old man who initially had a right neck lump that he was diagnosed with medullary thyroid cancer, but then he was lost to follow-up. He came back because he was now having a globus sensation. He does not have any radiation exposure to head and neck area, and his past medical surgical history is not contributory. Family history, he has no family history of cancers or endocrinopathies. He does have a heavy alcohol use with binge episodes, no smoking or any drug use. In terms of medications, he does not take any medications. And on exam, he had a very firm, that is not mobile, right level 2 and 3 nodal mass, and also a thyroid nodule that was palpable. Immediately, our concern is, given his history of this medullary thyroid cancer previously, we're concerned for locally advanced disease. And his lab work, a biochemical profile that is with calcitonin that is over 10,000, CEA of 138. The serum, urine, catecholamines, metanephrines were negative. And he had a normal parathyroid hormone and normal calcium. And FNA confirmed this is MTC.
All right, Arthur. So let me pause right here. So with the calcitonin level in the 5 digits now, so you're seeing this calcitonin of 11,000. What are your thoughts about? Are you only thinking about locally advanced disease right now, or does this already start to tell you, you might have distant metastatic disease also?
with those numbers? And then how does that guide you with what next evaluation you will be doing for this patient?
Yeah, absolutely. So I think with the, he has this history of MTC that was diagnosed years ago. There's certainly a concern that this may already be metastatic disease, as he was lost to follow up, now coming in with significant symptoms. So I think the next step I would do is to do some staging scans to see where the extent of the disease is. Anything to add, Dr. Taneja?
I think that's a good starting point. And your calcitonin of like 500, 1,000, you can still think that might everything be limited to the neck. But when you start seeing these numbers in the sort of tens of thousands, I think you're very concerned about distant metastases also. So I think I would agree with you with sort of getting cross-sectional imaging, not just of the neck, but the rest of the body as well.
Yep. So that's what we did. So I wanted to bring you to take a look at the scans. So there is the main thing. So if we look at his neck, there is a lot of disease in his neck. In the prevascular lymph nodes, they were very large and enhanced. There's also a lot of right jugular chain and inferior cervical lymph nodes. And in the lung, concerning are the small pulmonary nodules, which is certainly concerning for metastatic disease. And then we also did a day-to-day PET scan. His right thyroid lesion is day-to-day avid, multiple bulky right-sided neck nodes, and multiple non-avid lung nodules. So some of the molecular testing, so germline RET testing was negative. No germline RET mutation was identified, which the significance of doing this is there is a reason we want to exclude MEN2 genetic syndromes associated with these medullary thyroid cancer. And so this is a very important part of the workup. And then we also did somatic tumor profiling, and that found a RET M918T mutation. He did not have any concurrent RAS, BRAF, or other actionable mutations. So Dr. Taneja, based on this case so far, what are your thoughts in terms of next steps?
Right. So I think this is an exciting time with molecular genetics, and at least in this part of the world where there's availability and access to molecular testing early on. Germline molecular testing for medullary cancers is indicated for all cases, but somatic testing, you're already starting to think about what are your other options for management here in terms of the standard of care for medullary thyroid cancer being surgery. But the reason why you got somatic molecular testing in this case up front is because I think you're already thinking about, is there something else we can offer to this patient early on? And I think that's where we're thinking about challenging the paradigm that is upfront surgery the first thing that we think about, especially for these locally advanced cases, or is there something else based on their molecular profile and specific genetic information that we can get that can tailor our therapies to be more personalized, more nuanced?
Yep, absolutely. We'll be talking about some of the data that we have currently in terms of systemic therapy prior to surgery. And there's some exciting data hopefully coming out of the phase 2 study of neoadjuvant strategies in this disease. So we're excited for the future of this management and evolving landscape of this disease. So next thing I wanted to kind of go over is to talk a little bit more and think about RET as a driver, just the background, and we'll see different RET mutations, and they do have different significance. So RET stands for rearranged during transfection. It's a receptor tyrosine kinase. It is located on chromosome 10, and normally it would require a ligand to bind to activate downstream signaling, which will be RAS, ERK, PIK3, and ATK pathways, JAK-STAT pathways. All of these are proliferation and survival signals. So in MTC, the activating point mutations in RET basically eliminate the ligand requirement. So the kinase is active constitutively, and it's really producing the oncogenic signal. So for this disease, the location of the mutation matters. So exon 10 and 11 mutations are moderate to high risk, and mutations in exon 15 and 16 are the highest risk. So M918T codon 918 mutation falls in the exon 15 region, which makes it a very aggressive mutation in the risk stratification in ATA. And also one thing, it's very important to differentiate between differentiated thyroid cancers like PTC compared to MTC is that RET alterations tend to be gene fusions in PTC rather than point mutations. So MTC, it's almost exclusively point mutations. So M918T is the highest risk mutation, and 25 to 35% of sporadic MTC carry this mutation. And in fact, 100% of MEN2B patients will carry it in the germline. And this has a worse overall survival compared to other RET mutations. And in ATA risk stratification, this is the highest risk category. In fact, if we find germline mutation in germline mutation of this, it would typically the guidelines would say urgent prophylactic thyroidectomy. And it is actually very highly sensitive to selective RET inhibitors like selpercatinib. So we brought this case to our multidisciplinary tumor board with the specific question of whether the patient should receive upfront surgery or systemic therapy first. And I'm curious, Dr. Taneja, what was that discussion like, and what were the arguments for and against? And I would be interested to see you shed light on those discussions.
Right. I think I think you've highlighted them very nicely on this slide, and the issue with this question is that data is really emerging, and a lot of the data regarding neoadjuvant therapy for thyroid cancers, and specifically for medullary thyroid cancer, it lives in these published case reports and case series. So there's not a lot of guidance. There's not a lot of randomized controlled trials, showing us what the real implication is. And I think one of the important questions that comes up with this discussion is, what is truly unresectable? What is the disease that you are calling unresectable? Is it truly unresectable because it has invaded into your vital structures? It's invaded into the trachea, great vessels, and the surgeon cannot get it out? Or is it that the surgery is going to be very, very morbid? So, the disease hasn't invaded, and maybe the surgeon is able to get it all out, but it will be a very morbid surgery in terms of injury to surrounding structure, including the recurrent laryngeal nerves, the parathyroid. So, can neoadjuvant therapy in those situations shrink your disease to make it less morbid? And I think those are the arguments for using systemic therapy, that you might convert sort of this borderline resectable case to a more resectable case and improve your surgical outcomes, and then improve your survival because you were able to get an R0 resection using systemic therapy up front. But on the flip side, it's the data is limited. So is it, by delaying surgery, are you actually allowing for progression, which is a less common situation because as you mentioned in your previous slides, these cancers with this specific mutations, they usually do respond to selective RET inhibitors. So if you give someone a selective RET inhibitor for, let's say, 3 to 6 months before surgery, you wouldn't expect a dramatic progression while they're waiting to have their surgery. So that tells us that we do have some time to try this out to see if we can make this a little bit less morbid for the patient.
Yep, absolutely, Dr. Taneja. Thanks for sharing that those points. Really, I think in this patient, it's a very challenging discussion, of course, with our multidisciplinary team, thinking about how we can make the surgery more to achieve R0 resection, and then thinking about the vital structures that the tumor is sitting on. And of course, knowing that this tumor has this mutation M918T that is very sensitive to cybercatinib. Our group really felt that neoadjuvant strategy would be one way to go. But before we dive into this, I also wanted to talk about the treatment landscape and in this disease. So we have multi-kinase inhibitors prior to cybercatinib. So vindatinib, that was approved in 2011, and cabozantinib, that was approved in 2012. So these are multi-kinase inhibitors, which what does mean is that they hit RET, but they also hit VEGFR. And in cabozantinib, there's a lot of off-target effects as well, MET, AXL, KIT. And in clinical trials, there was meaningful PFS benefit. But if we look at the side effect profile, 79% of patients on cabozantinib required dose reductions. And similarly, vindatinib, also 35%. And if we look at the side effect profile, the toxicity, hand-foot syndrome, diarrhea, hypertension, QTc prolongation with vindatinib was really driven by the off-target activity. So a lot of times these patients were not able to stay on full doses and quality of life is really impacted. So then came selpercatinib, which is more specific. It's highly sensitive to the small RET kinase inhibitor because it blocks at the ATP binding site with 100-fold selectivity for the RET mutation. So the selectivity really eliminates the off-target multi-kinase inhibitor effect. So what does that mean? So the off-target toxicity profile here are clearly cleaner. So we're seeing, we still see some dry mouth, some hypertension, some transient hepatotoxicity, but essentially hand-foot syndrome, it's almost very uncommon. And dose reductions drop from 79% with cabozantinib, and with cybercatinib drops to 30%. The other thing is that it also has CNS penetration, which is really relevant for patients with brain metastasis. And then it also has activity against common acquired resistant mutations, so-called gatekeeper mutations that include V804M and S904F. To go over some of the trial data that came that led to its approval, we started with Libretto 001. That was phase 1/2 study. Really, the results were very striking, with objective response rate of 69% in MKI or multi-kinase inhibitor naive cohort, and median progression survival that was not reached after 2 years of follow-up. So that led to accelerated approval in the phase 3 trial. which was very practice changing. So that was the open label randomized controlled trial. It consisted of 290 patients, all treatment naive, locally advanced or metastatic RET mutated MTC, which were randomized to cybercatinib versus physician's choice. And primary endpoint was progression-free survival, and cybercatinib won decisively. Median PFS was not reached in the cybercatinib arm, and the progression hazard ratio was 0.28, which was very impressive. And I also want to bring your attention to the subgroup PFS hazard ratios. And across every subgroup, by mutation type or by prior therapy, cybercatinib consistently outperformed other MKIs. M918T, really a hazard ratio of 0.18. So exceptional efficacy in a high-risk molecular subset. So cybercatinib became the first-line standard of care for advanced RET-mutated MTC. So as Dr. Taneja was discussing at our tumor board, knowing that he has very bulky disease with high risk for residual disease, as well as injury to vital structures with surgery, and knowing also with this data that RET M918T is biologically aggressive, sensitive to RET inhibition, based on the data that we presented, the tumor board discussion was incorporating neoadjuvant therapy in this case. Knowing that this is not a cure, it's really meant to reduce the bulk of the local regional disease and to hope for R0, R1 resection and make the surgery less morbid. So the neoadjuvant literature in the RET mutant MTC is small, but it is directionally consistent. I wanted to anchor on 3 landmark case studies and case series. So the first was in 2021, Jozagi and colleagues at MD Anderson, they published the first case where a patient with 20-year-old patient with widely metastatic MTC, complete vascular encasement of his left subclavian artery. Effectively, it was inoperable. So he underwent 6 months of cybercatinib, and that led to reduction of the tumor bulk, that a gross total resection became possible. And he then continued on cybercatinib postoperatively with stable metastatic disease. And then in 2023, Contrera and colleagues published a large series, the largest case series consisting of 4 patients with locally advanced RET mutated MTC. They all underwent 4 to 6 months of cybercatinib with 20 to 50% reduction in the tumor and surgical outcomes. 2 patients achieved R0 resection and 2 patients achieved R1 resection with improved surgical morbidity scores, fewer right laryngeal nerve sacrifices. So morbidity was improved compared to what would have been expected up front. And then there was another case study from Japan with Kadoya and colleagues, similar approach, but this is in papillary thyroid carcinoma, not MTC, extending the principle of RET-altered RET biology into differentiated thyroid cancer. Again, they saw tumor regression with making the surgery more feasible. So we do have a phase 2 trial in this space, and really excited to look for those results in the next few years. So in the patient, we started cybercatinib, and he tolerated it very well. No dose reductions over the 6 months course. had a very dramatic and profound biochemical response. And his calcitonin was in the 10,000s, decreased to 60 by the time of surgery. Similarly, CEA, really reflective of what the calcitonin trend is. And radiographically, we saw a good response as well. This was pre and on treatment scan on salpacatinib. There was reduction in the nodal bulk. There were more new calcifications. And then the thyroid mass is significantly smaller. The nodal disease are much smaller at this point. So our MTD felt the disease has plateaued in the response where surgical timing was appropriate at this point. So patient underwent 6 months of TKI, then he had a total thyroidectomy with right neck dissection. The pathology, primary tumor showed unifocal right 2.6 centimeter MTC, no extrathyroidal extension, margins were negative, 21 out of 36 positive nodes, and with a largest deposit 4 centimeter with ENE, which means extranodal extension. So post-operatively, he had a very good recovery, no voice changes, at transient surgical hypoparathyroidism, which has now been resolved. So at this point, going forward, we were now left with some post-operative decisions. So he had an R0 resection, but again, there was a bulky N1 disease with extranodal extension, and then stable pulmonary nodules. So Dr. Taneja, what were we thinking in terms of what was the group's discussion around salpacatinib? Is there a role for continuing it as a maintenance therapy?
Yeah, I think that's, you bring up some very good points, and that was a great presentation and sort of a representation of what we're trying to do here. I think as we talked about before, the issue is that the studies you presented, sort of in total there were 6 cases, so it's a very small number of patients, and that makes it challenging to sort of understand what is your endpoint with systemic therapy before surgery. Is it biochemical improvement, or is it more structural improvement? Because as you saw in our case, and also in other cases, you will see that biochemical response happens very quickly with these agents. So salpacatinib will decrease your calcitonin levels significantly, and that can be misleading because sometimes that doesn't always translate to a structural response. So our patient did have a good reduction in size, which we think helped with making his surgery less morbid. I know some of the other cases that you presented have had a more significant reduction, but because of lack of a randomized trial, there's not a clear endpoint, which sort of leads into what is the right duration of using these drugs. Should we be using these drugs for 2 months before surgery or 6 months before surgery? Or in our case, let's say if instead of using it for 6 months, if we used it for 9 months or 12 months, would we have had more reduction, making the surgery even less morbid? I think those are still questions to be answered. The other question that you bring up here is about continuation of salpacatinib after surgery, and I think that is also a very debated area. The issue is that, let's say you only had neck disease and then you had an R0 resection. I think that makes more of a case for stopping therapy, because if you used it for a neoadjuvant situation and you had an R0 resection, you're not thinking that there's disease left, so you would discontinue it. But the other side of it is that when you're starting with such bulky advanced disease, there's always concern for microscopic disease left over. Now, is continuing salpacatinib going to help you with your recurrence-free survival and overall survival, with someone who has microscopic leftover disease? That's questionable. We don't know the answer to that one. In our case, this was a little bit easier to answer. Our patient does have distant metastatic disease, so it's not just neoadjuvant therapy anymore. It's also therapy for him for his distant metastatic disease that's already present. And I think his calcitonin has remained very low and stable after surgery. But I just want to share there was like a small period of a few weeks that this patient had to come off the selpercatinib for an unrelated reason, and his calcitonin went up from 30 to about 900. So that sort of also makes a case for once you stop the drug, there's some sort of progression, at least biochemically. And then the one last thing I wanted to bring up was that, what is the endpoint? Because as you know, these drugs, they all have acquired resistance over time. And, we have this great drug that's available, at least in the US, but we don't have something else right now if this drug fails. So if 5 years down the line, he grows acquired resistance and progresses despite selpercatinib, I hope we have another drug at that time. But I think those are sort of the areas of debate. And then, just like you, I'm also waiting for the phase 2 trial, hopefully in the next few years, to sort of give us more data and more guidance about how to use these agents for these cases. But really excellent presentation.
Yeah, absolutely, Dr. Taneja. It's I think we have great drugs. We're left with more answers, more questions rather, that we're eagerly awaiting answers on. So thanks for shedding light on all of those important areas of future area that we really need to look into to help our patients. Yeah, so amazing. So overall, these are the 4 takeaways. So first, RET M918T is a high-risk driver. We need universal germline testing in all MTC. Somatic mutation identifies those patients who have biologically aggressive and most likely to respond to RET inhibition. So we also spoke about Libretto trial, which established selpercatinib as the first-line standard in advanced disease. And then we also talked about the emergent strategy, neoadjuvant RET inhibition. Again, the data is limited to case series, but ongoing phase 2 trial in MD Anderson will be getting some readout in the next few years that we're looking forward to. And for NTD decision framework, it's essential in managing these tumors, and neoadjuvant approach seems to be a favorable case to make, especially if there's vascular encasement or bulky mediastinal N1B disease, or if there is any R2 resection that would be in surgical morbidity. I think these are the questions that we await answers to, but certainly important things to think about and discuss with our multidisciplinary tumor board in these challenging cases. Great. Any other closing thoughts, Dr. Taneja?
I think you summed it up nicely. But thank you for having us today and letting us share with you.
Thanks for having us. Oh, I think maybe we can stay for a bit, see if there's any questions from the audience.
Any questions. Mm-hmm.
Yeah.
Thank you, dear doctors, for valuable and interesting presentation. So let's move on. I want to introduce next our speaker, David Pelmer, radiation oncologist at London Health Science Centre and clinician scientist with the Ontario Institute for Cancer Research. He will present the escalation and adaptive radiotherapy strategies in hand and neck cancer. So, Dr. David Palmer, the floor is yours.
Thank you. Can you just give me a confirmation that you can hear me?
Yes.
is that this? Are we getting it? Yes, good audio.
Your
Okay,
voice is
thank you.
just
Thank you for the perfect. And can you see my slides all right as well?
Not now. Yes, everything is good.
You do not see my slides. Everything is good.
Now
Okay.
it's everything good.
Great.
You can start.
Good afternoon, everybody, or good morning, depending where you are. I'm coming to you, Canada, where it is morning, and today I'm going to talk about oropharyngeal cancer in the HPV era and how 20 minutes, and then we'll have some time for questions afterwards. These are my disclosures, which are not relevant. Oropharyngeal is a controversial area, and the controversy has been going on for a long time. About 10 years ago, this very first gray zone in the Red Journal written by Sue Yam. And for those of you who don't know, the gray zone is a series every month of a difficult case where we provide a difficult case and then some expert opinions. And Sue Yam, who's now actually the editor of the Red Journal, provided this case of a tonsillar cancer with a single involved lymph node. And then there were 4 expert opinions as to what to do. Expert number 1 said radiation alone. Expert number 2 said TORS plus a neck dissection. Expert number 3 said, well, do whatever you want, but avoid trimodality treatment. And expert number 4 said, I'll give you unilateral radiation, but with cisplatin. So 4 different opinions on how to manage a very common situation. And I think it's fair to say that 10 years later, even though we have much more evidence, the controversy still persists. So where are we going with my talk today? Well, I'm going to talk about de-escalation, and I'm going to do it in the context of the ORATOR studies, which are 2 RCTs that we led here at our center, but enrolled patients in Canada and in Australia. I'm going to talk about TORS in light of the results of the ORATOR studies and what the implications are. I'm going to talk about where it's going. Probably, I would say, the future treatment of HPV-related oropharyngeal cancer. And then finally, we talk about what I would do if I were diagnosed today, ORATOR trials, and what the pros and cons of each treatment are, and having worked closely with my surgeon colleagues who helped design and run the trials with me. So how the ORATOR trial came about is an interesting piece of history. This is my good friend, Dr. Anthony Nichols, who is a surgeon scientist, and he had trained in TORS and brought TORS back to Canada. And what was happening was that after TORS became available, every tumor board became the same discussion over and over. At our center, every head and neck referral, about 600 head and neck referrals a year, head and neck cancer referrals, and every single one is seen at a head and neck multidisciplinary clinic by a surgeon like Anthony and a radiation oncologist like me, seen together. And then at rounds after this clinic, we review all the cases with our neuroradiologist, with our pathologist, and the whole team. So it truly is multidisciplinary, but we found that we were getting bogged down with the same question over and over, TORS versus radiation, and doing no matter what I tried to do, I could never persuade Anthony to become a radiation oncologist, even though I brought him into the LINAC and showed him how cool our technology is. And then we were struggling to figure out what's the best thing to do. So we did the systematic review led by our fellow Sam Douthwaite, who is now an ENT surgeon in Australia, Dr. John Yu, who many of you will know, he's a very prominent surgeon, now the dean of our medical school. And we found that the evidence was lacking. It was certainly very much single-arm studies, uncontrolled, susceptible to strong selection biases. So we wanted to run a randomized trial, but we knew that randomized trials of surgery versus radiation often fail. This is a review article done by one of our radiation oncologists when he was a resident, Timothy Wynn. Tim is now the PI of the ARREST randomized trial of stereotactic radiation for more than 10 metastases. So Tim is now leading his own phase 3 RCTs. And when Tim did this review, what we found was that about 30% of trials in radiation oncology are failing, which is common across surgical trials, radiation oncology trials, medical oncology trials. The main reason is poor accrual, and the second most common reason is inadequate funding. When we did a multivariable analysis, we found that the main risk for a failed trial is if surgery is the comparison of interest compared to radiation, with an odds ratio of failure of over 12, which is enormous. And I had seen this in practice when I was a resident. I was exposed to a trial of prostate brachytherapy or brachytherapy versus surgery for prostate cancer. And that trial was designed in a way that if a patient was randomized to radiation, the surgeon would still get paid for as if they had done the surgery, trying to remove any incentives or disincentives, but that trial did not accrue. And then when I was in Amsterdam doing my fellowship with Suresh Senin, he was doing the Roselle trial of surgery versus radiation in lung cancer. And so I had seen the struggles with these trials, and we knew that we had to do something very specific to make Orator and Orator 2 work. So this is the schema of Orator. Patients with early T-stage squamous cell carcinoma of the oropharynx were randomized to a primary radiation arm versus a primary TORS arm. This was not de-escalated. But we knew based on the previous trials that the only way to make this trial work was if the experimental arm, which was TORS because it was new, was only offered on study, meaning that we could not do TORS unless the patient went on the trial. And the other centers that opened Orator agreed because it's a new treatment. And in medicine, a new treatment is considered experimental until proven otherwise. And that allowed us to successfully accrue to both of the trials. And at first we questioned ourselves. We thought, TORS is widely available in the US. Are we withholding something that should not be withheld? But once we got into the trial and we saw that the benefits of TORS were not as clear as they had been suggested from some of the retrospectives, we knew that this was only the right decision. I think it's a design that we've used for other trials, and that is really one of the only ways to do a trial of radiation versus surgery across most types of cancer. There are some exceptions we can talk about. So Orator was a 60-patient trial, accrued over 5 years at 6 centers. Some people have said, well, Orator is underpowered because it's only 68. It's not actually correct. Orator was powered for a difference in quality of life, and it was actually had a 90% power for the primary endpoint. It wasn't powered for overall survival or something like that, but it was adequately powered for its primary endpoint. Importantly, almost everybody was P16 positive, and this is the typical population you would see, mostly male, and some of them previous smokers, some current, some non-smokers. Not to go into the trial in too much detail, but the primary endpoint was the MDADI score at 1 year, the MD Anderson Dysphagia Index, and as you can see, an important difference with a p-value of 0.04. Now, when we designed Orator, there was no definition of a clinically meaningful difference in the MDADI. And so we guessed that it might be 10 points because in other quality of life scales, a 10-point difference when the scale goes to 100 is usually thought to be clinically meaningful. So this did not meet our definition of a clinically meaningful change. We've since learned that we were right, that 10 points is indeed the identified clinically meaningful change, but a 10-point change in the MDADI differentiates somebody who is fed with a tube versus somebody who eats orally. It's a very big change. A 9-point difference differentiates somebody who's aspirating versus somebody who's not. What our patients are interested in is not just, am I on a feeding tube or not? It's, can I eat without having to double swallow? Can I go to a restaurant with my friends? Can I eat bread? And those, can I eat without pain? Do I have first bite syndrome? Those things are all very, very important. And it's important to note that this is the initial analysis, the P of 0.049 with the linear mixed modeling. This is our latest analysis. And the curves do converge at 5 years. And we're going to be pulling data for a 10-year analysis very soon to see what happens. Even though they converge at 5 years, and some might say, well, they're equal by 5 years. What's the difference? Well, there is a difference in that over these 5 years, the RT arm had a better quality of life than the TORS arm. And notice this dip down here. This is seen in other trials as well. But there are other things to keep in mind when deciding between radiation and surgery. In Orator 1, swallowing was better with the MDADI and the functional oral intake scale, less pain and less opioid use. We don't like opioid use. No bleeding and less trismus, as you might expect, and a trend towards less shoulder impairment. In the surgical arm, we saw less tinnitus and hearing loss and less neutropenia, less constipation. Some people have said, well, the Orator results are from Canada and Australia. How well do they apply? How well do they compare to our practice? So I want to show the MDADI scores at 2 years, comparing the ECOG 3311 trial, which many of you will be familiar with. So what we see here, so here, let me just walk you through this. So the MDADI goes from 20 up to 100. And this is the MDADI score in Orator for surgery alone, about just over 80 for the surgery alone group, not the whole surgical arm, just the surgery alone group. In E3311, it was about 90, but that was a small minority of the patients. I think it was about 10 or 20 patients who were in the surgery, about 20 in the surgery alone arm, I believe. When you start adding in surgery plus radiation in Orator, in E3311, surgery plus 50 gray, surgery plus 60 gray, our results here were very comparable to the E3311 surgery plus adjuvant radiation group. And this is our surgery plus chemoradiation group in Orator, again, comparing very favorably to E3311. And what we see very importantly, just remember the key here for the MDADI. If you're doing surgery alone, then that's a very good MDADI score. As you start adding in the adjuvant treatment, you are getting pretty low. And then when you add in the trial treatment, you get quite low. So if we're looking at de-intensification, then concurrent chemoradiation plus surgery is not the way to go. I think the default across most patients should be trying for 2 modalities rather than 3, and trying for 1 modality rather than 2. So the follow-up study was Orator 2, which was de-intensification in the HPV positive setting. And we were very lucky because we designed this before HN002 and E3311 came out. 2 arms ended up being extremely similar. We did allow smokers to go into this trial, unlike some of the other de-escalation trials. So the arm 1 was just radiation with weekly cisplatin, potentially. Arm 2 was did allow the laser, not just positive margins or ECE. We did not allow, because in those patients with positive margins in ECE, we don't know that chemo is beneficial in this population. And those patients did fine in this trial. But Orator 2 was stopped due to treatment toxicity. There were 2 treatment-related deaths after TORS. One was an oropharyngeal bleed, occurred in the hospital. We're a quaternary care center, despite internal carotid artery ligation and a tracheostomy inserted at the time of TORS. For those of you who are not familiar with TORS-related bleeds, they are a problem because it's arterial bleeding at a non-compressible site. And so if you want to pack the oropharynx, you need a trach, and it's a dramatic scenario. It's very easy for a minor bleed to become a major bleed. And I should mention also that the bleeding, not only is it arterial, but it's going into the airway. The other issue was a cervical spine osteomyelitis, which is also referred to as cervical spondylodiscitis due to an infection of the cervical spine. And this may be seeding from surgery and possibly propagate adjuvant radiation. This developed shortly after the radiation completed. The mortality rate is extremely high. And it's fair that if this patient had not had adjuvant radiation, they might not have had this spondylodiscitis, but it is a complication in the TORS arm, and TORS is what breaches that barrier. And this spondylodiscitis is known to happen after transoral robotic surgery. Since we reported this a few years ago, I've had centers in the US reach out to me to tell me they have had cases like this as well, sometimes only recognized at radiation peer review rounds when something is noted in the vertebrae. And what we found in Orator 2 is that both arms did reasonably well, but the transoral surgery arm did have some deaths. The overall survival in the radiation arm was 100%. And then the primary endpoint of Orator 2 was comparison of overall survival against a historical control. And just like HN002, the RT arm was significant, and the TORS arm was not significant. A secondary endpoint showed better overall survival when you compare these two arms in the radiation arm with a p-value of 0.01. PFS, we had 6 patients in the transoral surgery arm with events. In the radiation arm, no events, no recurrences or deaths. And then similarly to the OS results, there was a difference in PFS. I also want to show you the swallowing scores. No significant difference, but the pattern does mimic what we see otherwise, with a dip in quality of life after surgery and then a slow recovery. Basically, you're spending 4 years underneath the curve here if you're in the transoral surgery arm. Here are the 2-year MDADI scores. And it's important to note that in the population of small T-stage P16 positive patients, feeding tubes after radiation are rare. We have this idea that radiation is associated with feeding tubes. Yes and no. Often the feeding tubes are in patients who have T3 and T4 cancers, and often it's because after the cancer is gone, there's just a defect at the base of tongue. The radiation itself might not necessarily be the cause of a feeding tube. Other important metrics comparing surgery and radiation. Radiation had better scores in the subdomains of social eating, coughing, and again, painkiller use. The transoral surgery arm had better scores in the sensory subdomain, taste and smell, which fits with what we see during radiation. And the radiation arm had higher creatinine values at last follow-up, as you'd expect from the chemo. So some people have asked, are the orator studies outliers? Are our results a lot different than everybody else's? And some people who are not believers in the orator studies will say things like that. Well, the surgeons are not credentialed in orator. That's not true. They are credentialed in orator. They'll also say that surgeons are not fellowship trained. That's not true. They are high volume surgeons at high volume centers. And our bleeding rates are very similar to other trials. Our bleeding rates grade 3 to 5 are almost identical to E3311. And we know that a grade 3 bleed can easily become a grade 5 bleed. These are very, very hard to manage, particularly at home. Our positive margin rates are a little bit worse than E3311. So 7.4% in orator 2 versus 3.8% in E33. But certainly much better than you see in the US as a whole. If you look at the incidence rate is 23% in T1, T2 disease. That is enormous, and that is often buying time. And it does show you that what is happening at the community centers or the smaller centers is not necessarily being reflected in the trials. There's a big gap in outcomes between the academic institution trials and the more generalizable outcomes. And so these outcomes probably don't apply to the population at large. So where do we go with de-escalation? We were very excited about HN002, which, as many of you know, it was minimal smokers with P16 positive cancers. They were allowed to have extranodal extension on their imaging, and they were treated with 60 gray of radiation with weekly cisplatin or 60 gray of radiation over 5 weeks. And the PFS endpoints were very good. I'll point out that these patients are not necessarily good TORS candidates. We've shown previously in other work that the ability to go for TORS, even if you're having radiation, but if your tumor is small enough, your outcomes are better than if your tumor is not small enough to have TORS. And the people with the ugly tumors are in HN002. PFS results were good, but the IMRT plus cisplatin arm cleared the hurdle to go on to the phase 3. It is, I think the design was rational, but it is certainly a point of reflection as to whether the RT alone arm under different rules would have been a better choice to move forward, because OS was very, very similar. And usually in head and neck cancer, we add in chemo when you improve OS. So should we be adding in chemo here is an open question. The MDADI scores, look at this, 86 in the IMRT plus chemo trial. I've not seen that in any of the surgical trials. But then we went on to HN005, which, as you will all know, was stopped early due to futility. There were 3 arms here. One was the standard, although they accelerate the radiation and give two cycles of cisplatin, which is or and it was stopped because it didn't meet the PFS threshold, with the PFS being roughly 10 to 60 group PFS event by omitting the chemotherapy, PFS event by going to 60 gray of radiation. But the OS difference, this is not meant to be statistically compared, but they're very, very close. We're looking at a 1, 2, or 3% delta in the overall survival, meaning that you'd have to give maybe 100 people chemotherapy to improve OS in one, to save one life. And that is probably not worth it, to be totally honest. So the open question right now, while we await the swallowing outcomes of HN005, is what is the trade-off for 8% PFS and 1 to 2% OS, and where are those progression events occurring? If they're in the neck and they can be salvaged, it might be worthwhile just doing the 60 gray and salvaging 8% of the people. 1 in 12. If it's a distant metastasis that can be treated with SABR, maybe that is something that you would want to take the risk of going to 60 gray instead of 70. Because from what we know, the toxicity at 70 gray is a lot worse than the toxicity at 60 gray. We're waiting for HN005 to show this, but we looked at the orator in 2 patients we compared. We found that with 70 gray, the toxicity is a lot worse. So you have worse sticky saliva, you have worse cough, you have worse dry mouth, some of the lower. So it's certainly something we need to be thinking about is what are we buying? Whether another 10 gray of radiation, is it worth 10 more gray? Is it worth all these side effects for 8% in question? And then you ask patients about that, they will give you different answers to the scenario where we're offering both. So my last 5 slides are going to talk about how we things down. And there are a lot of options. We can reduce the radiation dose to the tumor. So we can reduce the dose to the elective volumes. We can reduce extent of the elective volumes. Therapy, although cetuximab has failed that. If we're giving TORS, we can dose. I will TORS MDADI scores, even at 50 gray, the MDADI scores are not fantastic. And then we have very few phase 3 trials. I would love to see a large phase 3 trial of TORS versus radiation, but I don't think that is forthcoming. I'm just going to highlight a couple of things very quickly. We have this idea of aggressive de-escalation that was popularized or their imagination in the third trial. This DS to 30 gray based on scanning and the absence of hypoxia. This is a small pilot study, but the outcomes were quite good and some very interesting correlates with some of the hypoxia markers. And this is now a phase 3 trial that we are very much looking forward to. We went to the US to enroll in this, but there are issues around us going down there, sending our patients down there and getting the FMISO scan. FMISO would need to be widely available for this to work. What we're doing in Canada is a short OPC phase 3 de-escalation trial, which is accruing very well, led by Huda Bahig. This is a non-inferiority trial, sample size 360, and it's accrued about a third. It's accruing very quickly. Our center is putting on about 3 per month. It's a very small de-escalation, but it shortens the radiation. It's a very small de-escalation to the primary tumor, but it shortens the radiation substantially, and the elective dose is a lot lower. So the standard arm is 70 gray in 35 fractions chemo as indicated. The experimental arm, you give 14 gray in 2 fractions, usually on a Wednesday and Friday. And then the following Monday, you start 40 gray in 20 fractions to the tumor plus elective volume with chemotherapy. And this, I think, is when you do the radiation calculations, it's a slight de-escalation on the tumor, a more impressive de-escalation on the elective volume. And I do have hope that this is going to be something that we are doing a lot more often. So for those of you who are interested in opening this trial, it's opening shortly in Ireland. It's opening at several Canadian centers, and we would love to have more people on board. I think it's going to take about 2 more years to accrue. Not many other phase 3s in the de-escalation setting. So in my last 2 slides, what would I do today? And I realize that this might be controversial and you might not agree with me, but I have seen people through both of the orator trials. And I think some people might say, I'm a radiation oncologist, I'm biased, but I've seen the pros and cons, and I'm not too far from the age that many people do get these oropharyngeal cancers. So if I had an early T-stage oropharyngeal cancer, I would enroll on short OPC if I could. I think that's a very good study, and it's a trial that I like both of the arms, and I would be happy to contribute to that trial myself. If I had a tumor where I could have TORS alone, I would consider that. But for every other tumor, I would go with 70 and 35. But I don't know that the benefits of 70 over 60 are that great. So if I was struggling in the last week of treatment, I would stop at 60 gray or just beyond. Because I think that delta of going from 60 to 70, the impact on OS is very small and recurrences could be salvageable. I realize not everybody agrees, but that would be my plan. Okay, well, thank you for listening. Thank you for joining today. I hope to see some of you at the ESTRO meeting. We will be doing a nasopharyngoscopy teaching session for residents. We have some 3D printed heads we are using for that. Please email me if you would like to join. So I'll just summarize here. Pharyngeal cancer are excellent in many patients. We have to think very carefully about what truly represents de-escalation. 2 modalities instead of 3 is de-escalation. 1 modality instead of 2 is de-escalation. We should bristle a bit when we have patients coming with positive margins who might have got away with dual modality instead of trimodality. Radiation versus TORS trials have favored radiation. And evidence-based medicine does not say, wait for a phase 3 trial before deciding what to do. Evidence-based medicine says you make a decision based on the strength of the evidence in the literature. And if there's no phase 3 trial, the next strongest level of evidence is a phase 2 randomized trial. I would have hoped more TORS versus radiation trials, but there have not been. And I'm not actually sure why the people who pioneered TORS have not done those trials. Finally, there's much more radiation de-escalation coming, and I think the future will really be about de-escalated radiation because we really have the ability to change our radiation dose very slightly or to a large amount to really find the right balance. So with that, I'll stop. Thank you for joining, and I'd be happy to take any questions.
Thank you for your informative and insightful presentation. Also, we have a question from our audience on YouTube live chat. If you don't mind, I can read it out. With the escalation strategies with toxicity endpoint improves the most serotonin, dysphagia, or feeding tube dependence. Repeat it one more. The question.
Yeah, could you repeat the question? The audio is just a bit glitchy. Sorry, could you repeat the question or perhaps type it out? I'm finding that the online platform is
with the escalation strategies, which toxicity endpoint improves the most serotonin, dysphagia, or feeding tube dependence?
Yeah, which endpoint improves the most? It's not feeding tube dependent because the feeding tube dependence is very low, even with 70 gray. I would say that it's probably the MDADI score is not a very sensitive tool. So you might only see a change in the MDADI, but those are clinically important findings. If you're choosing 4 instead of 3 out of 4 on the scale, it's a difference to you, but it's a small difference on the MDADI scale. So the things that we see the most are the sticky saliva, the dysphagia, and the coughing are the ones that gray.
Thank you very much for your answer. So let's move to the next section on thyroid cancer cases and discussions. And for that, we would like to invite our experts, Nakashi Sitaramo and Rakshit Sagar. Dear doctors, please go ahead on your presentation.
Hello. Hello, everyone. Yeah, we are not going to be discussing the thyroid case, so I don't know if that was a mistake.
Sorry for Dr. Rashid. I'm sorry, we have technical issue. So let's go and short break and we will return soon. Dear audience, thank you for staying with us. Dear doctors, go ahead.
I have technical challenges bringing up the slides, but let's get started with the case, and I'm going to try and see if I can bring up the slides as we continue the discussion, if that is okay. Dr. Rakshit, is that okay with you?
Oh, absolutely.
Okay. So this 71-year-old gentleman that I want to talk to you about is he has multiple 73-year-old. He has multiple comorbidities. He is a renal transplant recipient. He is on sirolimus and prednisone for post transplant, and he presented with dysphagia and feeling a global sensation and weight loss. He was noted to have a left soft palate lesion that was detected incidentally upon previously on a dental exam, and he took some time to get that followed up, and then finally when he had symptoms he went in to get the evaluation done, and this was consistent with a mass that was centered in the left tonsil and left base of tongue with some ulceration. So at that point, a biopsy was taken, and it was positive for keratinizing squamous cell carcinoma. P16 was positive, and then but the subsequent HPV testing on the tumor was negative. In terms of other comorbidities, our patient also has hypertension. He has, he did smoke cigars, for several years, no alcohol or illicit drug use. He does have some hypertension, like I said, and chronic chronic renal disease. As I mentioned, he has a renal transplant, but his creatinine runs around 2.3 to 3 post-transplant, and it's been stable for several years. He has a very committed nephrologist who's been following up on him very carefully. So, and in addition to that, on the tip of the tongue, of the tip of the nose, he was noted to have an ulcerating lesion that, seemingly had been neglected for quite some time. So that turned out to be a separate tumor, basal cell carcinoma. So with that, I want to, I know this is a very unique case, but I want to kind of, bring up the point that this is, with all the unique features that this case has, there are some commonalities, right? I mean, we do see some rare scenarios. These patients tend to have, our patients, not uncommon for us to be talking about, multiple primaries in the case of thoracic. In the case of head and neck malignancies, usually, we see lung cancer as well, or we are confused whether there is a separate lung cancer or metastasis. It's not uncommon for us to be in this situation, but this is a unique, case. But I wanted to get your thoughts on what you think about this. But by the way, can you see my slides now?
I can't. I don't know if now I can.
Mm-hmm. Yeah, okay, there is a little lag. Okay, all right.
Wonderful. Yeah, I mean, like this sounds like, some, obviously our patients don't always read our clean clinical trials, like, so we have these kind of real world situation in patients who have undergone renal transplant, and they're at risk for increased risk for non-melanoma skin cancers, as well as kind of, oral cavity head and neck cancers. I think some of the challenges in treating this patient that I can kind of see, it looks like he has a relatively locally advanced kind of, oropharyngeal cancer, which probably, takes a bit of precedence over the basal cell cancer, but also at the same time, kind of, how do we navigate if the basal cell carcinoma is indeed something that's very deep and something that needs to be maybe addressed at the same time, or we can't have significant delay in the in the management of that. And then how do we optimize kind of treatment for this patient who has a creatinine that's more than 2. So and probably an oropharyngeal cancer, where I'm thinking, given how it's locally advanced, probably not a good candidate for like surgical resection. So the question will be, if we are going to proceed with chemoradiation, what's our optimal kind of like concurrent chemo regimen? I think based on his creatinine, it would seem that probably cisplatin would be he would likely be cisplatin eligible. But then if he's cisplatin eligible, what do we kind of like end up using? Do we use like something carbo Taxol, but his creatinine clearance is quite low, and how do we support dosing for carboplatin in those patients, and will that leads to unexplained or unanticipated cytopenias and delay in his treatment? Or do we use kind of cetuximab, which is an option? And the other thing, sometimes I know for these locally advanced tumors, we are thinking about neoadjuvant treatment. Like, are we able to incorporate an immunotherapy with his history of like renal transplant? So definitely a complex case where I think we'll have to have like probably a close discussion with him, his transplant physician. And Alex, then what did you guys end up doing for this patient?
So to complicate the matters a little bit, so at the time when we saw him, his creatinine was actually on the best side, because I think he did get significant amount of hydration. He was in the hospital, and because he couldn't eat, and I think that helped him as well. A feeding tube was placed, and perhaps that helped him as well. But still, his creatinine clearance was 30 ml per minute. Like all of the all the infectious workup post transplant was negative at the time. So what so I stand corrected. The biopsy was basaloid non-keratinizing squamous cell carcinoma, as you would perhaps expect in this region. P16 was strongly positive. HPV, like I mentioned, was negative on the tumor. Further, HPV ctDNA through the NAVDEX platform was negative as well. The tip of nose was straightforward basal cell carcinoma. To complicate the issues here, the patient also has grade 2 neuropathy post-transplant, which I understand can be as prevalent as in 60% of the patient population. He has a baseline hearing deficit. So, again, a very complex, case, and further comorbidities to add to the picture. So that's, we just show some pictures here. There is as you can see here in the PET scan, there's intense hypermetabolism within the left palate, extending into the left lateral tongue, base of tongue, extending posteriorly to involve the left parapharyngeal soft tissues. Like you mentioned, I think this is, again, very advanced. This is not obviously surgically feasible without significant morbidity. He did not have any significant lymphadenopathy, but again, this was just radiological finding here. I do have the immunohistological slides here, as well as the P16 positivity on the left-hand side, and it's the basaloid non-keratinizing cell carcinoma. So yeah, I mean, no, adding to the complexity of the case. So what did we, so this is the basal cell carcinoma, and this is the biopsy of the basal cell carcinoma, showing typical basaloid features here. So, so in summary, we have this patient with 2 different malignancies, and as you can see, this is not a very superficial basal cell carcinoma. It was quite extensive, extending into the cartilage. So that was also advanced. But I agree, this is kind of given the intensity of the other malignancy, this was. This is kind of on the back burner. I mean, could place it on the back burner. So what we ended up doing is, I mean, obviously we discussed with the multimodality teams, and I think the most important thing is to make sure we had a good discussion and multidisciplinary tumor boards, engage all the stakeholders, patient, their caregivers, in our discussions, and that is what we did. And after a lot of debate, we knew that surgery was not a possibility here. Upfront radiation was something that could be done, though the extent of disease is significant, but it is within, as per our radiation oncologist, this upfront radiation with systemic treatment was thought to be the best modality of treatment. Now, the patient has significant neuropathy, so taxanes and platinums are out. Cisplatin is not something that we would consider here with a creatinine clearance of 30, a single kidney hydronephrosis in the remaining kidney. Not something that I would be able to comfortably consider in this case. So the next option really was to really to consider cetuximab as the radiosensitizer. So the patient did get bioradiotherapy. Dr. Rakshit, I want to get your thoughts on the choice of cetuximab. When do you use cetuximab in your practice?
So, Dharma, I think it's for some of the for these patients where obviously they're not cisplatin eligible, they their kidney function is not doing well, and then specifically if I am not so sure that they will be able to potentially handle carboplatin paclitaxel. I'm especially more worried about for these patients who have a creatinine clearance that's maybe even less than 30, because I worry about kind of how their cytopenias are going to be on treatment. So it's it is for probably our kind of our older patients, older, more frail patients. I know there is data in the P16 positive space that in direct comparison to cetuximab, to cisplatin, cetuximab is inferior, but unfortunately sometimes our patients are just not cisplatin eligible. And so I think if we truly have to get some of these patients through their entire course of radiation without any interruptions, I think sometimes cetuximab in these situations does come out to be a clear winner. So frail patients, renal dysfunction, have neuropathy, exactly like the case kind of that we have here.
Yeah, I mean, I have to say I agree with you. I mean, like you said, patients do not follow textbooks or clinical trial, data. So I think it is, this is not uncommon for us to see all these comorbidities, right, in our patients. So, I mean, I have used cetuximab in exactly the situations that you have mentioned, though my use has significantly been limited recently. But in this case, we felt that that was the best option. Now, I decided to also treat the basal cell carcinoma with vismodegib because it is a unique mechanism of action. There is no concurrent overlapping toxicities. So I decided to treat that as well. And, within a couple of weeks of starting that medication, his basal cell carcinoma, he had a complete response from that, as would be expected. And he did not have any overlapping toxicities. He was able to tolerate cetuximab. Of course, he had significant skin rash and occasional diarrhea, and hypomagnesemia, which we were able to manage. He completed his radiation as per schedule without any interruptions. He did have a G-tube placed. He lost a significant amount of weight during the treatment, but he's gained back his weight and he's doing really much better since the completion of chemotherapy and radiation. Has recovered significantly from the acute side effects. The post-treatment scan, which I don't have the pictures of at the moment, did show significant improvement, but there is still a focus of intense uptake in the oropharyngeal area. The basal cell, the tip of the nose, FDG avidity has completely resolved. So I'm pending a biopsy, and I'm hoping that that this is this is going to be post radiation changes. I've also, like I said in the beginning, we did do the HPV DNA testing, which was negative. So we have been sending tumor informed ctDNA monitoring as well, and that was positive in the beginning and has come down to zero, or not, to zero range. So I'm hopeful, but obviously there is a very high risk for local, regional, or even distant recurrence. And I want to be prepared. So that's why I thought I would present this timely case and get your thoughts on this. Let's say I hope not, I really hope not, but let's say for a minute that this biopsy turns out to be positive, there are persistent malignant cells. What would you do at this time? And I have a separate question from that. So maybe answer this. Maybe I'll have you answer this question, and then we'll go to a more routine case and perhaps answer the same question in that scenario.
Yes. No, of course. I think, I mean, as you described, as you were saying, as you're thinking through the cetuximab and radiation, and I'm like, I hope that he does not have any persistent or recurrent disease, because I think, it would pose kind of unique challenges. I think part of the discussion could just be like, like if he does have residual disease, like would he even be amenable to some kind of a very morbid surgical resection, which I think for his age and probably his comorbidities, I would say that, we probably won't go that route. And then we'll kind of have to think about our recurrent salvage, regimens, which, are typically, chemo plus IO. Now, in his case, I did not hear the PD-L1 score, but obviously the backbone that we tend to use is the carbotaxol.
PD-L1 was 30%. I'm sorry for missing that information.
So I think that with the PD-L1 being 30%, it begs the question, like, in that situation where we are, could we use immunotherapy? Now, I think traditionally, like, the risk for renal transplant rejection has been 30 to 40%, and I think it makes for a very close discussion, with the patient about that. If that's the case, do we use a regimen that's active, his PD-L1 is more than 20%, or do we choose to think about some kind of a non-IO regimen, like carboplatin, or go back on kind of cetuximab, given maybe that it will still provide some clinical benefit, or talk to him about the risk of neuropathy and closely monitor him and give him a taxane cetuximabs. But I think the key question there would be, like, are we able to use immunotherapy in that setting, and is there any data?
Yeah, I mean, so there is, as you know, there is emerging data, from the Dana-Farber group from Harvard, that and from other groups as well, that you can perhaps administer immunotherapy for renal transplant recipients safely with the use of mTOR inhibitors and steroids. So I mean, again, the nephrologist that is that was taking care of him is very academically involved in these type of discussions, and he was, I think there was a group of group of providers who felt that may be a reasonable option for him. But outside of clinical trial, I feel I'm personally very nervous to do that. Being on dialysis. And battling through through cancer is not an easy task. But also the patient was very averse to having anything that would affect, even if it's remote, that would affect the viability of his transplanted kidney. So we did have that extensive discussion, but we decided to not proceed with it, in case he were to have a like a persistent disease or relapse. But that's an ongoing discussion. If the data is very promising, I mean, they did note that there was 100% 100% safety with no, graft. But it's early stages. It's small study, so I don't know that I would be necessarily looking at that small data to say that I was that we will be offering it to all patients outside of clinical trials.
No, I think absolutely. I think it makes sense because I feel like the burden of if the graft does reject, the burden of going through dialysis 3 times a week, I think it's a significant burden for them. And I think it would have been even more critical if his PDL1 was really low. I think if the PDL1 is high, the patient is very, 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 very motivated that they don't care. I think in that case one may consider. But as you said, the data is still early. It would be really good to have some of these patients enrolled on trials where we can actually learn from what happens, similar to the study that you were alluding to from Dr. Han. I think where he had 12 patients who he treated successfully with cutaneous squamous cell cancer.
Yeah, the other I don't know, maybe you can answer this question. The other question that comes up is, these patients are on immunosuppressants, regardless of the PDL1 status. I would be concerned about the optimal immune response in these patients. So yes, there's a risk for rejection, but there's also a risk for lack of response, in my opinion.
No, absolutely. I think the data with IO probably much more robust in the cutaneous space. I think the response rates are much higher. And as you said, I think as we try to weigh the risks and benefits, as you rightly said, they are already on immunosuppression. We really kind of don't know, in a very large setting, what the response rate will look like, even if their PDL1 is high in this setting. So I think we'll have to proceed with extreme caution, and and hopefully we have some clinical trials in this space for patients who are motivated, and we want to see what would be the right thing for them.
Yeah. So now let me ask you, a different question here. Let's say that, we didn't have to, this was not as complicated as this, and this patient does not have a, renal transplant, and there is this persistent disease, but they did have some renal insufficiency, so they did get treated with, let's say bioradiotherapy, as in this case, and there happens to be a recurrence. What is your like in that scenario? Obviously, it's a clean cut scenario. What is your go-to these days with a PDL1 CPS of 30%?
I think in my mind, I think from what we learned from Keynote 48 was for these PDL1 CPS more than 20 subsets, I know immunotherapy overall in terms of long-term benefit can provide really long durable benefit in a good subset of these patients. But I always think of adding that chemo backbone, particularly based on kind of their burden of disease. Because if I worry that someone has a significant burden of disease and may not tolerate a quick progression, if I put them on just IO alone, I'd probably give them, some chemotherapy. And I think I have resorted to using carbotaxol as kind of the chemo backbone in that space if there's no, neuropathy or other contraindications. And I tend to, as you alluded to, do ctDNA testing to kind of also monitor the response as well as monitor them clinically. And as long as we get a good response, I have some, usually a low threshold to drop the chemotherapy, especially if their PDL1 CPS is high, because hopefully the chemo, gave me some safety that at least, I'm boosting up the response rates. And hopefully the immunotherapy is going to kick in and give them the long-term benefit. So prevent upfront a lot of cumulative toxicity with neuropathy or something, but hopefully get obviously it gets trickier, or rather I should say, what if the PDL1 CPS is between 1 to 20. I think in that case, I kind of follow similar principles, but the CPS is high, the burden of disease is not that great. I think, trial of immunotherapy upfront is something that I discuss with patients too.
Yeah, no, I agree with you. I also tend to use chemotherapy more so here. I mean, you and I also treat thoracic malignancies, and I feel like with head and neck cancers, the response to immunotherapeutic strategies are somewhat underwhelming compared to other disease types. You did mention skin. This is, it's a very immune-rich area. We are, the microenvironment is just not permissive to just, having a very good immune response. So I tend to also add chemotherapy, except perhaps in individuals who are very averse to it, or performance status doesn't allow me, or they have contraindications for chemo, or the CPS is very high, that I feel, and the disease burden is small. Those may be the situations where I use immunotherapy alone. But you mentioned the Keynote 048, and I mean like for even with CPS of 20%, it, the response rate was not very high. I mean, for any PD-L1 positive, it was even kind of on the lower side. So I'm not, I don't know when it would be appropriate to just do immunotherapy. I'm also in the same camp as you.
Yes, especially if I think that they have locally recurrent disease on top of distant recurrence. I think that any local recurrence in the head and neck area is often is in a critical area. I think the only cases where I really feel comfortable is if they have a distant recurrence, but it's just a small met in their lung, or in those cases we often utilize local therapies as well. But you're right. I think the response to immunotherapy is durable if you respond, but I think the response rates are still underwhelming. And so I am completely in that same boat in terms of not feeling so comfortable just giving them IO, especially if they are fit and otherwise would be a good candidates for chemotherapy.
Yeah. So I think, to kind of wrap up this discussion, the patient is committed to receiving further treatment. His performance status, believe it or not, with everything that I mentioned, it still remains at a solid 2. He started with 2, and he has a very good social support. So I'm kind of, like favoring a chemotherapeutic approach. I know, he has neuropathy, but perhaps, was thinking, dose adjusted carbotaxol may be my best bet at this point, or single agent, options like methotrexate and so on. We go down the list. We don't have very much options for patients like this who are not eligible for immunotherapy. Cetuximab is our best bet, but if there is there is progression upon that, we don't have anything. We don't have any options. Have you been routine? What do you think about that? Number one, and number two, have you been routinely sequencing all your head and neck tumors for actionable mutations or other mutations that may help guide your treatments?
Going to the question about what the therapeutic landscape kind of, or the options in this case, as you said, it's going to be challenging. I think starting off with chemotherapy makes sense because with chemotoxicities you stop and kind of you can get a handle on them, whereas with immunotherapy some of our toxicities can be kind of more long acting. Methotrexate, I would would getting cautious if the creatinine clearance kind of drops, because I would worry about the toxicity as well. But sometimes when we don't have great options, we just have to choose kind of what we have in front of us. With regards to the the next generation sequencing for these patients, obviously, I guess our initial, if they are eligible for all our standard treatments initially, even if their NGS shows something, I still go with our standard. But I am starting to do more and more NGS because we do have some of these patients who are remaining fit despite progression on 1 or 2 lines or standard lines of treatment. And if there is a molecular target for which we may have a clinical trial, it's always helpful. I would say that I found it very infrequently helpful, but I think in terms of trying to get to options, and as we explore more, hopefully, as we do more NGS testing for these patients, we may come up with targeted trials for them.
Yeah, I mean, I think this case calls for addressing these unmet needs, which is which many of our patients face. This was a unique case, but the scenarios, the components of this case are not that unique. We do see that renal issues or poor performance status or having another malignancy. These are very common scenarios in our practice. So I think this kind of calls for the judicious, perhaps advanced clinical trials that are able to include such patients, increase inclusivity, perhaps to obtain answers to real world questions. I really thank you for walking through this case with me and providing some feedback. I'm truly hoping that the biopsy will turn out to be negative and I don't have to be worrying about this. But now I feel a little bit more prepared than I was before this discussion. I do not believe that there are any questions on the live platform. So if there's anything that comes up, we'll send you an email later so we can address it. Thank you so much for your participation, and we'll move on to the next session, which is Dr. Randolph, Dr. Gregory Randolph from Harvard, will be talking about neoadjuvant therapy prior to advanced thyroid cancer surgery. Thank you so much.
Thank you, Dr. Sitaramu. It was a pleasure. Thank you.
Hello, this is Dr. Randolph, and I'd like to present on advanced thyroid cancer treatment, specifically the new innovation of neoadjuvant therapy prior to advanced thyroid cancer surgery as it relates to differentiated thyroid cancer. These are my disclosures, and with thanks to the inner circle, which is my research group, and the outer circle, which are all of my colleagues in a variety of different specialties that have worked with me over the years and with whom I've learned and do research. This concept, primarily a clinical trial on the use of lenvatinib prior to advanced thyroid cancer surgery, arose from a retrospective analysis of our patients that had been treated with neoadjuvant therapy. Neoadjuvant therapy is, prior to thyroid cancer surgery, is a new modality. The data on which we base our comments is nascent, and most of the clinical trials have not been fully written up other than in an abstract form. And so most of the signal of this approach, neoadjuvant targeted therapy prior to advanced cancer surgery, are arisen or have arisen out of retrospective analysis of patients treated over the last few years. In our example at Harvard, we combined our patients with those of University of Sydney, with Bruce Robinson and Maddie Guild, and wrote up a collection of a small number of patients that had been treated with neoadjuvant therapy, and this was published. This was a small group of patients with a variety of different histologies and a variety of different molecular alterations. As a result of that experience, retrospectively analyzed from those two centers, we came up with a algorithm which basically suggests that the agent that is chosen for neoadjuvant therapy should be based on a next generation sequencing panel of the tumor so that we know exactly the makeup of the tumor so that we can choose optimally the agent which would render the tumor most receptive. And this is based on a molecular profiling of the tumor. Unfortunately, we found that while there are ALK fusions, RET alterations, and BRAF mutations that can result in a druggable, actionable agent being chosen, most of the time, the next generation sequencing panel is bland and does not show a targetable, definitive alteration. And so we found that lenvatinib with a broader TKI profile was an optimal choice for those many patients who have bland NGS testing profiles with advanced DTC. And so the concept of lenvatinib really arose from this retrospective experience. As you know, the SELECT trial, which was run by Martin Schlumberger in Gustave Roussy, showed the efficacy shown here of lenvatinib for distant metastatic DTC with an impressive median progression-free survival of 18.3 months versus 3.2 months with placebo, with an overall response rate of 65%. So that means nearly 2/3 of patients respond with a 30% volumetric reduction of, for example, disease in their lungs. This is, again, the SELECT trial, the treatment of lenvatinib for patients with distant metastatic disease. So that's an impressively effective agent as agents go for metastatic DTC. And it turned out when we looked at the data that the median time to response, that 30% shrinkage in 2/3 of patients, occurred within the first 2 months of treatment. So this is a very effective agent. It is agnostic to the NGS testing, and those changes occur within the first 2 months. And so these features of the SELECT trial made us think that this would be an optimal agent to consider in a neoadjuvant setting. There are certainly side effects of lenvatinib. The broadness of its TKI inhibition comes with off-target effects listed here, but only 14% of patients needed to come off the trial in the SELECT trial for those off-target VEGF-related effects. And again, these are patients treated for distant metastatic disease, so these are patients treated over a long period of time for distant metastatic disease until they develop a resistance mutation and need to be switched. So we felt that this would be much less likely to be a problem in patients treated transiently over a period of months only for in the neoadjuvant environment. So this led to our multicenter phase 2 trial, which I will discuss here today, showing combination of Harvard. We are the PIs. Myself and Lori Worth, my medical oncology trusted colleague, and also our friends at MD Anderson, Mark Zafario and Naifa Busade, and our friends at Memorial Sloan Kettering, a 3-center trial at Memorial Sloan Kettering, Rich Wong, Alan Ho, Eric Sherman, and Jim Fagan. So this is a phase 2 study looking at neoadjuvant therapy for patients with bland NGS testing presenting with invasive DTC prior to surgery. 28 patients were enrolled in this study. The inclusion criteria were adults with local, regionally advanced, or advanced invasive recurrent DTC. They were therefore, based on axial scanning and laryngeal exam, deemed to be at risk for an R2 resection, that is, gross disease at the margin. The evaluative modalities prior to surgery were laryngeal exam and axial CT scanning, and the 3 centers listed here. Patients received up to 6 cycles of lenvatinib, restaging at 2, 4, and 6 cycles, and surgery was initiated when patients were felt to more likely have an R0 or R1 resection based on the serial axial scanning and laryngeal exam. Lenvatinib was stopped 7 to 10 days for a washout period prior to surgery. This is the study schema, which is listed here, showing initial intake, CT scan and laryngeal exam, and then 2, 4, and 6 cycles, reevaluation after every 2 cycles with repeat scanning and laryngeal exam. Primary endpoint was the patients achieving an R0, R1 resection. Our classification for margin status is, as noted here, R0 negative, R1 microscopically positive, R2 grossly positive. We also sought to evaluate the MMM score, which is a construct that our 3 centers put together, Harvard and Memorial Sloan Kettering and MD Anderson, which is a global composite score that relates to the distribution and surgical complexity and patient morbidity of invasive thyroid cancer disease. And I will discuss that metric a little further in a few slides. We looked at best overall response radiographically and R0, R1, R2 resection margins, not only overall for the patient, but also at 5 target interfaces, histologic varying target interfaces: muscle, cartilage, larynx, trachea, esophagus, nerve, recurrent laryngeal nerve, and major vessel. In terms of the MMM score, this is just a diagram to identify the makeup of the MMM score. So if the arrow points to an area of strap muscles, if the strap muscles are involved, then they are resected. And so the MMM score you would get a point for that, but you wouldn't get many points because the strap muscles are easily able to be removed. They have very little in the way of surgical morbidity. There's no real reconstructive issues, but it's non-thyroid tissue, and so you need to get a point because it isn't thyroid tissue and you're taking it out for an invasive thyroid cancer. If, on the other hand, you remove the nerve, while that is not a large volume of tissue, it has much greater functional significance. But you can, and so patient morbidity is also recorded with a unilateral nerve resection. However, you can reconstruct that with thyroplasty. You can improve voice and swallowing outcomes. And so you get several more points than you would, say, with a strap muscle resection when the nerve is resected. However, if both nerves needed resection, then you would get many points on the MMM score because that would have tremendous functional and reconstructive complexity issues involved in it, so that would be reflected by a much higher MMM score. Similarly, if you had a long tracheal segment resection, that would generate a number of points, many points. And similarly, if the carotid artery needed resection, that would also be non-thyroid tissue that would get you many points because of the surgical complexity and the reconstructive complexity involved in carotid artery resection. So the MMM score then is a metric of invasive thyroid cancer that relates to the distribution of anatomy that is involved in the invasive cancer, the functional aspects of that tissue that is involved, the surgical complexity of removing that tissue, and the reconstructive complexity involved in that resection, as well as the associated patient morbidity. So eligible patients, locally advanced adults with either persistent or recurrent DTC, deemed at risk for an R2 resection based on fiber optic and axial imaging with adequate ECOG scores. 28 patients were enrolled, mean age 61. Interestingly, we had a combination of both primary invasive disease but also DTC recurrent invasive disease in about a third, and these performed equally, as I will mention. Most patients had PTC, 82%, with a smaller number having oncocytic protodifferentiated or follicular. All of these patients, however, were DTC. The average time on lenvatinib was 4.5 months, about 5 cycles, 82% of the patients presenting with widely invasive disease were able to undergo surgery after neoadjuvant therapy with lenvatinib. And interestingly, at the bottom, you'll see that 84% with primary disease and 78% with recurrent invasive disease underwent surgery. So it looks like lenvatinib prior to surgery is useful both for invasive primaries as well as invasive recurrent disease. And as I mentioned, 82% of patients enrolled underwent surgery after neoadjuvant therapy with lenvatinib, and of those patients enrolled, 71% had R0 and R1 resections. So quite a positive signal, both in terms of being able to successfully go through with surgery, but also having quite a reasonable, successful margin status with a R0, R1 resection, which is considered successful in the setting of DTC. This is the best overall response rate shown in this waterfall plot. Also, the MMM score that I had previously discussed, which is kind of a global anatomic, surgical complexities, reconstructive complexity, patient morbidity score that relates to the distribution and extent of invasive disease on the left at presentation, in the middle decreasing at during neoadjuvant therapy, and on the right at surgery, the actual MMM score relating to the actual tissue resected at surgery. And so you could see there was a significant downshifting decrease in MMM score through neoadjuvant therapy leading up to surgery in the right-hand column. In terms of so overall, R0, R1 resection rates relate to the patient globally overall. I had an interest especially, though, in looking at the margin status and need for resection of the individual target interfaces, including muscle, nerve, cartilage, esophagus, and great vessel. We are in the process of evaluating that information to give a more granular subtype response to neoadjuvant therapy, depending on the actual R2 interface tissue type that we're dealing with. But obviously, we're especially interested in the recurrent laryngeal nerve. So I will provide you with some limited data, which is really quite encouraging and frankly was unexpected in terms of the RLN's response to neoadjuvant therapy. And so one lens on that was, did we think that the RLN required resection with preoperative evaluation based on imaging? This is primarily either with vocal cord paralysis or with significant tracheoesophageal groove infiltration. And so there were 10 patients who the surgeon judged based on laryngeal exam or based on tracheoesophageal groove infiltration would require RLN resection. And after neoadjuvant therapy, only one of those 10 patients required resection. So it looks like there is a downshifting of expectation of needing to take the nerve, and actual need to take the nerve is significantly reduced. Only 1 in 10 nerves felt that needed to be resected, required resection after neoadjuvant therapy. So it looks like there is a great ability to preserve nerves through neoadjuvant therapy. And then I wanted to shift a little bit to another dynamic of the potential for neoadjuvant therapy causing resolution of a patient who presents with vocal cord paralysis. It's very common in DTC presenting that there's vocal cord paralysis through significant invasion of the recurrent laryngeal nerve. So these patients often present with vocal cord paralysis. And we had published, again, now I'm leaving the clinical trial that I'm describing. I will get back to that in a second, but just going to a article that was recently published by our group with 3 other centers, looking back at retrospective data at can the vocal cord paralysis recover with neoadjuvant therapy prior to surgery. And this we have termed the Lazarus effect. This paper showed that there were an accumulation in 3 different centers of 7 patients, all of whom had advanced thyroid cancer, who presented with vocal cord paralysis. And all 7 of these patients had resolution of their vocal cord paralysis, hence called the Lazarus effect. It's a range of histologies, these 7 patients, a range of genetic alterations, but all of these 7 patients regained vocal cord function during neoadjuvant therapy prior to surgery. The average median time to return to vocal cord function was 3 months. The issue here also is that of those 7 patients presenting with focal cord paralysis prior to surgery, only 1 patient required nerve resection. So this Lazarus effect, this historical cohort of patients who had improvement of vocal cord paralysis prior to neoadjuvant therapy, has another lens on potential advantage of neoadjuvant therapy as it relates to the nerve, is that if it is paralyzed, it may wake up. The problem with this paper is that although we described this in 7 patients, we didn't really know what the denominator is. We didn't really know how likely is that to happen. We described it in 7 patients. We clearly saw that it occurred in enough with enough of a signal to be able to be seen in these 7 patients, but we didn't know how likely is that to occur. And so now we go back to the discussion of the neoadjuvant lenvatinib trial, and that, I think, although early data, nascent data, gives us the denominator in the clinical trial. Patients presenting with DTC that's invasive, we had 5 patients who presented with vocal cord paralysis, and 1 of them had vocal cord recovery prior to surgery. So again, small numbers, nascent data, but a signal that suggests that it could be up to 20% of patients presenting with vocal cord paralysis may have recovery prior to surgery. So to summarize, the nerve seems to be poster child for potential benefit from neoadjuvant therapy. You heard on one hand that only 1 out of 10 nerves that the surgeon felt were going to require resection actually required resection with neoadjuvant therapy. So it looks like nerves may be able to be more commonly spared, and the other lens on neural preservation is that it looks like you have perhaps up to a 20% likelihood of vocal cord paralysis recovery prior to surgery with neoadjuvant therapy. So less nerves needing resection and some nerves potentially recovering prior to surgery. So a very interesting data set as it relates to the histologic group of invasive DTCs that are involving the nerve. It looks like neoadjuvant therapy is very interesting and has quite a signal, which may result in neural preservation in a much greater percentage of patients than without neoadjuvant therapy. We, of course, are giving lenvatinib with VEGF activity to patients and then operating on them, and so we were concerned about fistula or bleeding either during neoadjuvant therapy or perioperatively. And the adverse events we found are listed here, fairly well treated, and we found no evidence of fistula, bleeding, or delayed wound healing during neoadjuvant therapy or postoperatively. So again, majority of patients, over 80%, able to get to surgery, over 70% ending up with R0, R1 resection. This is applicable to both primary and recurrent disease, and no fistula or bleeding. And lenvatinib seems to be a rational choice, which is agnostic to the NGS alteration, which gives it much broader applicability. And it seems that the nerve, both in terms of avoiding sacrifice and potentially recovering if presenting with vocal cord paralysis, is a very significant signal, positive event on the neoadjuvant landscape as it relates to DTC treated with lenvatinib prior to surgery. This is just one example of male who presented with actually a large invasive node adjacent to the inferior pole. This was felt to be inseparable from the longus colli, trachea, esophagus, TE groove infiltration. Therefore, the nerve was felt to be at risk. Other arterial interactions that were intimate. We did NGS testing. This is our MEE advanced cancer 6-point checklist looking at laryngeal exam, possible R2 interface, mediastinal involvement, nodal distribution, whether metastatic disease is present below the clavicle, and what the molecular alteration is. If you have these 6 data groups, then you, I think, can well manage patients with more advanced thyroid cancer. This is his initial set of imaging. You show a trachea, esophagus, and prevertebral fascia that are indistinct and potential R2 interfaces. After several months of lenvatinib therapy, the mass does not shrink down volumetrically very dramatically, but it becomes much more nodular with a clearer margin. And this patient was treated with 4 cycles. His MMM score went from 22 to an actual score of 2 at surgery, and he had an R0 resection. The nerve, which is dotted white line, in its inferior straight portion was free of tumor, but in the curved section it was distorted and through involved and required resection. But with that resection, this was an R0 resection. I want to invite you to our upcoming meetings. We have a 30th anniversary of our excellent Harvard surgery of the thyroid and parathyroid glands, November 20th and 21st. This is a QR code for registration. This is our 30th anniversary. Excellent group of topics and really superb world-class faculty. And then also, of course, the World Congress on Thyroid Cancer, which is in Paris in 2027, June 23rd to the 26th. We expect perhaps 1,500 attendees from perhaps 90 countries. It's a global program, multidisciplinary and global, and I know you will enjoy yourself in Paris. Please consider that QR code to get more information. And with that, I want to thank you very much for your attention. Thank you.
Associated Professor of Medical Oncology Department, Biomedical Sciences, Humanities University, head of Head and Neck, Skin and GI Oncology, Medical Oncology and Hematology Unit, Humanitas Cancer Center, ERCCS, Humanitas Research Hospital, Italy, Paolo Bossi, and he will speak about pathological perspectives, molecular biology, and biomarkers of head and neck squamous cell carcinomas. Professor Bossi, very welcome.
Thanks so much. Thanks so much to all of you for this very kind invitation. So I'm gonna show you the slides. Could you just please tell me that all is okay?
Yes, of course.
Perfect. So we are speaking about pathological perspective, as you mentioned. So this is the agenda of today. I will start by speaking about the molecular biology at the premalignant level, because this is where everything starts. Then we'll try to identify why we had in the past many mirages about targets in head and neck, squamous cell carcinoma, and what is the reality. We'll have a look to the mutation analysis, to the functional analysis. We'll just open a window on liquid biopsy because we have no time, and we will finish about biomarker for response to immune checkpoint inhibitors. So we will not speak in so much details about what is already well known, like HPV or PD-L1 CPS, because this is something that is many times has been discussed. I'll try to give another possible view on different topics. Let's start from premalignant, or better, potential malignant diseases that are all the lesions that can happen in the oral cavity and in another setting in the laryngeal mucosa, and that can transform or not into cancer. So what we know about this type of lesions? First of all, we know that the immune microenvironment is crucial in the process of malignant transformation. And as you can see on the right part on the slides, you may see how the impact on the shift between a more immune competent or, on the other side, a more immune deprived microenvironment can really be crucial in this transformation. And there are many actors, as you can see here. Of these actors, inflammatory cytokines, immune checkpoint inhibitors, different population of T cells and B cells are involved. There is not only the immune mechanism, but also the old field of extracellular matrix that is involved a lot in this process. And just citing the role of the extracellular matrix with the fibroblast, with the impact of TGF beta as an important cytokine that can change this matrix, and also on all the impact about hypoxia and vascular endothelial growth factors. And lastly, just to give you a flavor how complex sometimes these elements are, I like to shed light on the neural microenvironment. You may see here that also in the process of developing an oral squamous cell carcinoma, there is an action driven by the brain itself, or a direct brain by an increase in the nerve density by means of different neural growth factors, or by an indirect stimulation by cortisol or other growth hormones. So just to give you an insight on how complex is the process of malignant transformation, how cannot leverage only on one single mechanism that can justify it. So having spoken about the pre-malignant, let's go to what we treat as medical oncologists more frequently. So the head and neck cancers in their early or local advanced setting. In the past, as you know, we had this mirage of the head and neck as a single gene-driven cancer. When we discovered about 25 years ago the importance of epidermal growth factor receptor and its ligand TGF, that were overexpressed in more than 80% of the cases. Then we thought to solve the issue as somewhat was happening in lung cancer, but that was not true. And what we know now from a more in-depth evaluation is that all that glitters is not gold, because we discovered that there was a limited activity by blocking EGFR alone. And even the prognostic role of EGFR as a whole is debated. And I'd like to show you the results in a nutshell in this table of the prognostic and predictive value of EGFR in head and neck cancer. As you can see here, there are a lot of know about the prognostic role of EGFR expression, activation, polymorphism, even mutation in head and neck, and in particular, for what concerns the predictive role of EGFR overexpression, this is true only for some combination of treatment with radiation in terms of expression. This is a predictive role. We do know that a patient with a high expression of EGFR may benefit from a more intensified radiation setting, so in a hyperfractionated or other altered way of fractionation radiation. So for the other fields, the evidence of the role of EGFR is really limited. So let's look more in depth, try to dissect the mutational status of squamous cell cancer of this area. These are the seminal papers that have been published in 2011 in Science, put together by Nishan Tegrawal and Nicholas Stransky. And these are the evaluation that a few years after who appeared on Science about the comprehensive genomic characterization in the Cancer Genome Atlas Network. What we learned from these papers, that between 50 and 70 genes and 100 genes are mutated in head and neck cancer and can be considered as candidate cancer driver genes. However, many genes are mutated but at very low frequencies. And what we really need is try to understand their functional status. This is in a single cartoon, the amount, the frequency of alteration of single gene mutation. You can see here TP53, it has the lion's part, followed by CDK and 2A, PI, PIK3CA, the Notch1, and the HRAS at the lower frequencies. We do know also that the pattern of gene mutation is very different between HPV positive and negative cancer. And I'm gonna show you here in this table, where you can see here that the HPV positive cancer are more mutated in the PIK3CA and less in the P53, while the HPV negative cancers have a completely different patterns of mutation. They have more in a more frequent way mutation of genes, but also the type of genes that are mutated are different. In another way, you can see here, on your left, in the HPV negative population, you can see that the amount of mutations are higher than in HPV positive, and the HPV positive mutation are clustering in the PIK3CA type of mutation. And that's quite interesting at this different molecular level. So thanks to Samantha Haselleiter and to the Professor Amanda Spsiri, I'd like to show you the implication for what concerns the ESCAT framework of the current genomic and actionable landscape in head and neck cancer. We do know that previous work, as the ones that I've presented to you, or this one that has been recently published, described the no actionable molecular alteration in head and neck cancers that could be confined to these more frequent genes. You will recognize that most of the genes that I have already spoken with you in this table they are categorized according to the type of actions of their corresponding proteins, so the cell cycle, DNA repair pathway, the pathway of PIK3CA, the TKA pathway, epigenetic, and many others. But what we do know in this cohort of patients that the colleagues presented before have collected, they are not just leveraging on the TCGA, but they have collected a huger sample issues, both in HPV negative and positive diseases. And they found out that as a whole, the type of mutation in terms of genes is not different from what has been already presented from the two Science seminal papers in 2011. What these authors were really very impactful in showing was the fact that they tried to put this mutation into the SCAT category. For who is not confident with this type of differentiation of classification, the SCAT tried to create a different level of evidence. So by a classification that define that the SCAT mutation tier 1 as the ones that they are ready for routine use, tier 2 as investigational, tier 3 and 4 and just hypothetical target, and tier 5 as a combinational development, while tier X with a lack of evidence. And when they try to understand what about the mutation they identified, you can clearly see here that most of the mutation in head and neck squamous cell arena are tier 3, so not, as if you can go back, they are just hypothetical target, not even investigational or ready to use. So that is something that from the mutational point of view of DNA, we do know. So if you would like to go beyond the mutational status and try to put an integrative genomic analysis in association with the functional mutation, this could be of a higher value because we may identify potential markers for prognosis and what is more interesting to us as oncologists, something that could give the possibility to have signatures with a predictive value for new treatments. And I'd like to show you some gene expression signatures that could have both a prognostic role and help identify new therapeutic pathways in this disease. And I'd like to start with the fourth papers by Christine Chan that has been published 20 years ago with a very nice and elegant analysis of gene expression patterns of 60, only 60. Don't be surprised about this, but it's just it's the first paper that was published about this. And Christine was able to identify throughout a hierarchical cluster analysis at least 4 distinct molecular subgroups. And they defined them as an EGFR signaling pathway, a mesenchymal one, a normal epithelium-like subtype, and a group 4 more linked to exposure to cigarette smoking, so what we could call xenobiotic metabolism. And also in the following years, other classification with a higher number of patients appeared. This is in the clinical cancer research. You can see here that the sum of the clusters identified are really similar to the first ones depicted by Christine Chan. And this is the 5 cluster, 2 related to HPV, 3 non-HPV related, that have a direct counterpart in the combined overall survival. So it's a nice way to present how gene expression profile can subdivide head and neck cancer and squamous cell cancer into different prognostic models. And also in National Cancer Institute, we built this type of classificators with 6 different clusters. We named them as an HPV-like, mesenchymal, hypoxic, defense response, classical one that was very similar to the first one depicted by Christine Chan, and an immunoreactive one. And throughout the survival analysis, you can see clearly here that if we apply this classificator to the TCGA or to another series of patients, these clusters have a direct implication in prognosis, both OS and relapse-free survival. Another interesting point is trying to apply this way of functional annotations into HPV-driven and non-HPV-driven. Let's start from the HPV-driven. This is a work on more than 200 HPV-positive cancers, but where there was a validation of a 3-cluster models. You can clearly see here that there is a very low-risk HPV-positive patient that is associated with the highest level of immune score. So memory CD4 T cells, memory CD8 T cells, and more B cells that are very important in this type of disease. While on the opposite, there is a high-risk group of patients where you may find more hypoxic gene expression features, more associated with TGF-beta signaling and P53. These are the patients with an HPV-positive cancer who are also maybe more related to smoking. You do know that there are also these overlapping between HPV and smoking features of this patient. And what about the HPV negative? If there is also an heterogeneity of the tumor microenvironment, and you can divide into the mesenchymal subtypes, that is considered the ones with the strongest enrichment for immune cell types, then the atypical subtype, the basal and the classical, who the classical is the one that is more linked to a severe immune depletion. So this is as a counterpart into prognosis and could also pave the way towards a different way of targeting, maybe with more immune checkpoint inhibitors in the more inflamed subtypes, and with other type of treatments trying to restore the immune sensitivity, or going towards other type of drugs into the less immune infiltrated tumors. So I'd like just to finish this first part telling you that it's not just only the dichotomy between HPV positive and negative. And the group of Raylan Lemans and Ruth Brackenoff nicely showed in this paper how we can face 3 types of disease. The 2 ones that I've already presented you, so the HPV positive cancers, and the ones that are more linked to tobacco smoking. But there is another one that is considered as an HPV negative, and curiously, it is a CNA copy number alteration silent tumors. you can clearly see here that the difference between this copy number alteration high and this copy number alteration silent. And interesting, these are the tumors presenting more HRAS mutations, and they could be linked to the female sex maybe, and with a higher age. This is just some assumption. They are not so frequent, but there could be another way to present this type of classification. Then I'd like to spend one slide about this concept that is quite interesting, the concept of the second field tumor, second primary tumor, and local recurrence. This is something that as clinicians we tend to consider often as only one situation. Now, we do know that you can have a local recurrence when the same cancer cells that has been excised can get the start to another cancer, and this is really local recurrence. While if you have the progression of an altered field within the field of the previous tumor, these could be considered as second field tumors, so clinically local recurrence or a second primary tumor that shares a lot, but not all the characteristics with the primary tumor. And then there is the possibility to have a progression of an independent field, and this would be considered as a true second primary tumor. That's important also in terms of molecular differentiation that could pave the way towards different type of treatments. So just opening the window for the future into the topics of liquid biopsy, I cannot go into details, but just telling you that is a real is an early advance in this topic. We have more information from other cancer, but now even in head and neck cancer, there are a lot of development in the last few years. And liquid biopsy could go for tobacco-induced cancer and for virus-induced cancer, both HPV and EBV, where we try to identify viral DNA in the EBV or HPV-related cancer, while you can see for the other tobacco-related cancer, you can look for ctDNA as well as for methylated ctDNA, exosome, and something other. So just to give you this flavor about the importance of the molecular biology into the setting of liquid biopsy. What about other biomarkers? So we do know that that's, for me, it's a very important assumption that before starting any discussion on new biomarkers, because if tumor biomarker tests are going to be used to drive the patient care, then an understanding, careful assessment of this concept are essential, because a bad tumor biomarker test is as bad as a bad drug. So that's very important. We should follow a very specific path to identify a new biomarker and to categorize it in different way of testing. So you can use biomarker for screening, for differential diagnosis, for prognosis, and to predict the therapeutic activity, as well as to monitor the disease status. And to identify new biomarker, there is a very strict and scientific way to proceed with the discovery and test validation stage, like the ones that we have for drugs. So this just to give you the importance of identifying biomarker in a rigorous way, because the application of biomarker as a strong counterpart into the activity of new drugs, into the selection of the drugs that we are going to use, as well as into the determinants or determination of new algorithms for survival. And I just gonna finish my presentation with what could be the new frontiers in personalized medicine in recurrent metastatic cancer. We have a lot of candidate molecular tumor markers that could stratify this type of cancer patient that are treated with immune checkpoint inhibitors. We do know that for the time being, we are using only the PD-L1 as a CPS score, but this is absolutely insufficient, and we do need a more granular differentiation of patients according to their predicted, expected working of immunotherapy or not. And the infiltration of the lymphocytes into the tumor, in particular CD8 positive lymphocytes, as well as the tumor mutational burden. We have less to know because there is no huge expression of mismatch repair deficiency genes, while we have more experience about the T cell inflammation and the gene expression profile, in particular the interferon gamma signature has got a growing body of evidence about the possibility to derive a signature to infer the sensitivity to immunotherapy. We are also studying the co-expression of other immune checkpoint regulators, like the ones that you can see here, but many other exist in literature. And there is a new frontier that there is the one of microbiota that is quite appealing to me, but it is still in its infancy. So this is just an overview. I'm not going into so much details in these 20 minutes, but I'd like just to give you the flavor, the importance of molecular pathology as a determinant of prognostic and new predictive way in this type of cancer. And having said this, I'd like to thank all of you. These are my emails, so feel free to contact me for any type of clarification or any type of doubts you could have. And thanks again.
Professor Bossi, thank you very much for your very interesting, meaningful presentation. I have a question for you, and for me, very interesting your personal opinion. So, what do you think? Are we depending on PD-L1 more than we should when choosing treatment?
Yeah, so as I'm used to say, PD-L1 is just as trying is a good biomarker because it's the only one that we have. Is a good biomarker, but it's like trying to have a picture of the moon with a very old photographic machine. So it's just you can see the moon, but you cannot see all the details of the moon as we have with the Artemis expedition in the last weeks. So PD-L1 can orient you, but do not trust too much in this biomarker, because we do know that for instance, when we treat first-line cancer patient, recurrent metastatic cancer patient with head and neck cancer, with immune checkpoint inhibitors, with a low expression of PD-L1, the probability to having a response is 17%. With a high, that I mean after 20, above 20, the probability of response is 23%. So the difference is only 6%. So what are we speaking about? It's just a sign, just a little, just a flavor, but it's not the whole reality. CPS is not capturing all the complexity of a very immune deprived tumor microenvironment as the one of head and neck cancer is.
Thank you very much. So we are continuing our virtual summit. Thank you everyone for staying with us. Our next speaker is Oren Karapetyan, radiation oncologist from Erebuni Radiation Center, and also medical writer at Intelligence Unit of OncoDaily. He is author of our very famous and interesting article about radiation oncology, and he will speak about advances in nasopharyngeal carcinoma contouring and target definition. Dr. Karapetyan, please. Dear audience, we will continue after 3-minute break. Thank you very much.
Hello everyone. Sorry for short little technical issues. My name is Aren Karapetyan. I'm radiation oncologist at Erebuni Radiotherapy Center, also a content writer, content creator at OncoDaily. And today I will show the advanced pharyngeal carcinoma monitoring and target definition, the updates. And there we go. Let me start. Sorry. And sorry for technical issues. Why contouring in nasopharyngeal carcinoma is challenging? It's three main points. First one is submucosal spread of the disease and frequent nodal disease, involvement of lymph nodes, and close proximity of organ risks, and also complex skull-based anatomy and contouring and treatment of skull base. So today we should discuss two papers that we use in our institution for contouring and target delineation of NPC. First one is the international consensus guideline on the clinical target volumes at the different dose levels of NPC. It's published in Red Journal at October 25. And second paper is Radiotherapy Guidelines 25, DAHANCA, the Danish Head and Neck Cancer Group. So this is the two main papers that we use in our institution. And first one that I want to mention is use for simulation MRI scan and PET-CT. So MRI scan we use it's mandatory for use MRI scan for primary tumor delineation. And PET-CT we use mainly for a primary tumor also, but mainly we use for lymph node contouring for lymph nodes and integrated boosts in lymph nodes. So first one that I want to discuss is a high dose volume comparison in these two papers. I mean the primary tumor. In IG24, as showed in this, so our gross tumor plus the DAHANCA recommendations, there was mandatory plus 5 millimeter for gross tumor. So it's primary tumor and some gross lymph nodes that we want to boost. Second one, it's intermediate risk comparison. So it's a 60 gray critical point. It's covering the whole nasopharynx. So and IG and DAHANCA recommend to nasopharynx for 60 gray, and mainly it's done by if we look at IG, it's 8 to 10 millimeters, and if we look for it's GTB plus 10 and nasopharynx should be included. And when we look at this screenshot, we can see the board, so the volume of whole nasopharynx that was treated by 60 gray. So it's very critical contouring and treatment of NPC. It's covering foramens of the skull base, so it's over foramen ovale, rotundum, and lacerum. And in about oval and rotundum, it's selective ipsilateral in eccentric tumors per IG24. So it's recommended by both the covering of foramen oval, rotundum, and lacerum. Also, the covering of and including in our volume of the clivus of the skull base. So if it's uninvolved, anterior 1/3, it's enough. So if it's involved, sure, we should cover a whole clivus. And also we cover inferior part of the sphenoid sinus and also posterior part of nasal cavity and maxillary sinuses. So it's also very important to cover. And cavernous sinus coverage. So it's there was and there is a lot of discussions about the coverage of sinus coverage. If we look at IG24, it's ipsilateral only if there is a T3 or T4 tumor. And if you look at the ANCA, it's including the cavernous sinus if we have ipsilateral invasion. And about the elective neck, so in this screenshot you can see the neck anatomy and lymph nodes. So bilateral retropharyngeal or bilateral 2, 3, 5A and 5A, 5B, or fourth level lymph nodes, and only including the 5A and third level if we have some involvement or there is some gross lymph node we have. And when we look at the HANCA, it's let's say it's the similarity is low. So the ANCA recommend to took for second, third, fifth A and seventh A, also the seventh B, and also the pharyngeal lymph nodes. And if we have some involvement of lymph nodes, the ipsilateral 4th and 5B levels. About 1B, first B level of lymph nodes, there was a lot of paper discussions about it. So IG24 recommend if there is some oral cavity or anterior nasal cavity involvement, or for sure the gross involvement of first B level, so we should cover these lymph nodes. And for the ANCA, it's almost the same. So selected ipsilateral 1B coverage if we have some involvement. Very, very important questions for all, I guess, for all radiation oncologists. How to handle with post-induction chemo volumes, because when patient underwent induction chemotherapy and we have a shrinkage of the volume of the primary tumor or some bulky lymph nodes, so there is challenging to choose the right volume and how to contour it. So IG24 recommend post ICGPs. So when we do MRI and after the induction, we use this MRI for contouring the 70 gray volume. In our institution also we use post-induction volumes, not the pre-induction volumes, because it's increased the toxicity and we in practice we just irradiate healthy induction. We use pre-induction, and how it's recommended in IG-24. We use pre-induction volumes, but in all other cases, we use the the post-induction volumes. About the borders, so if we look at the IG-24, here you can see the level when we start to contour the second level lymph nodes. It's skull base when from the skull base, and posterior also there is a important change in last update that let's say historically we contour by sternocleidomastoideus muscle, but now in the latest update there is a posterior edge of infrahyoid strap muscle, slight little change in the lymph node volumes. And in the end, take-home messages. So MRI fusion and PET-CT fusion is mandatory, as we say, MRI fusion for primary tumor, and also why not? We can use this for skull base, for 70 gray volume contouring, like for nasopharynx, and PET-CT is mandatory for lymph node evaluation to find the involved lymph nodes and do a boost to them. Skull-based contouring remains critical and let's say challenging. So post IC contouring is practice changing because now we know that we should use post IC volumes for gross tumor, except when we have extranodal extension for the lymph node. So in this case, we can use pre-IC volumes. Thank you.
Thank you very much, Dr. Karapetian, for remembering us about power of radiation oncology. We have a question from our audience in live stream. So, do you think two experts contouring the same MPC case will still significantly differ, and why?
I don't understand
maybe he mean that in one institution or in different contouring is the same, or are any differences, and why it happens?
I guess in main part of the world, main institutions use these two papers for contouring. I guess if there is some differences, it will be little differences, not very critical differences. Because in the whole world, these two papers that was on these two papers, so I don't think that there will be any big differences.
Okay, thank you very much, dear audience. Now we have break. Please wait our other stations.
Oh, okay. Sorry about that. I think the technical issue was on my side. Thank you so much for returning for our block 4. We had a very interesting block 3 session that had very interesting discussions on nasopharyngeal malignancies, HPV-driven oropharyngeal cancers, and thyroid malignancies. Now we return to a very interesting block 4 representing North America with a focus on how translational science, equity, precision radiation, and surgical innovations are shaping modern head and neck cancer care. This session will bring together experts across medical oncology, radiation, surgery, highlighting the importance of multidisciplinary collaboration in head and neck cancer management. Our first speaker is Dr. Ari Rosenberg, a medical oncologist at University of Chicago Medicine, whose work has integrated basic translational and clinical research in head and neck cancers and thyroid malignancies, with a focus on novel therapeutics, including immunotherapy, while reducing treatment-related toxicity and preventing and preserving quality of life. Next is Dr. Coral Olazagasti, who I've worked with very closely, a medical oncologist and an assistant professor at the Sylvester Comprehensive Cancer Center at University of Miami. Her work has really centered around equity, advocacy, and addressing cancer care disparities. And then my colleague, Dr. Lauren Ganry, an oral and maxillofacial surgeon at Northwell Health, who has truly traveled the globe. He did his training in reconstructive microsurgery, training in Japan, and served as an attending at Henry Mondor Academic Hospital and Gustave Roussy Cancer Center in France. And now he is in North America, so he's really transgressed the entire globe at in all segments, and I'm sure he can speak to the global perspective. And then we will have Dr. Vivek Ghosh, clinical oncologist in radiation medicine and clinical fellow in advanced radiation oncology at the University of Manitoba. He brings extensive international experience and expertise in advanced radiation techniques, with a strong emphasis on precision and individualized treatment planning. And the last session is Dr. Alexander Barbaro, who is a medical oncologist, my colleague here, assistant professor at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He specializes in medical oncology with a focus on thoracic and head and neck malignancies. He is committed to patient-physician relationships, education, and mentorship. Together, I believe this panel will represent the breadth of contemporary North American head and neck cancer care. With that, I would open the podium to Dr. Rosenberg. Thank you. Actually, I stand corrected. I think it's my session next, and then Dr. Rosenberg. So I will be talking about giving you an overview of management of head and neck mucosal squamous cell carcinomas, looking at the current portfolio and a little glimpse into the future. So thank you.
Okay, now.
Hello, everyone. Welcome to OncoDaily Virtual Summit on Head and Neck Cancers 2026. This is our How I Treat series, and my topic is systemic treatment of head and neck mucosal squamous cell carcinoma. I want to give you a pragmatic and an optimistic view of the current and possibly future portfolio. These are my disclosures. None of this has any influence on what I'm going to present. I also want to tell you that I will be talking about yet to be approved products as well as some products in pipeline in clinical trials. So let me start off with the early stage head and neck squamous cell carcinoma. Well, we are all used to surgery being the primary modality in very early stages, especially in the anterior head and neck areas. But now we have a slew of studies looking at perioperative and postoperative immunotherapy. So let's start with the NEVO post-op study, the GORTEC 2018-01. Well, we all know that immunotherapy has made a huge splash in different types of cancers in early stage. And if it works there, of course it has to work here, right? So that was the premise for the study. This was a phase 3 randomized trial of adjuvant nivolumab added to radiochemotherapy in patients with resected head and neck squamous cell carcinoma at high risk for relapse. This was presented during the plenary session during 2025 ASCO. So what was the study design? The study randomized patients to receiving nivolumab along with chemo radiotherapy followed by more immunotherapy, 6 doses afterwards, versus the standard of care cisplatin 100 milligrams per meter square every 3 weeks along with IMRT to 66 gray. Patients who were included in this study included individuals less than 75 years of age, good performance status 0-1, squamous cell carcinoma of the oral cavity, oropharynx, larynx, or hypopharynx, who had undergone complete macroscopic surgical resection, had a stage of 3 or 4, early stages of 4, and high risk pathological features for relapse. The primary endpoint was disease-free survival assessed by investigators, and the sample size was calculated for disease-free survival events to detect a hazard ratio of 0.05. The secondary endpoints included overall survival as well as safety. Baseline characteristics, as you can see, are very well matched between the two arms. The combination of immunotherapy to chemo radiotherapy had a very similar patient population with regards to demographics, tobacco use, as well as P16 status and PD-L1 status, amongst others. Treatment exposure, this is important slide to kind of note. Majority of the patients in both the arms received a cumulative dose of 200 milligram per meter square of cisplatin or higher. More than 50%, almost 60, 62, 68% of patients received 3 cycles of intended cisplatin. And majority of the patients were able to complete radiation within the 55-day duration and up to 66 gray. And patients were also able to receive 3/4 of the patients were able to receive 4 cycles along with chemo radiation and subsequent immunotherapy in the adjuvant space. So the study met its endpoint. The median follow-up at the time of this reporting was 30.3 months. The 3-year disease-free survival was 63.1 with the combination arm, the Nivo plus CRT versus 52.5 with CRT alone. And when you look at the bottom left, all the outcome measures, including local regional control, local regional plus distant control, and mortality were much better in the Nivo plus chemo radiotherapy arm. The p-value for the EFS, the DFS, was 0.034 and the hazard ratio was 0.76. So the study completely met its primary endpoint. So what about the subgroups? When you look at the forest plot here, almost all subgroups of patients benefited from combination of immunotherapy with chemo and radiation. And looking at the survival, it's immature as of now, but you can clearly see the trend here. At 36 months, 74.2% of the patients were alive compared to 67.8%. The curves remain separated at the time of reporting. The data was immature, and so we will probably hear about this in upcoming meetings. The treatment-related events, as you can see, fairly even, actually looks very similar to the control arm, but of course you can expect some immune-related side effects that are unique to checkpoint inhibitors, so pretty well tolerated. So, but wait, the NEVO post-op, had positive results, secured a plenary presentation, but we do not have approval as yet, and NCCN has still not updated this. We need mature data for overall survival, and now with a complex scenario, I think we want to limit, or rather finesse our recommendations. So I'm waiting for that, and which means that I'm using this in my clinic, but insurance approvals sometimes get very tricky in this space. So that brings us to the concept of neoadjuvant therapy. So we all know that perioperative therapy, perioperative immunotherapy is standard of care in many different types of cancers, lung cancer being a poster child for that. We also know that neoadjuvant therapy is not a new concept in head and neck cancer. So we had the TPF and other regimens prior to chemoradiation and prior to surgery in the past. So this idea is really not novel. We're just building upon the older studies with the newer new strategies. So what is the rationale here for neoadjuvant immunotherapy? So with the tumor intact, as you can see here in the figure, the immune cells are better educated about the tumor makeup. So the surface antigens are present. They're able to trigger the immune responses, which thereby can help clear not only the cancer cells in the primary site, but also theoretically work at distant areas, including the lymph node, the draining lymph nodes, as well as possible micrometastases in distant tissues. So that brings us to the Keynote 689 schema. This is perioperative pembrolizumab for head and neck squamous cell carcinoma. There were dual primary endpoints with the study. Major pathologic response, which was 10% or less of tumor cells within the resected primary tumor and regional lymph nodes, and then event-free survival. So what was the study? So this is again in resectable, non-metastatic squamous cell carcinoma of head and neck. 600 patients were randomized to receiving pembrolizumab every 3 weeks for just 2 cycles, or they go directly to surgery. Surgery, again, based on the surgical findings, patients in the pembrolizumab arm with high risk received pembrolizumab plus radiotherapy and cisplatin, and those with low risk, again, depending on the known indications for adjuvant chemoradiotherapy, those patients received chemoradiotherapy along with pembrolizumab, and those with low risk received pembrolizumab plus radiotherapy alone. And those that did not receive pembrolizumab in the neoadjuvant treatment, or those that were randomized to no neoadjuvant treatment, received treatment based on their risk status at the time of surgery. So event-free survival. So there are 3 figures here. On the left-hand side are specified based on PDL1. So PDL1 high, composite proportionate score of 10% or higher, and then PDL1 intermediate, anything about 1%, CPS 1% or higher. As you can see on the left-hand side, you have in the high population, you have 39% of the patients having an event-free survival at 36 months, 39% additional patients having EFS at 36 months. So this is significant with a hazard ratio of 0.66 and a p-value of 0.04. And even in the intermediate population, you still see a significant improvement by adding pembrolizumab perioperatively with a 13.3% benefit. Again, even in all comers, regardless of the PD-L1 status, there is still an improvement and it's still in the significant range. So this is definitely something that I currently use in my clinical practice. Our head and neck community here within our institution is very pro perioperative approaches. The surgeons refer patients before surgery for them to be evaluated for perioperative therapies. So definitely seeing a lot of movement in this area. So switching gears now to talk about local regionally advanced head and neck squamous cell carcinoma that is not resectable. Just want to point out to a couple of studies here. This was again presented last year at ASCO 2025. This was the long-term results of randomized phase 3 Keynote 412 trial of pembrolizumab or placebo plus concurrent chemoradiotherapy for unresected locally advanced head and neck squamous cell carcinoma. So this is not a new study. We've heard about it in the past in prior meetings, but that was the short-term findings, and now this update was to present the longer follow-up. So what was the study? This was high-risk, unresected, locally advanced head and neck squamous cell carcinoma, and again, based on the stage, depending on the P16 status, and the subsites were stratified, and then patients were randomized 1:1 to receiving pembrolizumab plus chemoradiation or placebo plus chemoradiation. In the pembrolizumab arm, patients did continue maintenance pembrolizumab for 14 doses after conclusion of chemoradiation. In the placebo arm, they did receive placebo for those 14 doses. Patients were followed for progression and survival. So just in the little box below, I have noted what we previously knew about this study. At the time of 47.7 months of follow-up, the event-free survival median event-free survival was not statistically significant with the hazard ratio of 0.83, but the upper bound confidence interval was outside of 1. So it was not significant. There was no significant improvement. But now at 74.4 months when they presented last year, so let's see what the results show. So the primary endpoint event-free survival was significantly improved at this time point with a hazard ratio of 0.79 at 16 months, 54.7% compared to 47.2% had event-free survival. There was improvement in all outcomes, including distant progression of disease, local regional progression, as well as local regional and distant progression. It seems that the EFS, which was their primary endpoint, improves with time. So time may be of essence for these tumors, which really have a very lengthy survival period. So I just want you to focus for a second on the bottom right, on the very lower corner. Why are we talking about, we talk about curative intent when we do chemotherapy with radiation, but honestly, we only achieve that in about 50% of the patients with what we currently do, 50 to 60% of the patients, as you can see here from Dr. Edelstein's study from 2003. So that's why it is important to try and see if we can do any better with these potentially curable tumors. So there are several clinical trials. I just wanted to point out to one for no good reason other than the fact that we did have this study open at some point. So this is a global study of volrustomig for participants with unresected locally advanced head and neck squamous cell carcinoma following definitive concurrent chemoradiation. Here it was not concurrent, it was following, it was just sequential. So the study is still ongoing. Volrustomig is a PD-L1 CTLA-4 bispecific molecule, and just helps to widen the therapeutic index potentially. So what I wanted to highlight here is not particularly this particular study, but the fact that, because we really have such suboptimal results with what we currently have, we should think about clinical trials for every patient. So moving on, I just want to move on to metastatic recurrent head and neck squamous cell carcinoma. Do we have a bright future here in this disease? So let's see. So just jumping right into current status, right? So we have incorporated immunotherapy into our treatment paradigms in first line, subsequent lines. So the few studies that come to mind are pembrolizumab compared to cetuximab plus platinum 5-FU, followed by cetuximab maintenance, or the pembrolizumab. The larger study that looked at platinum 5-FU, cetuximab followed by cetuximab, or the pembro plus chemo compared to cetuximab plus chemo. All of these studies we are familiar with. I just wanted to point out the difference in median overall survival is really, to the tune of a month and a half, at most, when you combine chemotherapy plus pembro to chemotherapy to cetuximab, you have about a 3-month benefit. So not a big difference, but meaningful, right? So the 2-year overall survival in all the studies that I mentioned here have been substantial. So even if it is 27% of overall survival, these could be, the responses could be potentially durable. So for those that somehow missed the immunotherapy in first line, of course, nivolumab was one of the first studies that looked at nivolumab compared to investigator choice second line chemotherapy or cetuximab, and there was a significant difference in both over 2-year overall survival and median overall survival. So immunotherapy is here, and we are using it in everyday practice. So what is new, right? There are several new kits on the block, right? So not just in multiple different tumors. So that can be broadly classified as antibody drug conjugates. So even in head and neck cancer, we'll talk about that in a quick second, but there are many targets within head and neck cancers that can be potentially harnessed to deliver targeted chemotherapy. So EGFR is one of them. There is the B7H3, HER3 is another one. So there are many potential targets that can be utilized to develop ADCs. Nasopharyngeal cancer I'm not going to touch upon today, but again, there are several targets there as well. Bispecific therapies, that's seen a lot of promise in several diseases. We do have EGFR as one of the anchors, but then there are many other molecules like CMET or, as I list here, the PD-1 and several other molecules that can be dually blocked with these bispecific molecules. So let's take a deeper dive into them. Okay, just as an example, when you talk about combinatorial treatments, this is a study that is looking at phase 2 study. This was a phase 2 study, but now there is a larger study ongoing right now looking at cetuximab with ficlatuzumab. Ficlatuzumab is an inhibitor of human growth factor hepatocyte growth factor, which corresponds to the receptor CMET. So it blocks the attachment or blocks the engagement of AGF with the CMET. So that's another. So two agents given synchronously to tackle this tumor. It's not a single molecule, but 2 separate drugs given concurrently. So those are studies that are also looking promising. As you can see here in HPV positive, the median progression-free survival was 2.3 months, and HPV negative, it was 4.1 months, with a p-value of 0.02. compared between the two. So the HPV negative group cohort is moving forward with the subsequent phase 3 study. Amivantamab is a dual targeting EGFR and MET bispecific antibody. We are very well aware of this agent in non-small cell lung cancer. With EGFR and MET inhibition, this has dual blockade, but also the FC domain engages immune cells. So the immune cell directing activity of the FC domain brings in another domain into the picture. So it's almost like a trifecta effect on the cancer cells. So the origami study design, this is amivantamab in recurrent metastatic head and neck squamous cell carcinoma. It's a phase 1b/2 study. They recently reported out the first cohort in HPV unrelated after platinum and PD-L1 inhibition, but there are several other cohorts in HPV unrelated, HPV related, treatment naive, as well as treatment experienced cohorts. So in this particular study, in pre-treated population, the overall response rate was 45%, which is quite impressive, including a partial response of 16% and a clinical benefit rate, including stable disease, of 76%. As you can see on the right-hand side, the waterfall plot, pretty much everyone did have some shrinkage in their tumor, and the spider plot below shows that the responses can be durable. So moving on to the antibody drug conjugates. So the main premise is the antibody binds to the cell surface, it gets internalized, and the chemotherapy payload gets released within the cell, and there could be a bystander effect to the cells surrounding that do not have the marker on the surface that would take in the ADC. So this is again making splash in multiple different tumor types. There are several tumor target antigens to be explored in head and neck cancers, as I've listed on the left-hand side. TROP2, EGFR, HER2, HER3, c-MET are the ones that are leading the pack, but there are several of them. And I think the future will be, will involve some of these agents for sure. Dual immune targeting is another concept that is extremely enticing. PD-1 and CTLA-4, we've heard about it. PD-L1 and CTLA-4, we've heard about it. But then there are so many other checkpoint molecules that can be dually blocked, that can be concomitantly blocked, either through separate drugs or through a bispecific mechanism. We'll talk about that, in the next slide, perhaps. Then within head and neck cancer, especially within the HPV cohorts, we do have the cancer vaccines as well, targeting the E7 and E6 molecules. And then within the NPC, we have EBV-driven vaccine therapies as well, and oncolytic viruses in combination with checkpoint inhibition. So a lot of immune modulating combinatorial treatments in the horizon. Nivolumab plus ipilimumab was looked at in head and neck squamous cell carcinoma. As you can see, there were 947 patients that were randomized in this phase 3 study. Nivo-AP was compared to platinum 5-FU cetuximab, which was the standard of care at that time. There was no improvement in overall survival with the IO combination, but it seemed to be somewhat better in PD-L1 20%, CPS 20% or higher subgroup, with a median duration of response of 33 months. So the bottom right graph depicts the duration of response. So it's the tail that really matters, I think. We do know that immunotherapeutic agents portend to provide durable responses. But this does not answer the question as to whether dual immunotherapy is better than monotherapy and where exactly you would be using ipi/nivo. So I do not use any of these agents outside of a clinical trial in my current practice. So combining PD-1 or checkpoint inhibitors with other targets like EGFR, for example, or VEGF receptor, for example. In this case here, we do know that cetuximab, in addition to target-specific activity, it also has induces antibody-dependent cytotoxicity and engages the immune cells. And then add in the checkpoint inhibitor, you have a synergistic effect as noted in this figure here. So that's a very useful strategy, and I do tend to use that in second and subsequent lines when patients progress on first-line therapies. So this was a study, there have been several studies looking at different PD-1, PD-L1 inhibitors along with EGFR-directed therapies. The first one here on the left-hand side is pembrolizumab plus cetuximab, single-arm study, about 33 patients, but you do see the waterfall plot showing showing deep responses, and majority of the patients did have some response. The same thing with the middle here, where they combined nivolumab along with cetuximab, and you can see similar picture here. Median overall survival of 20 months in this case. And on the right-hand side, you see durvalumab plus cetuximab, kind of telling you the same story as well. So combining EGFR-directed therapies with checkpoint inhibition seems to be a reasonable option that can be adopted in current clinical practice. There are several unmet needs. Nothing seems to really work that well in head and neck squamous cell carcinoma. Hopefully, there will be, there will be a change in this story with the novel agents. But compared to other tumor types, you really even the immunotherapeutic responses are somewhat lukewarm compared to other tumor types. Morbidity is still an issue. We don't seem to be able to get rid of cisplatin. We still have the nephrotoxicity, the neuropathy, hearing deficits, and with radiation, there's long-term side effects as well. So we have not been able to eliminate any of that. We've been adding to it. So that, in my opinion, is also an unmet need. Can we do better than what we currently have rather than just adding to it? Sequencing and maintaining a good performance status is another issue with these patients. They may not have received a particular agent, but they may not be able to receive it because of declining performance status, because of underlying disease, the location of disease, as well as treatment side effects. And lastly, we do not have good biomarkers. We really don't, we talk about the established ones currently are PD-L1, CPS, HPV status, TMB, MSI high status, which very rarely you see in head and neck cancers. But the problem is that none of these markers are really very good or very predictive. So there are some potential signatures, if you will, that are being looked at that include tumor-related factors as well as tumor microenvironment as well as host factors as detailed here. This is just an example. You could look at PD-L1 expression, tumor mutational burden, IF interferon gamma gene signature, as well as take into account the tumor microenvironment, which seems to be a big factor in why none of the treatments work in head and neck cancers, and then also the host factors, including the microbiome. So emerging treatments, including the TILs and emerging biomarkers, including TILs, as well as blood-based biomarkers that look at immune gene signatures, AI prediction tools are all in the horizon, and hopefully with all of this, we'll be able to predict who's going to respond to what treatment and tailor treatments accordingly. So there's a long way to go, but this was just a very rapid run-in of what we currently have and what might be in the horizon. So thank you very much for your attention. I am happy to answer any of your questions, either via email or any other formats.
you so much. And his topic about non-systemic weapons, ADCs, bispecifics, fusions, proteins, and TKIs in advanced head and neck cancer. Dr. Rosenberg, did you hear me?
Yes, hi. Does it look okay? Can you hear me?
Yeah. So,
okay,
yeah.
perfect. And the presentation's in the looks good on the screen? Hello? Okay, I'll take that as a yes. Well, someone will interrupt me if there's any issue. Sounds good. Well, thank you for the invitation. And my name's Ari Rosenberg. I'm an associate professor at the University of Chicago. I'm a medical oncologist. I treat head and neck cancer. And I was tasked with the job of discussing novel systemic weapons, ADCs, bispecific fusion proteins, and TKIs in advanced head and neck cancer. This will hopefully build on some of the themes that you heard about in the last talk as well. Here are my disclosures. So here are some of the main items that I'll be touching on, including the bispecifics, ADCs, and then a little bit on multi-targeted kinase inhibitors in head and neck cancer as well. So we'll start with a case. This is actually a patient of mine. This was a 49-year-old lady with recurrent head and neck cancer. She actually initially underwent a surgery for an advanced oral cavity cancer, floor of mouth cancer, that was staged as a T4N3B with 6 out of 32 positive lymph nodes with extranodal extension present. So pretty much all poor pathologic risk features for this very unfortunate lady with no smoking history or risk factors for oral cavity cancer. And underwent adjuvant chemoradiation with high-dose cisplatin. And unfortunately, 3 months later already developed new neck adenopathy on the left side. And despite 3 cycles of carboplatin, 5-FU, and pembrolizumab, developed progressive disease. And that's when she came to me in our University of Chicago clinic. We actually enrolled her on a clinical trial with amivantamab, which you heard a little bit about in the last talk, and I'll be delving into in more detail as well, which is an EGFR c-MET bispecific. It's approved in lung cancer, and it's in trials in head and neck cancer. And you can really appreciate after 3 cycles of amivantamab, really an impressive clinical on the bottom, as well as radiographic response on the top. This patient experienced improvement in her pain and in her morbidity. And so just to highlight again some of the future directions of where we're thinking about some of these novel therapeutic mechanisms in the context of head and neck cancer. So you've heard about this a number of times. I won't delve too much into it, but just to say that we think about our head and neck cancer patients in 2 biological subsets, our HPV positive head and neck cancer, in which most of the focus is on de-escalation, although these patients do develop recurrence about 15 to 25% of the time. And HPV negative patients, where, like you heard in the last talk, we only cure about half these patients still, with many of these patients developing recurrence, and where there's remains an unmet need across therapeutic settings for better systemic therapeutics. In head and neck cancer, we're thinking not only about cure and survival, but also thinking about quality of life and function, and really how do we leverage our various therapeutic modalities to optimize these outcomes. Now, in the recurrent metastatic setting, again, this is in patients that are not amenable to salvage surgery. Survival remains quite poor, even in the immunotherapeutic era. So median survival only about a year. Our options remain limited, as you heard about, pembrolizumab alone or with chemotherapy. Both of these are suboptimal, but with some enrichment based on PD-L1 expression. And then post-immunotherapy, we really have cetuximab, chemotherapy, but really limited options with no good or effective therapeutic options in this setting. So we'll start talking about bispecifics. So these are uniquely leveraged as having 2 arms that can simultaneously target 2 individual targets of interest as well. And this has potentially advantages across 2 separate targeted therapeutics in combination, such as co-localizing anti-tumor effects, driving anti-tumor immunity through multiple mechanisms. We'll see some of that in across some of the examples that I'll highlight here. So we'll start with one of the drugs that are pretty advanced in development in head and neck cancer. This is a drug that's called petosemtamab. So this is a bispecific antibody that targets EGFR, right, a validated head and neck cancer biomarker that's overexpressed in over 90% of head and neck tumors, along with LGR5, which is actually a stem cell marker, which is overexpressed. And there's a number of different mechanisms by which this drug has activity, anti-tumor activity in head and neck cancer. It binds EGFR, similar to cetuximab, but then also through LGR5 ligase results in internalization of the complex and subsequent EGFR degradation. There's also engagement of the immune system. So through an ADCC-enhanced antibody mechanism, there's a mechanism of anti-tumor immunity as well. And you can see here in some of the preclinical data how the EGFR degradation seems to be further enhanced over cetuximab alone. We initially saw data as monotherapy in recurrent metastatic head and neck cancer that had progressed on prior PD-1 and chemotherapy. Again, response rate 36-37%. That's across multiple different evaluations. And then in combination with pembrolizumab in frontline, response rate 67%. So again, much higher than we would expect from pembrolizumab alone. And again, most of this activity enriched for the HPV negative head and neck cancer population. And this is now in 2 phase 3 trials. So this is a frontline phase 3 trial for PD-L1 positive patients with randomization to pembrolizumab alone or pembrolizumab with petosemtamab with a survival endpoint. And then this is the other phase 3 trial, which is in the immunotherapy and platinum refractory setting, randomization to petosemtamab monotherapy versus investigators' choice chemotherapy, again, with a response and survival endpoints. And so we eagerly await the results of these registrational phase 3 studies, both in frontline as well as in second, third line for head and neck cancer. What are some of the other bifunctional proteins that we have? So this has been another asset. TGF-beta we know is very important for the tumor microenvironment in terms of an immune suppressive effect. There's been lots of interest in TGF-beta trap-based inhibitory mechanisms. This is a bifunctional that inhibits both EGFR and TGF-beta, so it localizes the TGF-beta inhibition to the tumor microenvironment, as well as an ADCC and increased NK cell activation. And again, in combination with pembrolizumab, this is updated data that we saw earlier this year at the Multidisciplinary Head and Neck Cancer Symposium that Dan Zandberg presented. Again, response rate in HPV negative 48%. This is actually with the Q2 weekly dosing. The prior studies were with weekly dosing. And this is also in a registrational phase 3 study. You can see here with a randomization to Pembro placebo as a control versus Pembro plus Ficera. And now the dose decision has been selected. So this will move forward with the Ficera 1500 milligram with pembrolizumab with a primary response and survival endpoints. We heard about this in the last talk. So amivantamab, EGFR c-MET bispecific. Again, multiple different reasons why we think targeting MET is advantageous. We know that MET is overexpressed along with EGFR in the vast majority of head and neck cancer tumors, and also that amivantamab is uniquely situated to not only inhibit EGFR, but also inhibit MET, which is an important escape pathway to anti-EGFR, as well as immune cell directing activity through the unique FC receptor component of the bispecific construct. Again, we saw in ESMO this past fall data that Kevin Harrington presented of amivantamab monotherapy in HPV negative head and neck cancer progressed on prior PD-1 and platinum-based chemotherapy. Again, response rate 45%. You can see here a very impressive waterfall illustrating this. And again, very promising early efficacy signal. I think we'll get another update very soon as well. We've also seen data. This is a multi-cohort study. So we've seen now the amivantamab plus pembrolizumab combination data in HPV negative that Ronnie Mera presented at the Multidisciplinary Head and Neck meeting earlier this year as well, with response rate 56%. And there's also a perioperative or neoadjuvant cohort that's enrolling as well with amivantamab pembrolizumab, and that's cohort 6. And us and others are enrolling to that as well. We look forward to those results as well, again, building on the 689 data that you heard about in the last talk. And this is also in a registrational trial in frontline recurrent metastatic. This is a little bit of a different design than the other studies. So here, the control arm is pembro chemo rather than pembro monotherapy. The experimental arm is amivantamab with pembrolizumab carboplatin. Again, a registrational phase 3 trial in frontline HPV negative head and neck cancer, regardless of PD-L1 expression as well. What are some of the other bispecifics? So you heard very elegantly about volrustomig in the last talk as well, which is a PD-1 CTLA-4 bispecific. Again, there's been a number of signals that PD-1 CTLA-4 is an advantageous combination, and it seems that when this is a bispecific construct, this may have additional advantages. This is data from lung squamous disease with a response rate of 65%. And again, you heard about the left trial here, which is the registrational maintenance trial. So chemoradiation, patients are randomized to volrustomig versus observation. We've, at our site at University of Chicago, been very interested in neoadjuvant PD-1 CTLA-4 bispecific. There's a number of preclinical and clinical data sets to support this paradigm when the tumor lymph nodes in the neck and the tumor-drained lymph nodes are still intact. And so we're actually giving 4 cycles of neoadjuvant volrustomig chemotherapy, and we're treating both surgical and non-surgical patients, and we're giving adapted chemoradiation, so radiation doses and volumes based on either radiographic or pathologic response, along with maintenance volrustomig. So we look forward to this data. We're looking at a number of translational endpoints, including ctDNA, as well as tumor-based biomarkers as well. So looking forward to the neoadjuvant volrustomig as well. All right, now transitioning to antibody-drug conjugates. Again, you've heard about this in the last talk. This has been showed efficacy in a number of different tumor types. There's many variables in the ADC construct, from the antibody component to the linker component to the cytotoxic payload component. Most of the promising ADCs have MMAE, which is a microtubule inhibiting payload in head and neck cancer across a number of different targets. One of the targets that we've been very interested in is Nectin-4. Nectin-4 is overexpressed in head and neck cancer, similar to urothelial carcinoma, where enfortumab vedotin has multiple approved indications. And so initially this was tested as monotherapy in IO and platinum refractory head and neck cancer, again, as a single arm head and neck cancer cohort. We published this earlier this year, demonstrating a response rate of 24%. Again, anticipated toxicities with a microtubule and MMAE Nectin-4 targeted ADC, with peripheral neuropathy being the most notable, but some patients having skin toxicity as well. So this is now included in the NCCN guidelines as monotherapy after IO and platinum refractory disease. We then tested this in the frontline setting in combination with pembrolizumab or PD-L1 overexpressing with the primary response endpoint. Again, here we saw a response rate of 39%. So again, quite promising activity over pembrolizumab alone. Interestingly, this was highly enriched in HPV positives. The HPV positive response rate actually was 81.8%. So this does seem to be enriched for HPV positive. And again, we look forward to for this to be formally published, but this data was presented at ESMO by Paul Sosecki last year. What are some of the other ADCs that are in development? So CRB-701 is a next generation Nectin-4 ADC, which includes a site-specific cleavable transglutaminase conjugation technology, as you can see here, that aims to reduce free MMAE, which drives much of the toxicity, dose-limiting toxicity for many of these assets. This is being tested in a number of different trials, including head and neck cancer. We saw data that was presented by Dr. Perez at ESMO, where we saw a response rate of 33% at the lower dose level, but up to 47.6% at the higher dose level. And again, the main toxicity we modulate here is keratitis. So we have to keep a close eye on the eye outcomes, although with current prophylaxis, this has been greatly reduced, particularly the grade 3, when this can be managed appropriately. And again, very promising activity, and we look forward to more data in the head and neck cancer population for this drug as well. And there's been many other ADCs that are in development. A big common theme I think we're seeing with ADCs is that in head and neck cancer, which is a frail population for which toxicities can be quite important, really dose optimization, schedule optimization, dose reduction optimization is critically important. And so we'll have to keep an eye on this as these other targets and other ADCs across payloads sort of pan out. Now I'm transitioning to the last part of the talk. I'll plan to discuss multi-targeted kinase inhibitors in head and neck cancer. We know that this is an important mechanism for the tumor microenvironment that drives immune modulation through a number of different mechanisms. So these can actually prevent accumulation of immunosuppressive MDSCs, as well as inhibitory and regulatory T cell proliferation, limits tendencies towards the M2 immunosuppressive phenotype, and also can enhance APC-mediated maturation function and antigen presentation. We have multiple proof of concepts across many other immunogenic tumors with TKI-IO approvals, including hepatocellular carcinoma, renal cell carcinoma, endometrial cancer, among others, hence the enthusiasm for testing this in the head and neck cancer population. There's been a number of early trials that have suggested a signal. This, I think, is a very important phase 3 trial that was presented by Lisa Lecitra and then eventually published, where this was a randomized phase 3 registrational trial of pembrolizumab with or without lenvatinib. What was interesting in this trial is that the response rate in this randomized phase 3 was significantly higher, 46.1% versus 25.4% in the control arm, and duration of response quite good across both arms, as you can see here. PFS also significantly improved with lenvatinib pembro versus placebo pembro, as you can see here, with 12-month PFS rates of 28.5 versus 19.2%. That was sustained at PFS2 as well. And yet, despite that, we did not see a survival advantage. And so we can discuss why that might be. The discontinuation rate and the patients going on to subsequent therapy were substantially different between the two arms, in addition to the fact that pembro placebo actually had a very impressive control survival rate, much better than we'd seen in KEYNOTE-048 and under the prior registrational trials with a median survival, 12-month survival, as you can see there, 59%. So again, overperforming control arm and patients not able to go on subsequent therapy, having to discontinue for toxicity, all potential contributors to the lack of survival benefit. But I think the fact that there was a significantly better response, PFS, is proof of concept for this combination IO-TKI in head and neck cancer. What about other TKIs? We've seen this data from Nabil Saba and Christine Chung of cabozantinib with pembrolizumab with, again, response rate 52%, and that's in PD-L1 positive patients, again, quite promising. We've also seen data for TKIs with EGFRs that look quite promising as well. And so this is, we look forward to the randomized phase 2 presented results from Stellar 305 that we haven't seen yet. This is a randomized trial of pembrolizumab with or without zanzalintinib. Zanzalintinib is a next generation TKI that overlaps at its targets with cabozantinib, but has a shorter half-life and maybe better tolerated. So we look forward to those results. And then we're also testing this in an investigator-initiated trial, actually, at University of Chicago with a triplet combination. So pembrolizumab with cetuximab, EGFR inhibitor, with zanzalintinib in recurrent metastatic head and neck cancer, both in frontline and in second, third line, as we look forward to these results as well. Feel free to send any eligible patients who might be interested in this trial to us at any of our institutional or network sites in the Chicago area. So I think the key takeaways here: bispecific antibodies, fusion proteins, leverage uniquely dual target engagement and co-localization of anti-tumor effects with promising early efficacy signal alone and in combination. We've seen ADC against Nectin-4 in particular, but other targets as well appear promising. And multi-targeted kinase inhibitors that modulate the tumor microenvironment, particularly with immunotherapy, continues to be actively tested. And really, neoadjuvant immunotherapy combinations continue to be tested as well. And we look forward to this in the evolving landscape as well. So with that, thank you for your attention. And I look forward to the discussion and happy to answer any questions.
Dr. Rosenberg, thank you so much for this insightful presentation. And our audience have a question for you. So many ADCs rely on antigen expression like EGFR or HER2. Given tumor heterogeneity in head and neck cancer, how do you see antigen escape shaping the long-term efficacy of ADCs?
Yeah, that's a great question. And hopefully, as we see more of these patients being treated with some of these strategies, we'll be able to do progression biopsies and be able to characterize that a little bit better. I will say that in head and neck cancer, the expression level does not seem to correlate with anti-tumor activity, at least with Nectin-4 targeted ADCs. Again, it's overexpressed to some degree in the vast majority of head and neck tumors, which may explain why even low expressing Nectin-4 by IHC, by H-score at least, does not seem to predict response. And so we're not using that currently as a biomarker selective approach. Maybe HPV subtype may predict, right? So we saw enrichment for response in HPV positive in enfortumab vedotin. We'll have to see with the other Nectin-4 targeted ADCs whether that also pans out. We do know that Nectin-4 is overexpressed in HPV positive as compared to HPV negative, so that might be a biomarker that will pan out. But antigen escape is a great question, whether that's the mechanism of resistance or whether it's some other adaptive evading of the ADC construct. I think we have to better characterize that.
Thank you. Thank you so much once again. So we are moving to our next speaker, Dr. Coral Olazagasti, Assistant Professor at the Sylvester Cancer Center, University of Miami, Florida. And her topic is about challenges of immune blockade in special population. Dr. Olazagasti, did you hear us?
Hi, yes. Can you hear me?
Yeah, hello.
Hi.
So floor is yours.
Can you see my screen?
Yeah, yeah.
Okay, let me put it in presentation. Oh, yikes. You're not seeing in presentation mode, are you? No. Okay. Sharing. Okay. Are you seeing in presentation mode now? I can hear. So I think that's a yes.
Yes, yes.
Okay. So hi, everyone. Thank you for having me. I'm excited to be here today talking about immune checkpoint blockade in the elderly and comorbid patients. I'm Coral Olazagasti. So these are my disclosures. And so what are some of the key objectives for today? We want to summarize pivotal trials of immune checkpoint inhibitors in head and neck squamous cell carcinoma, describe the biological and clinical barriers to immune checkpoint inhibitors, and discuss potential frameworks for immune checkpoint inhibitors decision-making in the elderly. And so why does it matter? Head and neck cancer is different than other types of cancer. We have been seeing an incidence in younger populations. For head and neck squamous cell carcinoma, the median age at diagnosis remains 65 years old. And so we have about 50% of more of the patients that are diagnosed at 65 or older. And so this brings concerns about the immunosenescence, right? Like, is the immune system and immune function declined in these older patients, and also patients that are of more advanced age, they carry more comorbidities, which add complexity to the treatments that we choose for our patients. Moreover, we know that for patients that are passing away from the disease, about 70% are in patients that are 65 years or greater. And so the disease carries a median age of death about 70 years old. And so what does the NCCN says about the older adults in oncology regarding immunotherapy, they specify that age should not be the primary consideration to determine the use of these therapies, that we really need a multi-D approach to evaluate the potential role of using immune checkpoint inhibitors. Because honestly, there hasn't been really evidence that older patients have less benefit of immunotherapy, and we'll go more in depth about this compared to the younger adults. But we do know that we need closer and more aggressive follow-ups to really be able to stay on top of potential toxicity profiles. So let's review some of the landmarks immunotherapy trials in recurrent metastatic head and neck squamous cell carcinoma. First, we have the Checkmate 141, and this was the first study that randomized nivolumab compared to physician's choice for second-line treatment for head and neck squamous cell carcinoma. And we can see here in the left that there was overall survival benefit with a median overall survival of 7.5 compared to 5.1. Not only that, but after 2 years, the survival benefits were maintained, and patients in the immunotherapy arm were found to have less adverse events than the patients in the standard therapy, because obviously at that time, the standard therapy was just chemotherapy. So when we look at the subgroup analysis, we can see here that the median age of both groups was about 60 years old. And we just talked a few minutes ago about how this is really not the reality that we see in our clinics. We said that the median age of diagnosis is 65. And so this is where it starts to kind of like not align necessarily with the real world that we see day to day. In the Nivo arm, median average age was 59 and 61 in the standard therapy. We see here in the subgroup analysis that patients that are older than 65 that were randomized to the Checkmate for 141. They did kind of like are going into the right, kind of like almost to the benefiting more from standard therapy. And similarly with performance status, we see here that they only basically most have performance status of 0 and 1, and those with greater than 1 are kind of like also almost like leaning into the right side. And so importantly that the study excluded significant autoimmune diseases and organ dysfunctions that are also something that we see in our day-to-day clinics. So what does the label says about nivolumab in the elderly patients? Opdivo label says that there's really no overall difference in the safety that has been reported between elderly and younger patients. We see from the real world for patients, particularly colorectal cancer that have MSI high, that combining Nivo and EP, the patients have higher incidences of grade 3 and 4 AEs when they're older than 65 compared to younger than 65. But overall, single agent anti-PD-1 seem to be well tolerated. It is those combination regimens that carry higher toxicity in these patient populations. What about the real world setting, right? Because I think it's very important to really translate what we find in the clinical trials to see if it's applicable to the real world scenario. And so a study of nivolumab in metastatic non-small cell lung cancer evaluated patients that were greater than 65 years old, and they had a median overall survival of 23 months, generally well tolerated. And most of the patients that experienced toxicity, it was basically a grade 1 toxicity. Nivolumab and chemo in gastric cancer has been compared in patients that are older than 75 or younger, and they have found to be similar immune-related AEs and really no difference overall in the survival benefits. So Nivo, again, seems to be really an effective therapy, tends to be overly safe or for patients with overall good performance status. Following up, we have the Keynote 048, which was the first study that evaluated the role of immunotherapy, in this case, Pembro, in the first line setting for recurrent metastatic head and neck squamous cell carcinoma. It was a phase 3 study, and they randomized 882 patients in a 1:1:1 comparison to either Pembro alone or Pembro chemo or the extreme regimen, which is cetuximab with chemotherapy. And we can see here in the left, for patients that have a CPS greater than 20, up in the top, we see the patients that were just treated with Pembro alone compared to the extreme regimen, and down the bottom with Pembro chemo compared to the extreme trial. And we see across both groups an overall survival benefit of about 15 months compared to 11 months for the standard of care at that time. Similarly, for the patients in the right that are with a CPS greater than or equal than 1, Pembro monotherapy had an overall survival benefit, as was Pembro chemo, of about 12-13 months compared to 10 months in the extreme trial. There was noticed to have more grade 3 AEs, mainly in the patients that were treated with pembro chemo, and also the extreme trial, which makes us think probably some of the most of the side effects that we see in these cohorts are guided from the chemotherapy itself rather than single agent pembro, because we notice lower rates of pembrolizumab monotherapy in the rates of grade 3 AEs. And so for the 5-year follow-up of the Keynote 048, the total population, they maintained the overall survival benefit, 14.4 with 6.5 in the pembro alone and 16 versus 5.2 in the pembro chemo. So really this established pembrolizumab with or without chemotherapy as the first-line standard of care for recurrent metastatic head and neck squamous cell carcinoma. When we look at the subgroup analysis, we can see that really all patients derive similar benefits, whether those are younger than 65 or even the patients that are older than 65, and the patients with ECOG of 0 and 1. So what are the real world challenges that we see on the study? Again, the trial only enrolled patients with an eco performance status of 0 and 1. This is not, again, what we see in our day-to-day clinics. We have elderly patients that have higher comorbidities that are underrepresented and still today are really not included in clinical trials. However, there have been some real world data. This study in particular evaluated 130 patients with a median age of about 73 years. And they found that there was no significant differences in overall survival or PFS in patients that were younger or older than 75 years old. In older adults, however, with low CPS score, we see that the benefits appears limited. And so this really highlights the importance of careful patient selection. And so elderly patients may not necessarily tolerate platinum-based chemotherapy, which makes pembro monotherapy very attractive, but important to use and understand the CPS status, how it becomes critical really for decision-making in these patients. So what about in the perioperative immunotherapy, in the perioperative setting in head and neck squamous cell carcinoma? We have the Keynote 689 study. And so this study was for patients with resectable locally advanced head and neck squamous cell carcinoma. Again, good performance status with an ECO of 0 and 1. And this makes sense, right? Because these are patients that are about to undergo surgery. They were randomized to neoadjuvant pembro, followed by surgery, followed by pembro and RT with or without cisplatin, or patients to go straight to surgery, followed by RT with or without cisplatin. We can see here an event-free survival benefit for patients treated in the neoadjuvant approach. And so with a median EFS of almost 52 compared to 30.4 months. After this study was presented, FDA approved neoadjuvant and adjuvant, so what we call kind of like the sandwich approach, pembrolizumab for resectable locally advanced head and neck squamous cell carcinoma. And this was important because this was really the first approval in the locally advanced setting in many, many years. And so in general, we were very excited about this potential innovation, and finally the use of immunotherapy in the neoadjuvant and adjuvant approach for head and neck squamous cell carcinoma, which we have been doing already for a long time in non-small cell lung cancer. So how about adjuvantly? How do immunotherapy has been presented for patients in non-small cell in head and neck squamous cell carcinoma? We have the Nivo post-op, which was presented as a plenary session at last year's ASCO. And so the study utilized adjuvant nivolumab. So patients basically had to be younger than 75. Again, ECOG of only 0 to 1. They have had to undergo surgery and had what we call the high-risk pathological features of relapse. Patients were randomized in a 1-to-1 setting to either Nivo for 1 dose, followed by radiation, cisplatin, and nivolumab, and then followed by 6 doses of Nivo every 4 weeks, or just a standard of care, which is cisplatin with radiation. Disease-free survival, we can see also here a benefit at 3 years. There was a disease-free survival benefit of 63 compared to 53% of the patients. And so this is a regimen that I tend to utilize in my clinic. But again, it's important to highlight patient selection, right? When we look at this chart here, this subgroup analysis, we see that in the older patients, it tends to kind of like almost go into almost favoring the chemoradiation. And here it's because you're adding some treatment, you're not replacing treatment, right? And so we do see an added side effects profile. And so I wouldn't say here that necessarily this is only due to age, but we know that older patients, again, higher comorbidities, which takes into consideration how these patients will tolerate treatment. When looking and discussing the treatment-related adverse events, here we see any grade, and definitely we see a higher incidences of any grade adverse events, severe, for patients in the nivo and chemoradiation compared to just chemoradiation, and similarly higher incidences of grade 3 and grade 4 side effects. So definitely something to keep into consideration when you're selecting the patients that you're going to offer this regimen, this nivo post-op after surgery. So, what are the challenges for immunotherapy in the elderly population? So, I would say that the first challenge is immunosenescence. We know that the immune changes with the age, right? There's like thymic involution, there's less naive T cell repertoire, and there's chronic low grade inflammation in older patients. However, there's a paradox because there has been some preclinical studies that suggest that the tumor of older hosts also have lower T cell infiltration. And so we think about how this potentially can enhance the efficacy of immune checkpoint inhibitors. And then the clinical reality is that most data do show that there's comparable efficacy across different subgroups. This was a study that was published in JAMA Oncology that highlights the PFS in geriatric patients treated with immune checkpoint inhibitors. And there was similar overall response rates for patients with non-small cell lung cancer, melanoma, and GU, really across different subgroups. So the second challenge is frailty and performance status, right? I think we have highlighted that at this point is whether a patient is fragile and not necessarily the age. That will be the key determinant of the outcomes for immune checkpoint inhibitors. The study evaluated frail patients, and even though there were not really significant differences in immune-related AEs between frail patients and non-frail patients, they were found to have higher hospitalization and overall mortality than non-frail patients. There was a study also evaluating the discontinuation due to immune checkpoint inhibitors from immune-related AEs in patients older than 90 years old. And they found that they were twice as frequent than in patients that were younger. So perhaps a combination, right, of different factors that can take into consideration how immune checkpoint inhibitors can become toxic or have side effects or even hospitalizations in this cohort of patients. Another of the challenges that we see frequently in our clinic is pre-existing autoimmune diseases. So there are patients with autoimmune diseases that are routinely excluded for immune checkpoint inhibitor trials. And so we don't know how this really translates into the real world setting. A meta-analysis studied 24,000 patients with pre-existing autoimmune diseases, and they found that they had greater incidence of immune-related AEs at 61%, compared to 35% in the general population, and higher incidences of flares from the autoimmune diseases. The flares typically tend to be milder in about 50% of the cases, and the incidences of mortality from immune-related AEs were still low at less than 1%. Study also found no really significant difference in overall response rate, overall survival, or PFS in patients with autoimmune diseases compared to those without. So what does the NCCN recommend? They say that anti-CTLA-4 has a higher risk for exacerbating baseline autoimmune diseases than anti-PD-1 or anti-PD-L1, that the goal is for a patient to be on prednisone less than 10 milligrams per day prior to starting immune checkpoint inhibitors. We know that patients with autoimmune neurologic conditions or really life-threatening, uncontrolled autoimmune diseases might not be the best candidate to start immune checkpoint inhibitors, and that patients with baseline immunosuppression at immune checkpoint inhibitor initiation, they do have a shorter PFS than those without baseline immunosuppression. So things to take into consideration for patients that we see in our day-to-day. Another challenge that we typically can see is organ transplant recipients. So graft failure has been reported with immune checkpoint inhibitor therapy, particularly transplant organ loss has been a real risk and consideration. Again, NCCN says that for patients that have a viable alternative, if the graft is rejected, for example, patients with kidney transplant that might go to dialysis may be candidates. But I would take this with a grain of salt. This is something that I don't really tend to mess with. And so, really, definitely requires careful discussion with the patient's risk versus benefit approach before initiated immune checkpoint inhibitors in a patient with a transplant. So what's a framework that we recommend in the decision making for these patient populations? We recommend geriatric assessment, right? Really taking into consideration the overall picture rather than just the age as a determinant factor for starting or withholding immune checkpoint inhibitors. Performance status, right? Most of the studies included performance status of only 0 to 1. So definitely to take into consideration how well the patients are doing. Biomarker driven selection, we can see here that a CPS score is important, and particularly patients with a positive CPS score, particularly greater than 20, they do better and they do well with pembro monotherapy. Comorbidity inventory, so whether that's a different polypharmacy, different other diseases that they have or other comorbidities or autoimmune diseases are important to take into consideration. Definitely making, particularly in patients with autoimmune disorders or in patients that are frail, and closer monitoring because maybe elderly patients that are frail, they won't be able to really comment or share toxicity profiles, something that really has to be closer monitoring in order for us to be able to identify those potential side effects from these drugs. And so the key takeaways is again that age alone should not preclude ICI therapy. The efficacy has been shown to be preserved across elderly patients. Checkmate 141 and Keynote 048 showed and established ICI as the standard of care in patients with head and neck squamous cell carcinoma, and the real world data supports this use in the elderly. Adjuvant immune checkpoint inhibitors, this requires careful discussion because we have seen higher toxicities observed in patients greater than 75. Neoadjuvant immune checkpoint inhibitors may offer a favorable safety profile rather than prolonged adjuvant therapy. Pre-existing autoimmune diseases, some are manageable, but definitely have to be closely monitored. And anti-PD-1 and PD-L1 are preferred over anti-CTLA-4. And fragility and PS and not chronological age should really be the drive in guiding treatment decisions. I'll take any questions that you may have, and thank you everyone for having me here today.
Thank you so much for this incredible presentation, Dr. Olazagasti. So we have some questions from our audience. And first question is, in your opinion and based on experience, do you really think age equal immunosenses or immune reprogramming through prior antigen exposure, resulting in maybe even better responses?
Yeah, so like we say, like sometimes like we worry about the immune system in the older elderly population, but I guess it's interesting that paradox that has been found that the hosts are also have lower regulatory T cell infiltration, and so I think it's definitely something worth approaching and worth giving the patient a try. In my patient population and in my clinic, patients tend to do really well. From experience, I haven't necessarily seen higher adverse events, even in patients that tend to be a little bit on the frail side. But again, we really do a good job trying to closely monitor these patients and the side effects and the potential toxicity, and also have family members involved in the day-to-day and the conversation to make sure that we're not missing anything. But yes, absolutely.
Thank you so much. And second question is chronological age still relevant, or should biology lead treatment choices?
I think definitely biology. I think biology and performance status. I think chronological age is just so subjective that maybe someone that is 65, two patients that are 65, even though they can have the same age, depending on the comorbidities and depending even on the performance status and social status, right? And even social determinants of health can really impact someone's ability to tolerate. So I would say definitely we see some patients that are 60 that look like 90, and we have some patients that are 70 that look like 50. So I definitely, it's not something that I prioritize when choosing a treatment option in my clinical practice.
Thank you. Thank you so much once again. So we are moving to our next speaker, Lauren Henry. I'm sorry. We take a short break, so stay tuned.
Biotech is moving fast. New breakthroughs, major clinical updates, company moves, regulatory decisions, and industry shifts are happening all the time. But keeping up with what actually matters can be difficult. That's where OncoDaily Biotech comes in. We bring you timely, relevant, and engaging biotech news in one place. From innovation in cancer care to broader developments across the biotech space, including research progress, funding news, partnerships, emerging technologies, and the stories shaping the future of medicine. Whether you're a healthcare professional, researcher, biotech leader, investor, or simply someone who wants to stay informed, OncoDaily Biotech helps you stay connected to the news that matters. Follow OncoDaily Biotech and join a growing community exploring the future of biotech one update at a time. We all read the data. We follow the trials. But real learning comes from discussion, from asking questions, from hearing different perspectives, from sharing experience. That's how Gioconda was created, the official journal club of OncoDaily, a global open space where oncology professionals come together to critically analyze evidence and translate it into real-world practice. From students to experts, across countries, across disciplines, connected by science. Welcome to Gioconda, where knowledge is questioned, shared, and made stronger together. Artificial intelligence is quietly reshaping oncology, not in theory, but in how we think, how we work, and how we decide. Across the world, researchers and clinicians are moving with it. Different places, the same moment. A pause, a realization, a decision, and then they move. On May 30 in Chicago, during the ASCO 2026 annual meeting, these paths come together. OncoDaily Grand Rounds, AI and Oncology Edition, organized by OncoDaily with ZS as exclusive partner. Become part of the AI oncology community. Register now. Biotech is moving fast. New breakthroughs, major clinical updates, company moves, regulatory decisions, and industry shifts are happening all the time. But keeping up with what actually matters can be difficult. That's where OncoDaily Biotech comes in. We bring you timely, relevant, and engaging biotech news in one place. From innovation in cancer care to broader developments across the biotech space, including research progress, funding news, partnerships, emerging technologies, and the stories shaping the future of medicine. Whether you're a healthcare professional, researcher, biotech leader, investor, or simply someone who wants to stay informed, OncoDaily Biotech helps you stay connected to the news that matters. Follow OncoDaily Biotech and join a growing community exploring the future of biotech one update at a time. We all read the data. We follow the trials. But real learning comes from discussion, from asking questions, from hearing different perspectives, from sharing experience. That's how Gioconda was created, the official journal club of OncoDaily, a global open space where oncology professionals come together to critically analyze evidence and translate it into real-world practice. From students to experts, across countries, across disciplines, connected by science. Welcome to Gioconda, where knowledge is questioned, shared, and made stronger together. Artificial intelligence is quietly reshaping oncology, not in theory, but in how we think, how we work, and how we decide. Across the world, researchers and clinicians are moving with it. Different places, the same moment. A pause, a realization, a decision, and then they move. On May 30 in Chicago, during the ASCO 2026 annual meeting, these paths come together. OncoDaily Grand Rounds, AI and Oncology Edition, organized by OncoDaily with ZS as exclusive partner. Become part of the AI oncology community. Register now. Biotech is moving fast. New breakthroughs, major clinical updates, company moves, regulatory decisions, and industry shifts are happening all the time. But keeping up with what actually matters can be difficult. That's where OncoDaily Biotech comes in. We bring you timely, relevant, and engaging biotech news in one place. From innovation in cancer care to broader developments across the biotech space, including research progress, funding news, partnerships, emerging technologies, and the stories shaping the future of medicine. Whether you're a healthcare professional, researcher, biotech leader, investor, or simply someone who wants to stay informed, OncoDaily Biotech helps you stay connected to the news that matters. Follow OncoDaily Biotech and join a growing community exploring the future of biotech one update at a time. We all read the data. We follow the trials. But real learning comes from discussion, from asking questions, from hearing different perspectives, from sharing experience. That's how Gioconda was created, the official journal club of OncoDaily, a global open space where oncology professionals come together to critically analyze evidence and translate it into real-world practice. From students to experts, across countries, across disciplines, connected by science. Welcome to Gioconda, where knowledge is questioned, shared, and made stronger together. Artificial intelligence is quietly reshaping oncology, not in theory, but in how we think, how we work, and how we decide. Across the world, researchers and clinicians are moving with it. Different places, the same moment. A pause, a realization, a decision, and then they move. On May 30 in Chicago, during the ASCO 2026 annual meeting, these paths come together. OncoDaily Grand Rounds, AI and Oncology Edition, organized by OncoDaily with ZS as exclusive partner. Become part of the AI oncology community. Register now.
Welcome back. Thank you for staying with us. So I would like to introduce our next speaker, Lauren Genry, head and neck and cranio-maxillofacialis surgeon at Northwell Health, Long Island Jewish Medical Center, associate fellow of the American Academy of Cranio-Maxillofacial Surgeons, New York. Dr. Genry, did you hear us?
Yes, can hear you.
Hello,
Thank you for having me.
Can you share with your...
Yeah, you want me to share my screen? Yeah, I can do that. I think it's already there. Oh yeah, let me put it into... Yeah, can you see it?
Yeah.
All right. All right, so thank you. Good afternoon. Thank you for the invitation. Today I would like to share how I basically approach advanced head and neck cancer, because this is where there is the most amount of discussion in the realm of surgery. Not only from oncologic perspective, but mostly today about reconstructive and functional standpoint, because this is where we have the most amount of discussion regarding morbidity, dignity, identity, quality of life, and so forth. So I think there was a tremendous amount of progress because when I started my training compared to nowadays, there is absolutely immense differences on the way we can repair, reconstruct people, patients. And I think it's important to use this kind of platform to share this kind of advancements to make everybody aware of what we can do to help. And so basically, let me go back this one. I don't know the slide. Here we go. So because obviously for this case, reconstruction was judged by only one metric. It was whether the defect can be closed or not. And I would argue that is obviously no longer enough. Obviously, today our goal of restoration is about restoration of what is kind of possible or remaining function, identity, and again, quality of life. And so the challenge here in advanced defect, like this one, for example, done by my partner, Dr. Andrew Salama, I work a lot with, that when you look at this and you wonder how I can fix that, there is many things to say. There is first the function, obviously, about speech, about swallowing, and about airway management, how I'm going to make all of this happen. There is form, about the physical structure of the face, bone. You see there is a large amount of bone removed. The mandible is nearly completely gone. The maxilla is open. There's a big problem there. And identity, how patients basically recognize themselves and are perceived by others after such a surgery and reconstruction. And ultimately, obviously, quality of life. So, and every treatment decision we make affects all four. So I would say the perspective matter a lot, because treatment decisions are not made in just with one person. They are shaped by also the training of each individual, each surgeon, radiation oncologist, medical oncologist, and the perception of the problem, because both person can see the same problem, like this number on the floor, and see a different solution. So especially when we discuss surgery versus non-surgical approach. So historically, surgery has been associated with quite a high morbidity in head and neck. And today I'm going to show you basically 4 different cases fast, because we have just 15 minutes to discuss all of them, of what are the last advancements. Obviously, we use what we call virtual surgical planning to prepare a surgery on a computer, and then use the 3D printing technology to have guides to help us to cut the bone, shape the soft tissue, and have a custom dedicated guiding of our surgery for the patient, peculiar anatomy and identity. But there is also other things such as a dental rehabilitation. I'm going to start by a case like that. Now we can give back full denture and dentition in all of our case, except case we see after radiation that were not anticipated. So everything matters if you anticipate before. And obviously, the specialized reconstructive training. Personally, I had a reconstructive training in form of fellowship in a triple specialty. I'm OMFS trained initially, but then I did an OMFS fellowship, head and neck training. And on top of that, I had a plastic surgery training with a fellowship in Asia. and I have an ENT training with a head and neck training in both Europe and United States. So this is really depending on each individual, how you are trained to see different ways to help people. And I think that matters a lot. So basically the four case we're going to discuss, basically, rather than thinking in terms of procedures, I approach this kind of defect through four principles. The first one is to restore, obviously, whenever possible, the function. The second one is to escalate with very technical, approach if there is a large complexity, and sometimes transforming an unsalvageable scenario into something possible. This is where the most discussion happen, obviously. Preserve identity and not only survival. This is very important too. And when needed, and I will show you a case that we are going to do very soon, you will see how to reinvent something when people has no solution, and maybe there is something to do still that is acceptable both in morbidity and balanced benefits risks. So first of all, I would like to show you a case of maximal reconstruction regarding teeth in the oral cavity. I'm OMFS, obviously I do a lot of oral cavity cancer that are usually the most aggressive type of head and neck cancer you can have. But the problem is on top of the bone and the jaw and the lining on the mouth or the tongue, the function, there's also the teeth. And you see, we did something quite unique here at Long Island. I'm not sure it was done before elsewhere. What we call the triple denture. The patient has 3 denture in one day. I'm going to show you the case. So this is a patient that came, you see, with this large defect, segmental defect into his bone, into his right mandible, and came a little bit disfigured by all of this, holding only by a reconstruction plate, a little bit, I would say, the way we were doing a long time ago, but this is sometimes you don't have any other solution, so you just make the jaw hold the mandible by titanium and until the titanium breaks, obviously. And then obviously you can see his poor oral scenario with his teeth, and basically came to us from another team, another hospital system, to ask if anything could be done. And yes, you can perfectly reconstruct his jaw using a piece of bone from the body, which is here in a light blue, a scapula bone, a bone from the back of the chest that match, as you can see, very well naturally the shape of the mandible. And then you can place these cylinders, which are basically dental implants, and then add the denture, you see, all of that to match basically a new scenario with the dental implant fixed into the bone, so this denture are fixed. I am absolutely not a dental practitioner, because OMFS in Europe, where I was trained initially, is a medical specialty. I never put a foot in dental school, but now, thanks to this virtual surgical planning, you can see that we can do that ourselves and advance basically the reconstruction of patient, which was absolutely not done 5 years ago or 10 years ago, not even. It's just we made tremendous progress, and these denture are 3D printed and immediately restorable. So basically, I'm going to go fast, and then technicality. We have guide in titanium, 3D printing also to the patient anatomy. You can clean basically everything that needs to be cleaned regarding bone and teeth, and place with guide these cylinders, these dental implants. And you see, you place on the maxilla, you place on the remaining mandible, and basically you place also that into the free flap, the piece of bone from the scapula. You see, all of that is guided too, and you're able to place 2 nice dental implants to this piece of bone, as you can see here, to hold another denture. So you see, typically a scapula is known to not being able to receive dental implants. Well, you can see that there is a way to make it happen. There is far more enough bone to receive this yellow cylinder, this basically dental implant that is a screw and nothing else, to allow the restoration. And I'm going fast on the surgery, but you can see the defect of the patient and the problem he had due to the lack of bone. Obviously, the teeth, you understand. My colleague, Dr. Salama, did the part of the mouth onto the native maxilla and mandible to place the dental implant and the denture. This is the flap where it's still attached to the axilla, still vascularized. You see, with all this 3D printing technology, you can access to this and basically place your implant, fix your denture. You see, there is teeth attached now to the bone, and transplant the flap already ready with the pedicle. You can see the artery and the vein that is on the right side of the screen, and basically transplant that into the head and neck area. This is my colleague that did the denture on the lower and upper aspect of the native jaws. And then I came with a scapula with a third denture, basically. And you see, with what we said, a sub-occlusion, you don't make the denture touch, like that. You cannot chew on this on the side of the free flap because the bone quality is different. And you have to wait before putting a certain load on it to allow the implants to heal. And this is him after when everything healed and he had a final denture that is in zirconium. It's basically strong for a lifetime. And you see he had now a nice double denture, everything is aligned, and a patient that basically had no chance of being reconstructed. And you can see doing not so bad after only one big surgery. It's not an easy surgery, obviously.